on critical airway management, recent trends. So see you whole day. It will be a nice treat for everybody. Thank you. We begin with the inauguration.
Good morning, everybody. On behalf of the Department of Anesthesiology, DY Patil Medical College and Hospital, I welcome you all. We will proceed with the inauguration function. I request our organizing secretary, Dr. Sandeep Kadam, to kindly step on stage and take over the proceedings.
Good morning, everybody. On behalf of Department of Anesthesiology, DY Patil Medical College, Hospital and Research Institute, Kolhapur, I extend you all a warm welcome. We, the Department of Anesthesiology, do conduct CMEs, live workshops, PG assemblies, etc. every year. But because of COVID pandemic, we have resorted to this kind of virtual conference this year. Critical airway management, recent trends. The biggest challenge for anesthesiologists is securing the airway in all scenarios and of anticipated and unanticipated difficult airways. With proper knowledge of newer techniques, gadgets, and current guidelines, we can prepare ourselves to face all sorts of challenges. With active participation of all stalwarts in the airway management throughout the day, via their presentations and sharing of their personal practical experiences, will be a great help for all delegates and postgraduates. I am happy to tell you that more than 500 people have registered and watching this live program. Now I call upon and welcome all the esteemed dignitaries on the dais. First of all, I call upon our chief guest for this ceremony, Dr. Rakesh Mudgal sir, Vice Chancellor, DY Patil deemed to be University, Kolhapur. Now I welcome Dr. Mrs. Shimpa Sharma, Madam, Pro Vice Chancellor, DY Patil deemed to be University, Kolhapur. Now I request respected Dean Sir, Dr. Rakesh Sharma, DY Patil Medical College, Hospital and Research Institute, Kolhapur. I also welcome Dr. V.V. Bosle sir, Registrar, DY Patil deemed to be University. Now I call upon Dr. Vaishali Gaikwad Madam, Medical Superintendent, DY Patil Hospital, Kolhapur. Now I welcome Dr. Kalpana Kulkarni Madam, Professor HOD, Organizing Chairman of this conference. I also welcome Dr. I.J. Namaje, Professor Emeritus and Co-Chairman for this conference. I also welcome our MMC observer, Dr. Sachin Firke sir. I extend my warm welcome to other members of the Education Society and University, Deputy Registrar Dr. Mr. Sanjay Patil Zadav, all HODs, faculties, PG students and supporting staff. Now I welcome from my bottom of heart all the chairpersons, speakers and delegates participating in today's webinar. So I also welcome Dr. Mrs. Sujata Prabhu, President, Society of Anesthesiologists, Kolhapur branch. Now we begin with felicitation of our honorable guests on dais. I ask upon Dr. Kulkarni Madam to felicitate our honorable chief guest, Dr. Rakesh Mudgal Sir, Vice Chancellor, D.Y. Patil, deemed to be University, Kolhapur. I also request Dr. Kulkarni Madam to felicitate Honorable Pro Vice Chancellor, Dr. Shimpa Sharma Madam. Now I request Dr. Namaji Sir to felicitate Honorable Dean, Dr. Rakesh Sharma Sir. I also ask upon Dr. Namaji Sir to felicitate Honorable Registrar, Dr. V.V. Bosle Sir. Now I request Kulkarni Madam to felicitate our Medical Superintendent, Dr. Vaishali Gaikwad Madam. Now I request Dr. Namaji Sir to felicitate our MMC Observer, Dr. Firke Sir. Also request Namaji Sir to felicitate President SAC, Dr. Mrs. Prabhu Madam. Now we begin with our inauguration by traditional way of lamp lighting, Deep Vandana and Puja of Shri Gajan Maharaj and gain his blessings. I request chief guest to proceed for the lamp lighting. Light brings brightness with it and removes the darkness and ignorance. The light or knowledge shows us the way out of our problems and fears as well. Sama ki pura. Now I call upon our organizing chairperson, Dr. Kalpana Kulkarni Madam, Professor HOD, to give her welcome speech.
Respected dignitaries on the dais, Honorable Vice Chancellor and Chief Guest of today's function, Dr. Rakesh Pudgal, Honorable Pro Vice Chancellor, Dr. Mrs. Shimpa Sharma, Madam, Dean Dr. R.K. Sharma, Registrar of DY Patil University, Dr. V.V. Bhosle, Medical Superintendent, Dr. Mrs. Gaikwad, MMC Observer, Dr. Firke, and Society of Anesthesiologists Kolhapur President, Dr. Mrs. Sujata Prabhu. All the heads of the department, invited guest faculty, speakers of this conference and attending delegates and friends. A very good morning to all of you. It's my pleasure to welcome you all for this inaugural function of today's web conference that is on critical airway management, organized by Department of Anesthesiology at DY Patil Hospital and Research Institute, Kolhapur. As we all know that biggest challenge and responsibility of an anesthesiologist is to secure the airway for oxygenation and ventilation primarily. We not only in operation theater, but in emergency department and ICU settings. But many times we get trapped with difficult airway situation like CICV, that is cannot intubate, cannot ventilate situation, and the incident remains as a nightmare or near misses experience throughout our life. Although in recent years, a lot of advancement in the technology and equipment have taken place, which are of great help to deal such situations. But it requires training, expertise, skill, and competence. I hope today's conference will be of great help to all the attendees to achieve the knowledge about airway assessment, preparation, and management of such situation like complete ventilatory failure. Today, we are fortunate to have pioneers and experts in the field of difficult airway management. In fact, they are founders of Difficult Airway Society of India and became popular worldwide for establishing different guidelines for difficult airway management, which are published in Indian Journal of Anesthesia recently, that is in 2016. With this, on behalf of Department of Anesthesiology, I thank all the dignitaries on the dais, guest faculties, invited speakers, delegates for accepting our invitation for today's inaugural function, joining us for this event to share their knowledge and attending the conference in large number. Last but not the least, I wish to thank our Honorable President and Chancellor, the Chief Patron of this today's function, Dr. Sanjay D. Patil, for his constant support and encouragement to conduct such events. We also thank all the university authorities, especially Dr. R.K. Sharma, Dean, for constant guidance, help to arrange such conference. Thank you one and all.
Now I request organizing co-chairman Dr. I.J. Namaji sir to explain the theme of this virtual conference.
Good morning. Thank you, Organized Secretary Dr. Sandeep Kadam has given me a chance to speak. Respected Honorary Chancellor, Vice Chancellor Dr. Rakesh Pudgal sir, Pro Vice Chancellor Madam Professor Dr. Shimpa Sharma, Dr. V.V. Bhosle, our Registrar of University, Dr. Rakesh Sharma, Dean of our DY Patil Medical College, MMC Observer, my friend Dr. Sachin Firke, and SAC President Madam Sujata Prabhu. It is my pride privilege to welcome inaugural ceremony of critical airway management. The critical airway is a different entity as compared to the difficult airway. Critical airway is a life-threatening scenario of hypoxemia leading to hypoxia due to failure of ventilation or intubation. Difficult airway in which anesthetic clinician finds difficulty in back mass ventilation, supraglottic airway device insertion or intubation on both. There are many webinars coming of airway management for difficult airway management. Many guidelines are also available for difficult airway. But regarding the critical airway, no definite guidelines or algorithm are available. So the expert in this webinar will highlight this point. Honorable faculties, Professor Alok Samantra from Tirupati, Dr. Amit Dixit, Dr. Mangal Dave, and a well-known national faculty devoted for airway, Dr. Apex Patwa from Vadodara, Dr. Rakesh Garg from AIMS Delhi, Dr. Professor Syed Muhyiddin from Aligarh will guide us. I wish this welcome webinar will be more informative and fruitful. Thank you.
Thank you, sir. Now I request our Honorable Chief Guest, respected Vice Chancellor, Dr. Rakesh Mudgal, sir, to deliver an inaugural address.
Good morning, what you call enthusiastic learner and my worthy colleague on the stage, led by the Honorable Pro Vice Chancellor of the University, Dr. Shimpa Sharma, a professor in medicine, Dean Dr. Rakesh Sharma, the Registrar of the University, Dr. V.V. Bhosle, the organizing chairperson, Dr. Kalpana Kulkarni. We have able support of Dr. Sandeep Kadam in organizing and guidance of Dr. Nazami into it. We have Dr. Sachin Firke, who is the observer for this particular webinar. And we have an external guest in the name and style of Dr. Sujata Prabhu, who is always supporting this particular event in the university when it comes to anesthesiology. And I don't think I've missed Dr. Nazami, Namaji, who has been always leading and has been advocating that there has to be a proper technique while deciding whether we should be ventilating people or intubating people, whether in a supine position or proline. He's going to advocate about that. Definitely it is going to be an eye-opener for us, because when the patient is available in the right stage and coordination, definitely it is easier for us to really operate upon. That's a belief everybody is carrying on. What I feel is that end of the webinar, we are going to be richer. And during this testing time of when the world is totally kept to a halt by pandemic, which we call as a COVID-19, the technology has come as a great savior. It is my belief that at the end of the day, we will be richer in technology, we'll be richer in our approach, and definitely will be competent in handling critical airways. My belief and everybody's agreement is going to be definitely there. आयु और वायु का दोनों का संबंध बहुत ही अच्छा है. If we are able to ensure vayu, definitely we are basically moving in ensuring IU also. And if we are not able to pump air in the right fashion with the right magnitude and intensity, definitely we are going to achieve suboptimal result when we are carrying a surgery or we are reviving the patient. With these words, I congratulate each one who has been instrumental in creating this particular opportunity for all of us to learn. And my firm belief, definitely it is going to turn out to be a very wonderful learning experience for each one of us. With these words, my heartiest congratulations and best wishes to the participants.
Thank you very much, sir, for your inaugural address. Now I request Pro Vice Chancellor, Madam, Mrs. Shimpa Sharma, Madam, to address.
Thank you, Dr. Kadam. Honorable Vice Chancellor, Dr. Mudgal, Dean Dr. Sharma, Registrar Dr. Bhosle, Medical Superintendent Dr. Gaikwad, Dr. Kalpana Kulkarni, Dr. Namazi, Dr. Sachin Firke, Dr. Prabhu, and of course, Dr. Sandeep Kadam. A hearty good morning to everybody. I would like to congratulate the Department of Anesthesia for organizing today's event. More important because you've chosen a theme that, as your poster says, is not just a recent trend, but it's a critical trend, and critical airway management is important. There's a quote that I learned when I read very recently, and it has stuck in my head, so I'm going to repeat it to you again. And it says that in times of drastic change or crisis, it is the learners who will survive. The learned will find themselves equipped with knowledge that does not work in the world that does not exist. And that's the problem with people who do not update their knowledge. Critical care is one place where I think updation is running at supersonic speed, because with every leap of technology, There is something new in critical care that helps us to provide better patient care. And therefore, it is events like this that help us all keep update. A lot of work has gone into putting together this fantastic galaxy of faculty. I was going through the list of faculty, and I was pleased to see that so many senior and experienced people from this field have consented to be part of the event and the seminar, for which I think on behalf of our university and all the delegates, I thank you. I wish you all the best for the day's debates and the proceedings, and I'm sure all of us are going to come out better equipped to deal with patient care at the end of the day. Thank you so much for having us here.
Thank you very much, Madam, for your kind address. Lastly, I call upon Honorable Dean Dr. Rakesh Sharma, sir, to guide us on this occasion of this webinar. Sharma, sir.
Good morning, everybody. Honorable Vice Chancellor, Dr. Mudgal, sir. Honorable Pro Vice Chancellor, Dr. Shimpa Sharma. Registrar, sir, Dr. V.V. Bhosle. The head of the Department of Anesthesiology Department, Dr. Mrs. Kulkarni. Professor Emeritus, Dr. Namazi. Dr. Kadam, the organizing secretary of today's conference. Dr. Sachin Firke. And Madam. Dr. Prabhu, Madam. She's the president of the Critical Care Society here. First of all, on behalf of the Medical College, I extend a heartiest welcome to all the delegates as well as the faculties who are participating and going to give us lots of knowledge. As a dean, I have always found that Department of Anesthesiology of our college is a very, very proactive department. And I always find it very interesting that the seniors in the department are so energetic, especially Dr. Namazi. He's always chasing all of us to get new things, new technology, innovation, ably supported by Madam Dr. Mrs. Kulkarni, the head of the department, that, he is able to succeed in organizing the conference that is going to happen today onward. They are very tech savvy. They have got state-of-the-art infrastructure in the form of operation theaters and the instruments inside. In spite of that, they always will have challenges, that they will be difficult and critical airways, which needs a lot of learning and a lot of practice to overcome these issues. And that is why this important workshop has been organized. I'm sure with the galaxy of the speakers and the experts available from all over India, we are all going to learn a lot. This pandemic has brought us together. I think the technology has brought us in a better way together, that we are able to see so many distinguished people from all over the country joining us and teaching us all today. I wish you all a good luck, and I am sure that you will enjoy this academic feast over 2 days. Thank you very much.
Thank you very much, sir. Now we come to the end of this inauguration program, that is Thanksgiving, rather expressing my gratitude. First of all, on behalf of Department of Anesthesiology, I thank our beloved and honorable President, D.Y. Patil Education Society, Chancellor D.Y. Patil, Deemed to be University, Kolhapur, Dr. Sanjay D. Patil, for his constant encouragement and all his support and generosity to conduct such kind of educational activities. He is always in forefront to guide us. Thank you very much, sir. I thank our honorable chief guest, Dr. Rakesh Mudgal, sir, Vice Chancellor D.Y. Patil, Deemed to be University, for accepting our invitation and inaugurating this function. Thank you very much, sir, for giving your valuable time. I now thank Honorable Dr. Shimpa Sharma, Madam, Pro Vice Chancellor D.Y. Patil, Deemed to be University, for being with us and always generating positive vibes. Thank you, Madam. Next, I express my heartfelt gratitude to respected Dean Dr. Rakesh Sharma, sir, for his guidance and sharing the vision and expertise to conduct such activity. I also thank respected Dr. V.V. Bhosle, sir, Registrar D.Y. Patil, Deemed to be University, for sparing his valuable time. I thank Dr. Vaishali Gaikwad, Medical Superintendent, for being so supportive. I thank Dr. Mrs. Prabhu, Madam, President SAC, for gracing this occasion. I also thank our MMC observer, Dr. Firke, sir. I thank Deputy Registrar, Mr. Sanjay Jadhav, sir, all HODs, faculty, students, supportive staff, on this occasion. I thank all the chairpersons, airway experts who have spared their valuable time and going to guide us throughout this day. I want to specially thank the web designer Nilesh Patil for beautifully designing our conference web page. It is appreciated by many. It is for the first time we have used this platform of website for online registrations. I also thank Mr. Saurabh Jagtap for extending his help in all forms. I would like to thank Mr. Suraj and Samir Lohar for their expertise in conducting this Zoom meeting. I also thank Mr. Ajit Patil, Mr. Subhash Patil, Mr. Avdut, and lastly, I thank all my anesthesiology colleagues and PG students. Without their support and cooperation, this event wouldn't have happened. Thank you all.
A very good morning and a warm welcome to one and all for today's Zoom conference organized by Department of Anesthesiology, Dr. D.Y. Patil Medical College, Hospital and Research Institute, Kolhapur. Department of Anesthesiology has always been active in organizing workshops, CMEs and all other learning objectives every year. This year, we have gone a step ahead in framing today's conference on critical airway management on a virtual platform even during this COVID-19 pandemic times. As we all know, the biggest challenge for the anesthesiologist is securing airway in anticipated as well as in unanticipated difficult airway scenarios and in critical emergency situations. As our theme for today's conference speaks it all, critical airway recent trends will be helpful in gaining knowledge about the newer techniques and the current guidelines for the same through the lectures delivered by our wonderful speakers for the day. Before we start in our actual program, there are a few proud moments of our institution. Firstly, we are proud to announce that our institution has won the Special Appreciation Award from the Collector of Kolhapur District for the recognition of services delivered in COVID-19 pandemics. We are also proud that our institution has banked the 11th rank in the All India Ranking of Medical Institutions by NRIF Rankings 2020. And also, this year, we're happy to say on successful setting up our new simulation center, as our institution has always been a constant support to students and faculties in learning new things and updating our knowledge. Please note, we're also live on YouTube channel Anesthesia TV. Now moving on to our conference, the first topic for the day is Assessment of Difficult Airway in Routine and Critical Situation, USG Assessment of Airway by Dr. Amit Dixit. Chairperson for the session is Dr. J. Paranjapi. I request Dr. Paranjapi, her education qualification is MBBS, MD Anesthesia, and she has also done her MBA in Hospital Administration. She is currently working in Bharatiya Medical College and Hospital, Sangli. She is the professor and head of the Department of Anesthesia since last 5 years. She's also been an internal examiner in BVTU Medical College and Hospital for 5 years, external examiner at RG University, Gulbarga, Karnataka, JJUM Davangere, and she has been a dissertation evaluator in Maharashtra and Karnataka. She has attended many state and national conferences, CMEs, and workshops as a faculty and chairman, and she has also worked as a faculty for MET Cell. She has almost got 32 original publications, 23 review and editorial, and other publications as well. I request Dr. Paranjapi to introduce our speaker, Dr. Amit Dixit.
Can you make it a little bigger? I can't read it. Hello? Dr. Amit Dixit, the first speaker, today's first speaker is consultant anesthesiologist in Ruby Hall Clinic, Pune. He is fellow in regional anesthesia, MGR University, course coordinator for 1 year regional anesthesia fellowship under AORA, peer reviewer of ISA, Indian Journal of Anesthesiology, board of studies member of executive committee member, AORA India. His areas of interest are regional anesthesia and POCUS,
he has published articles in index journals, in ISA and AORA, and newsletters. He has contributed chapter in Regional Anesthesia Handbook, Bookmate, and he is an invited speaker at various national and international conferences. Now, coming first of all, as my opening remarks, I would like to congratulate Department of Anesthesiology, DY Patil, Kolhapur, which is a very vibrant department, and they have shown vision to choose the topic like advancement in airway management. Whenever any person joins as a student in anesthesiology, he has to start dealing with airway. We have various gradations, Malampati classification, Chroma or all-inclusive Lemon criteria for assessment of difficult airway. But ultrasound is emerging modality for assessment of difficult and critical airway. Till now, we were vouching upon it only for whenever we used to find, we used to do cricothyroid membrane puncture under ultrasound in difficult situation, large neck and all, or to assess the position of endotracheal tube when cardiac output is low or gold standard, that is EtCO2, is not working. Now let us see our beloved speaker Amit Dixit, what he enlightens upon the newer thing for assessment of difficult airway at critical situation. Over to you, Dr. Amit Dixit, sir.
Yes. Yep. I'm just thank you very much for those kind words, Paranspe madam. Okay. Are my slides visible?
Not yet, sir.
Okay, just a minute. Is it visible now? Is it visible?
Yes, sir. Yes, sir.
Yeah. So at the outset, thank you very much, Paranspe madam, for those kind words. This is really honor and pride for me to be part of this airway conference, and I would like to thank the organizing chairman, Kulkarni madam, for providing me this opportunity. I would like to extend my deep gratitude to Namaji sir and Sandeep Kadam sir for inviting me to Kolhapur. This is not my first time in Kolhapur. This is probably the third visit, and I am always astonished and encouraged to see a lot of enthusiasm with Kolhapurkars, and I learn a lot from them as well. So thank you for this opportunity. Coming to my today's topic, airway ultrasound. I'll be talking about ultrasound airway. Actually, 8-9 months of COVID time has given a lot of opportunity to every one of us to dwell into some new areas, and focus is one area which is very close to my heart. And airway ultrasound, as it is emerging, we are moving ahead with that. So greetings to you all from Ruby Hall Clinic. It's a 750-bedded multi-speciality hospital. We have 4 dedicated ultrasound machine with our department. And, nowadays, whenever any case is taken up, PGs and fellows are, with a lot of enthusiasm, they move the machine inside the OT. Recently, our DNB students are allotted with thesis topic in airway management with ultrasound. So, to start with, disclosures and acknowledgements. I have no conflicts of interest, nothing to disclose. Videos and photos are of my own patients. I would like to express my gratitude to my volunteer from OT who has kindly consented for scanning, and a few of photographs of airway gadgets I have taken from my good friend Dr. Him Jyoti from Shillong. So outline of my talk is basics of ultrasound, because some of us may not be using ultrasound very regularly. So I would just like to start with some basics, and then conventional methods of ultrasound assessment compared to ultrasound and conventional, that comparison, some articles I'll be showing. Ultrasound and difficult airway, extended use of ultrasound in critical airway situations, and I would like to end with summary. So what is ultrasound imaging? Now, whenever we put probe on any given structure on the body, we just see black and white two-dimensional imaging. We do not know what is what, and we really are not sure what is this structure. So something which is black is called anechoic, gray is called hypoechoic, and white is called hyperechoic. So anechoic, hypoechoic, and hyperechoic. So now I am just bringing this to your notice. This is Lee Day Tour France. So what is this all about? Some of us may not be knowing what is this all about, but if I ask you to focus your attention on this bicyclist, so this is nothing but a race across France on bicycle. So now, since I have brought bicycle to your attention, now you all can see a bicycle and a person over it in this diagram. So this is similar to ultrasound training. So when I tell you that this structure on the left side of the screen, this black hypoechoic area is cricoid cartilage, then these beaded structures are nothing but tracheal rings, and we label it. So now we are tuned to see these structures and identify these structures as with anatomical correlation. So as we develop more and more scanning experience, we are good at it, and this is how ultrasound training is done. As regards to airway ultrasound, person will require at least 33 to 40 scans before he could embark on airway ultrasound, and more or less half an hour to 1 hour scanning is enough to train them, at least with real-time intubation with ultrasound assistance. So what I am trying to highlight here is it is not at all difficult. We have different probes. We have linear, curvilinear, echo probe, but for us today, we will be using either a linear probe or a curvilinear probe. Most of the time, I am using linear probe, and when I am using longitudinal scan, the curvilinear probe is better. We must know about the orientation marker so that we can correlate which is medial, which is lateral, which is cranial, which is caudal. So orientation marker, knowing about it is absolutely necessary. Adjustment of gain, depth is necessary so that better image visualization. This is some, as we are dealing in the neck area, we must understand which is vein, artery. Veins are compressible, arteries are not compressible. We can put color Dopplers, we can see muscles. Bones are hyperechoic, white structures. Nerves are in between. So fat and all that are like hyperechoic. So we need to get accustomed with these structures. Little bit about ergonomics. Ergonomics is, it should be in such a way that the performer should be at ease. As regards to airway ultrasound examination, it can be done in sitting position or in supine position. So, if the performer is comfortable, if the screen is in front of the performer and the hand, the wrist, the elbow, and other joints are in absolutely relaxed position, then imaging is better. Now, is airway ultrasound a toy or a tool? Now, this is a very important question, as Paranspe Madam was also highlighting, that more or less ultrasound is being used only for cricothyroidotomy. and whether it is really needed. So is it a toy or a tool? Let us answer this question. It is up to you, and you will have the answer at the end of this session. So coming to the position, as far as I was describing, the position can be supine position. You can usually it is or it could be a sitting position. You have to support the patient. A small pillow can be given, and different procedures require different neck position. So I'll be talking about it little later. So mainly we are examining patient either in supine or in sitting position. Now, let me tell you, when we are demonstrating in sitting position on volunteers, this ultrasound beam do produce some sort of exothermic effect, and this causes drying up of larynx. So sometimes larynx is just not visible. So at times our trick is we just ask our volunteer to drink water, or can have a cup of tea or something, and the structures are even more visible. That is why you can understand that patients who have epiglottitis or laryngeal edema are better picked with ultrasound. They are nicely visualized. As far as probe orientation, now I'll be scanning the neck up and down, either in transverse way or in the sagittal plane. So either it is transverse plane or sagittal plane. It is not exactly sagittal, it is parasagittal most of the time. So as far as anatomy is considered, it is desirable that we can visit cadaveric workshops and get very well accustomed with airway anatomy. Important point I am trying to highlight here is hyoid bone. Then there is a thyroid cartilage, there is a cricoid cartilage and tracheal rings. So these are all the cartilaginous structure. Now between hyoid and the thyroid cartilage, this area, I am supposed to find epiglottis. So if I am holding the probe between hyoid and the trachea, I will be seeing epiglottis. Now, if I am putting my probe over the thyroid cartilage, then I'll be seeing vocal cords and vocal cord apparatus. Now, if this area between the cricoid cartilage and the thyroid cartilage is for our cricothyroidotomy. And why these tracheal rings? Tracheal rings are also important to me, so that I can very well confirm whether it is endobronchial or whether the tube is correctly placed or not. So each and every structure is important here. We must understand where are the vessels, where are the nerves, where is the esophagus. So again, in a cut section, I can show you, this is the anterior side and that's the posterior side. So between hyoid and the thyroid cartilage, here we have overhanging epiglottis. So when ultrasound beam is placed here, we can see epiglottis. We will be dealing with epiglottis. Behind the thyroid cartilage, we have vocal cords. Then we have between thyroid and cricoid, we have cricothyroid membrane. And below are the tracheal rings. Now, here, this is the anterior side. That's the mentum. So again, you can see when we talk about different thyromental distance or mentohyoid. So this is mentum and this is hyoid bone. So this is mentohyoid. Then that's the base of tongue. So again, I can put, when my probe is submental, I'll be able to see, the tongue and the tongue mass. Then when I am putting it over the hyoid bone, then again I'll be putting between the hyoid and the cricoid. So it will be for epiglottis. Then over the larynx, for larynx, I'll be putting it over the tracheal, the thyroid cartilage, and below are the tracheal rings. So this is more and more, you get acquainted with all this anatomy very nicely. you will be very well equipped as what to expect. Otherwise, I have seen with my PGs, they don't know when they see say cricoid cartilage. If probe is moved up, what structure to expect? If probe goes down, what structure to expect? So for identifying this anatomy correctly, we need to know what is the correlation. So there are conventional ways of assessing difficult airway, and we have thyromental distance more than 6.5 is difficult intubation. Then we have interincisors. Then we have sternohyoid, Malampatti, Cormac-Lehan, neck circumference. So all these are well and good, and I am here to suggest, as the literature evidence is in favor, that it is ultrasound is always an adjunct to it. So we have to understand our conventional way, and on the top of it, how ultrasound can help us. So today I'll be showing you some of the principles of airway management, airway assessment, and you can use those principles in variety of scenarios. So this is one wonderful article in recently from Egyptian journal, where ultrasound versus conventional method was evaluated and prediction of difficult airway. So more and more, I was just brushing up all the articles, and I found many articles have emerged in last 2 years. If you want to really do some thesis or research in this area, even last 2 years, you have more than 40-50 articles. No need to go really that back. So focused airway assessment and armamentarium in the future. So again, this is 2019 article. So I'll be discussing the concepts given in this article. I'll be discussing the principles. And, there are multiple indications why people are using airway ultrasound. And the list is, it is when you look at any review article, you will find the list is increasing, whether it is intubation, LMA insertion, dilatational tracheostomy, cricothyroidotomy, assessment of epiglottis, DLT, so on and so forth. But my question is, when it comes to difficult airway, how we learn during our PG days are, it is the approach is whether it is difficult mask ventilation, whether it is difficult laryngoscopy, or whether it is difficult intubation. Airway management is looked upon into especially 3 areas. The difficult, whether mask, I will be able to ventilate this patient, whether I will be able to do laryngoscopy, or whether intubation is a problem, or everything is a problem. So my question is whether ultrasound can help me with this. So yes, this is another article, and which says that as far as mass holding is considered, the skin to hyoid bone distance, if it is more than 1.4 centimeter, it is difficult mask ventilation. So skin to hyoid is so mento-hyoid distance is an independent parameter to predict mask ventilation. It also predict difficult laryngoscopy. So yes, there is a good correlation where people can tell about difficult mask ventilation, also difficult laryngoscopy. Now, what about difficult laryngoscopy? Difficult laryngoscopy becomes difficult because of increasing tongue volume or tongue thickness. So there are parameters with ultrasound where we look at lung, basically the tongue volume, tongue thickness, and looking at width. Today I am going to touch upon the simpler aspect, the encouraging aspect of ultrasound, so that you can follow very easily. What about difficult intubation? Now, intubation, we have seen mask ventilation, we have seen laryngoscopy. Intubation is more or less, if you look at all these articles, it is because of the anterior neck soft tissue thickness. So over the anterior aspect of neck, the soft tissue thickness is more or less responsible for these difficult intubations. So how they are assessing? They are assessing distance from skin to following structure. So skin to hyoid, skin to epiglottis, skin to vocal cord, skin to thyroid isthmus. Of this, skin to vocal cord is a very sensitive test. And also they have looked at ratios, mento-hyoid ratio. So when neck is extended, mento-hyoid distance, and again neck in neutral position, again the ratio is then calculated. Another ratio is peri-esophageal space to esophagus, peri-epiglottis space to epiglottis to vocal cord distance ratio. So I'm not going to complicate all this. I'll just stick to simple basic things. But this ratio I have mentioned because if you look at recent advances in this area, people are looking upon ratio PES to EVC ratio as an important parameter as regards to sensitivity and specificity. So today what I'll be discussing is identification of hyoid bone. Now there are obstetric articles which says that if you are able to identify hyoid bone, then probably it is not a difficult intubation, because in morbidly obese parturient, when hyoid bone was not seen, then it is considered as an independent marker of difficult intubation. Then again, mento-hyoid ratio, skin to hyoid distance, skin to vocal cord distance, which is a very sensitive test, skin to epiglottis distance, and thickness of tongue. This is even used for assessment of OSA. And again, the ratio. So very quickly, we'll start with first thing, which is DSHB. It means distance skin to hyoid bone, skin to hyoid bone. So we are just putting the probe and we are assessing the distance. When it is 0.8, then it is easy mask ventilation. When it is more than 1.4, it is difficult mask ventilation. So this is 2019 article from European Journal. So this was one of our volunteer which we did, and you can see nicely the hyoid bone. I have already shown you where we can see hyoid in the submental area. This is the first bony hypoechoic structure, and we can just drop a perpendicular and we can see it is 0.57. So what I have said, less than 1.4, it is perfectly fine. So it is 0.5, it means mask ventilation and laryngoscopy is not difficult. Now we will come to hyomental distance. Now hyomental distance is basically between the hyomental distance, we have a ratio. So the patient is given neutral position and the other time it is extended neck position. So when the ratio was calculated, basically it is assessment of how much the neck mobility as far as flexion and extension at atlanto-occipital joint. So those who have a ratio of less than 1.2, it means there is hardly any mobility and we can anticipate difficult airway. Now, as regards to this ratio has low sensitivity. It means it is not very low. It is up to 70 to 80, but it is specific. It is highly specific. So what is the application of such a specific test? If you find a ratio less than 1.2, it means you should change your gear. You can move on to advanced gadget. Like probably I would use a video laryngoscope if I am finding this ratio less than 1.2. So there is no flexion extension easily possible. So this mento-hyoid ratio and extended neck versus neutral position ratio less than 1.2 or 1 is difficult laryngoscopy. So what is the position? One in extended neck and one in neutral position. So we just have to calculate the distance. It is very easy. We identify the bony landmark, the mentum, and easily the hyoid bone, and we calculate the distance. So this is extended neck, and here you can find that it is 4.89, and in neutral position it was 3.58. So when the ratio was calculated, 4.8 by 3.5, it was around 1.3. So it is definitely above 1.2, and it is absolutely no problem with laryngoscopy and airway. Now another component is, so here from when we are assessing skin to hyoid, skin to epiglottis, skin to vocal cord, basically we are assessing the soft tissue component on the anterior neck. So again, this is one more step. So skin to epiglottis distance, and the cutoff value in most of the article it is 1.85 to 1.9 centimeter. So when the distance is more, it means the fat content is more, the epiglottis is more, and we are anticipating difficult airway. So again, where to see epiglottis? So epiglottis is seen between hyoid and the thyroid cartilage. So here, if I place my probe here, I will probably see epiglottis. So here, as I am placing my probe in a transverse scan, I see a hypoechoic area which has two white borders, which is because of the air mucosal interface. So you can see air mucosal interface and you can clearly identify the epiglottis. Now, as you drop the perpendicular, you can calculate skin to epiglottis distance, and it is 1.69. Now, what we have said, our cutoff is 1.85. So anything less than 1.85, it has absolutely no problem. It means the anterior soft tissue neck area, the tissue is less, and there is no issue as far as intubation and difficulty level. Again, when people have other different focused article, when they look at periepiglottis space, which is actually the similar parameter, like dropping the perpendicular from skin to the anterior surface, to up to this area, the epiglottis. So when it is like 2.5, it has been found that it correlates very well with Cormack-Lehan 2B. So there are some supportive evidence that this is also a very useful test. Now there is one more thing. As I am seeing the epiglottis, I can put a caliper and see how much is the diameter, how much is the thickness. So in patients with stridor, in patients with H influenza, epiglottitis, or patients in ICU, sometimes epiglottic infection causes, or a overhanging epiglottis in pediatric patients. You can see the bigger sized epiglottis. Now again, I am coming to another lower down, one more distance, which is skin to vocal cord or anterior commissure distance. And here the cutoff value is very sensitive. It is 0.22 or less. So where I should see the vocal cord, it is just behind the cricoid cartilage. So I have to put my probe over the cricoid cartilage. I'll see vocal cord, and as I see this vocal cord, I'll just drop a perpendicular, and there should not be any foreshortening, and you should get a proper cut so that you identify the skin to anterior commissure distance, and it is extremely sensitive. And if it is around 2.2 to 2.25, so around more than 0.25 or 0.35, it could be, it is a very good screening test. It is highly sensitive. So tongue thickness, this is especially in morbidly obese patients and patients with OSA, it is found that tongue thickness at the base of more than 6 centimeter is an independent marker of difficult airway. So how will you assess? So it can be assessed in the longitudinal way, or it can be assessed in the transverse way in the submental area. So how we see the tongue? We see tongue, here is a longitudinal scan, so you can see the whole width of tongue. So you have to pick up the bigger and larger diameter, or you can do it in the transverse scan. So here in both, it is around 4.5. So it is definitely less than 6. And again, we can say that there is no problem as far as laryngoscopy and this parameter intubation, airway. They do not use word intubation or anything. Some articles have focused. They say airway assessment, difficult airway. So as a parameter for difficult airway, the tongue thickness, if it is less than 6, then it is not that difficult. So is ultrasound really useful in intubation? Now, ACLS guidelines have said that real-time, the role of ultrasound in intubation, and this is really, I think, for the first time, people have accepted its importance. As far as I am considered, I am always worried when somebody else is intubating, and it is very good idea to put either a linear or a curvilinear probe in the suprasternal notch, just identify and place in such a way that you see trachea as well as you see esophagus, and allow somebody else to intubate. This is very useful in pediatric population, and even in laparoscopic surgeries in adults where you really do not want any inadvertent esophageal intubation, because if esophagus is ventilated, I mean, it causes more bloating and, lap col and lap appendix and other laparoscopic surgeries, the surgeons do struggle. So what are the real advantages at intubation with the help of ultrasound? One thing in pediatric as well as in adult population, the size of ET tube. Is size of ET tube important to me in adult population? Yes. When I'm, say, doing thoracoscopic esophagectomies, and if I'm planning to use a bronchial blocker, probably I would like to use a upsized tube. And in a female patient, I really want to know whether she can take that 8.5 cuff tube. So size of ET tube is very important. So ultrasound will help us to, identify and see what is the subglottic diameter. Then real-time intubation is possible, and we can see the tube going into the trachea. The depth of endotracheal tube, whether it has gone endobronchially or whether it is exactly, above the carina, and ventilation is correct or not. And also if you are placing DLT, then again confirmation of DLT. So intubation is really, so first point is assessment of subglottic depth. You can really put a marker and subglottic area, and you can identify. So these are the subglottic area, and the internal diameter here, it is coming to 1.39 centimeter, which roughly corresponds to 8 tube. And there is, you can Google it, and then you will have this conversion between, if at this diameter, what should be the size of ET tube and DLT. Also at the time of intubation, this is how you can place the probe in pediatric population, and pediatric population subglottic area and assessment is useful in deciding the tube size. As far as oncosurgical work in adult population, we still depend on CT evidence, but airway ultrasound provides us that capacity of dynamic assessment when vocal cords are moving, when, in patients who have mass or swelling, or patients with tracheomalacia, the lumen does change. So dynamic airway assessment is only possible with ultrasound. So tracheal intubation, we see, nice trachea with a tracheal ring and the tube inside it. You can see it in long axis and a transverse axis. When we see, we can also identify esophagus very nicely on the left side most of the time by the side of trachea. So when we see esophageal intubation, we see two double, this is like double tracheal sign. We see two trachea. So this is probably an esophageal intubation. So if you are placing an ultrasound here, you can, if it is endotracheal intubation, then esophagus is quite all right. If it is esophageal intubation, you see another tracheal ring appearing here. So ET tube, this is the picture where we have initiated and created this. So ET tube is like you can clearly see two trachea and they are quite big in size. Now this is different from Ryle's tube in esophagus, which appears much smaller. Now I'm just showing you this scanning video to just show that how to identify esophagus. So esophagus is on the mostly on the left side, and at the tracheoesophageal groove, here is the recurrent laryngeal nerve as well. And as I am asking the person to deglute, you can see, the esophageal mucosa is moving. So if we are aware of position of the esophagus, then we can understand where to give cricoid pressure. Most often we give cricoid pressure wrongly, and it is I mean, if you really wish to give prevent aspiration or something, why not do a pre-procedural scanning with ultrasound, identify the esophagus and put pressure over there so that it will work. I mean, this is just a speculation. Okay, so that is esophagus. And another important aspect is, apart from whether it has gone in esophagus or trachea, how much should be the size. Third important aspect is whether it has gone endobronchial or whether it is in correct place. So this is from Him Jyoti, my friend, who I borrowed this slide from him. Saline is used to inflate the cuff, and you can see the proximal end at second tracheal ring, from where you can estimate that at least around 6 centimeter distal will be the tip, and you can correctly understand where the actually the tube is placed. Now, if it is the cuff filled with saline is seen at 6, 4, 5, like that tracheal ring, then you might have to withdraw. So is this the only test to confirm? No. If there is endobronchial intubation, you can also put a linear probe on lung and see the sliding sign. Now, if sliding sign is seen, it means the lung is getting ventilated. If it is endobronchial, you will see sliding sign on one side and barcode sign on other side. So what is this sliding sign? So when we put M mode as a motion mode, we pick up motion all across the screen. So as the pleura is moving very heavily, we see granular appearance at the base, and in the upper part skin subcute that doesn't move. So it appears like a seashore sign. So this is indicative of healthy, normal ventilating lung. And when it is there is no movement of pleura, it is like a barcode sign. How we identify barcode. A lines is also a normal feature. Apart from that, in pediatric population, or you can also see movement of diaphragm, whether the tube has gone endobronchially or it has gone on the both sides. So what you can see here is, bilateral movement of diaphragm. So if tube has gone on one side, the diaphragm on that side will move, other side it may not move. So good movement of diaphragm, you can check it individually in adult patient with use of either a curvilinear or a echo probe. So differential diagnosis, if you don't see lung sliding, then the differential diagnosis we need to know. It could be pleurodesis. It could be loss of lung volume because of complete atelectasis, mucus plugging, or pneumonectomy. It could be reduced or absent lung ventilation because of apnea, laryngospasm, bronchospasm, endobronchial intubation, DLT, or it could be pneumothorax. So word of caution when we do not find positive lung sliding sign. There are other differentials apart from endobronchial intubation. So this was one algorithm. If it is endotracheal, then we have bilateral lung sliding. If it is endobronchial, then we have only unilateral lung sliding. And when it is esophageal, we have completely absent lung sliding on both sides. So what is the role of ultrasound at the time of extubation? So nowadays, yes, tracheal leak test, surgeons for with thyroid patients and post-thyroidectomy, or in ICU where post-extubation stridor, we have also vocal cord movement is nicely seen. The strength of diaphragm can easily be assessed. We can predict length of ICU stay. So post-extubation stridor, what we have to do is we have to inflate and deflate the cuff. And if the difference is more than 1.6 centimeter, then probably the chances are more. The post-extubation, the mean difference after ET tube cuff deflation inflation is 1.6 or more, then the chances are more. So this is inflated cuff, and this is again a deflated cuff. So think of a situation of tracheomalacia. So the difference will be much more, because the valves are collapsing. So with inflation, deflation, and it will be more than 1.6, then probably patient might have stridor. What about vocal cord movement? Vocal cord movement, where to see vocal cord? I have already highlighted where to see vocal cord. So it is just behind the tracheal the thyroid cartilage. So at the level of thyroid, if I am placing the probe, I see vocal cord. So this is in long axis, we can also see the vocal cord movement. So some structures, I'll just show you the long axis video. Here you can see vocal cords moving nicely. These are the two vocal cords. I have asked the person to say E, and you can see the vibrant movement, the very rapid movement of vocal cord which is happening, and this is the vocal cord which is moving in long axis. So the structures which we need to know in short axis is lower down is the arytenoid cartilage. And this is very important because if arytenoid cartilage on both sides is moving up bilaterally equal, then probably there is no vocal cord palsy. If it is not moving, then there is palsy. So apart from vocal cord movement, we also have to look at these two hyperechoic dots at the base of larynx. So I'll be showing you a few videos of vocal cord movement. So here the volunteer is breathing normally. I mean, this is, you can see the arytenoids closely and approximating, and also the true and false vocal cord. That's the anterior commissure. So vocal cord movement is seen nicely. Now I'm moving to another where I have asked him to say E, and there is vibration of vocal cord here in between. So you can see the vibrating vocal cord. Another video I have. This is the third video, and again you can see vibration when he's saying E. So you can very well pick up vocal cord movements just at the time. So it is quite barbaric when to put a laryngoscope when patient is getting extubated and at the end of thyroid surgery. And I think ultrasound is a much easier and a very patient-friendly way of doing this thing. This is my personal opinion. Now, use of airway ultrasound in critical situation. First is cricothyroidotomy. Now, I think Nimaji sir was also, and Paranspe madam was also highlighting about CVCI. Nowadays, they call it as CVCO, cannot oxygenate. So here, the concept is we have a cricothyroid membrane, and we can easily pierce and pass a needle through this. So now, when we are doing a high-risk patient with a poor hemodynamics, we use arterial line monitoring, and at the end of surgery we just remove arterial line from the radial artery. Now radial artery, you know how much is the diameter, and we put a 20 gauge cannula. Now think of diameter of the trachea. I think this will not be a bad idea. If you really have a difficult airway, why not to put a prophylactic 18 gauge cannula into this area, because sometimes when you have a real difficult intubation and when things go messy and bloody, it is very, very difficult. So why not do a prophylactic cricothyroidotomy and put a safe, as a safety feature, 18 gauge cannula, because patient may not die because of lack of ventilation, but it is lack of oxygenation. So we have one port. So this is a very important point with large masses or patients with difficult airway, very dynamic compression, better to secure when you are really worried about airway. So how we see on transverse scan, we see a cricothyroid membrane and there is a interface, mucosal interface. So how to identify? Mostly it is done in parasagittal view, and what we see in the parasagittal view is mainly the thyroid cartilage and the cricoid cartilage. So here one is the thyroid cartilage and two is the cricoid cartilage, and this is the air mucosal interface, and we can just know this white hyperechoic line is the cricothyroid membrane. We can mark, we can bring the structure in the middle of the screen and we can just mark it with the help of a pen. And even if really we are worried, we can even put a needle. Now I have helped my surgeon with post radiation neck for tracheostomy, where they cannot find trachea, they cannot identify vessels. Of course, that topic I'll be covering with tracheostomy part. But airway, when it is complicated airway, putting a probe is a very simple way of assessing it. So we identify this cricothyroid membrane. We can put a prophylactic 18 gauge cannula there if needed, or at least we can keep it marked. One of my PGs was giving DNB exam last year, and we had this wonderful POCUS workshop at Kolhapur itself. He attended that, and when the examiner asked him about aspiration risk and such a difficult case scenario, he said, "Sir, I would like to do a gastric ultrasound and I would like to mark the cricothyroid membrane before starting this case." Then the examiner was very happy that this student is doing good. He's assessing the aspiration risk with ultrasound in pre-op area. Also, he's marking the cricothyroid membrane. I mean, the patient is absolutely safe in his hand. So this cricothyroid membrane, we must know and we must be able to do it. There are studies to show that 30 seconds, most of the people are able to identify and mark it and puncture it within 30 seconds with ultrasound, with a little bit of training. Percutaneous dilatational tracheostomy. Now, why ultrasound is important is because people either do it high tracheostomy or low tracheostomy. They go up to T1 or they go up to T3, T4, all have complications. Then there are vessels, the post radiotherapy, post modified radical neck dissection, sometimes patients with vascular masses or big thyroid swelling. It is very, very difficult. So ultrasound will help you to identify the exact level T2, T3 and where you can do it. And I once for tracheostomy, the surgeon was about to take a horizontal incision, and I just placed the probe and I could show that there is a good vessel around there in his incision, and then he made it vertical. So that was a post radical neck dissection patient. So actually we can help our surgeon to change their plan of action. So where are the tracheal rings? So this is the cricoid cartilage. Just below the cricoid cartilage is the thyroid isthmus, and then the tracheal ring starts. So we have to tell the surgeon that this is the area of thyroid isthmus. Kindly do not puncture it, because you may end up with a vascular injury. There are incidences where patient has lost life even with a simple procedure like tracheostomy. We have to be very careful. So I was just telling about the thyroid gland and the isthmus, and we should avoid damaging the isthmus, and we should go towards the tracheal ring area. So this is the isthmus and nicely seen thyroid gland. And you can see the scanning as well. So you can see whole area, and that's the esophagus and the vessels nearby. So this more or less we have covered the topic and the tracheal ring identification, and we can plan it accordingly. Now this was one of my patient who came in stride. She came in stridor, and we have to intubate her in sitting position. So airway ultrasound examination was handy. We could mark the cricothyroid membrane beforehand, and she was for neurosurgery. And vocal cord pathologies, sometimes some patients do have vocal cord nodules, polyps or cyst, and then in those patients an elective fiber optic intubation is a good idea. And though these type of pathologies are rare, but they are not very uncommon. So if you have this habit of scanning all the vocal cord and airway ultrasound pre-induction, then you may pick up some pathology and patient may be asymptomatic, and then you probably have avoided trauma in that patient. So vocal cord cyst, sometimes they may not produce any phonation defect, and you can pick up with good scanning technique. Yesterday I was scanning the volunteer and I could see some hyperechoic change in that area. Okay, so LMA positioning is also very quite all right, and we can easily pick up. So here you can see when there is no equal distribution, I mean the arytenoid moves bilaterally equal and apart, and there is a good bulge in the equal bulge in the parapharyngeal area. Whereas when it is LMA is mal rotated, you don't see it properly. Of course, the gold standard for assessment of LMA is still fiber optic, but with ultrasound very handy, we can easily put and check whether there is a adequate bulge. Maxillary sinusitis, air fluid level can be seen in semi-recumbent position, and this is a relative contraindication for nasal intubation. Similarly, severe epiglottitis, laryngitis, you can pick up in ICU, and you can plan hydrocord, and extubation strategy can change. So maxillary sinusitis, you can really see maxilla, and not all patients are good for nasal intubation. Aspiration risk assessment, it is even in e-learning module, gastric ultrasound is part of airway assessment. So lower airway assessment, gastric ultrasound is important. So I'm not going into greater details, but here is the pyloric antrum, and it is very easy to put a probe in the epigastric area, and here is the epigastric area. So it is in the supine position and right lateral decubitus position. So so when we tried this on volunteer, I am just showing you what we did with our volunteer. So important structures are, we have pancreas and liver, and in between, just beneath the liver, we have this pyloric antrum. Below is the aorta and superior mesenteric vessels. So what is the principle? Volume more than 100 or say 1.5 ml per kg of liquid is aspiration risk, or presence of any solid is aspiration risk. So if you see anything solid or volume more than 100, it is aspiration risk. So what we did is, this was an empty pyloric antrum. Then we gave our volunteer some fluid, and we can easily calculate. So you can put a caliper, calculate the cross-sectional area, and check it with the chart which is available in printed form, and look at the age of the patient. So previously it was 62 ml, and then after giving some fluid, it was 120 ml in 5 minutes. So now there is little aspiration risk is increasing. So this is the last section. Is there any sensitivity and specificity to airway measurements? So as I was telling, when any test is extremely sensitive, it can be used as a screening test. And whereas if the test is very specific, then it can be used to change your management plan. So if say Mento hired mento-head distance or mento-head ratio I have calculated, which is a very specific test. So if it is positive, then I will change or upgrade to probably fiber optic or to video laryngoscope. Whereas screening test is like skin to anterior commissure distance. So if you look at article now, this is one of the recent article, and I'm happy that it is Indian article 2020 from Uttar Pradesh, and this has dealt in greater details about preoperative conventional clinical predictors and ultrasound assisted predictors. And they have looked at all the parameters and their normal values. And what they have found is they have looked at combination. So here you can see sensitivity and specificity more or less touching 80s and 90s. But when we have used this anterior neck mass, or what it is like skin to anterior commissure distance at vocal cord with malam patti, then probably it is highly sensitive up to 85 with specificity of 90. So when so the take home message is we should not forget our conventional methods of malam patti, the thyromental distance, and when they are used in combination with these ratios, and then there is more increasing specificity and sensitivity. But by and large, you can see that there is emerging evidence, and days will not be far when we will have a very strong evidence in favor of ultrasound. So in summary, I have dealt with the assessment of ultrasound as far as mento-head ratio, tongue thickness, anterior neck soft tissue assessment of vocal cord at epiglottis level, at hyoid level, and these are good adjuncts to conventional method. Critical situations like endobronchial intubation, tracheostomy, percutaneous or surgical, cricothyroidotomy, airway pathologies, dynamic vocal cord palsies, post-extubation stridor are very well assessed by ultrasound in real time. Gastric ultrasound for aspiration risk is integral part of airway management, and real-time placement of ET tube, which is now a part of ACLS guideline as well, and DLT and LMA are better confirmed with USG. Supportive evidence in favor of airway ultrasound is definitely increasing. Thank you very much for your patient listening.
Thank you, sir, for the wonderful lecture. Please note, we're also live on YouTube channel, Anesthesia TV. Now, moving on to our question and answer session. Viewers, please note, questions are to be put up in the chat box. So, shall we take up the questions for the session?
There was only one question, and that was airway assessment in pediatrics. And without wasting time, I myself would like to answer this, that in cooperative and sedated child, yes, and it is very much necessary and useful. Two more, I thank Dr. Dikshit for very extensive coverage of the topic in very lucid language with giving cutoff figures. I would like to add only two things. To enhance the echogenicity, we can insert a stellate inside the tube. That is one. And another thing, he said that in a difficult airway, we can prophylactically put catheter in cricothyroid membrane. I differ in the opinion. We can mark it. And what I tell my students, that keep 18 gauge needle ready. 18 gauge needle, I mean to standard needle, and put a 2 cc syringe to it, and a 6 number 82 tube fits to it. Just keep it ready, mark it, and if required, you can with that thing you can go in. So that's all.
I agree with that. Thank you very much.
There is one more question. Can we do this ultrasound assessment in distorted anatomy like post-radiation? Yes, he has already covered it. We can.
Yes, we can. Actually, that's a little advantage. That there we have advantage where we can identify the structures and the course of vessels around, and we can avoid inadvertent vascular punctures. maybe.
Thank you, sir. Thank you, ma'am. Now, moving on to our next session. The topic is the recent guidelines for management of anticipated and unanticipated difficult airway by Dr. Rakesh Gar. Chairperson for the session is Dr. Madhuri Kudri. Dr. Madhuri Kurdri, MD Anesthesiology. She is the professor and Department of Anesthesiology in KIMS, Hubli. She is also the associate editor of IJA. Her area of interests are pharmacology, medical education, and research. She has an intense experience of 23 years in our PG teaching and also as an PG examiner. She has been awarded as a Best Reviewer Award in 2017 by ISA IJA for her achievements. I request Dr. Madhuri Kudri to introduce our speaker for the day.
Thank you very much. And I think you were just struggling with my name. I'm Dr. Madhuri Kurdi. And I thank Dr. Kalpana Kulkarni Madam, Namazi Sir, and Dr. Sandeep Kadam, and entire Kolhapur team for giving me a chance to join you for this CMA as chairperson. And I remember the nice times that I had at Kolhapur at various academic feasts and occasions that you people organize every year. Coming to the introduction of the speaker for this session, Dr. Rakesh Garg. He needs no introduction. I don't think there is any need to introduce him because he's a very well-known, popular speaker at conferences. He is a doyen in airway management and resuscitation. And it is my pleasure and honor to introduce you to him. Just as a formality, Dr. Rakesh Garg, he has done his fellowship in palliative medicine, in clinical research methodology, and now he is additional professor in All India Institute of Medical Sciences, New Delhi. He has got a total of 250 publications and authored 25 chapters in books. He is an editor in 2 books, and he is also the vice president of All India Difficult Airway Association. So he will be speaking on the recent guidelines for management of anticipated and unanticipated difficult airway. Over to you, Rakesh, sir.
Thank you, madam. Thank you for the nice words, for the nice introduction. And thank you also to Professor Kulkarni, Professor Namazi, Dr. Kadam for just not organizing a wonderful virtual CME, but also for giving me the kind opportunity to interact with the all dignitaries here. I've been asked to speak on one of my favorite sessions with regards to the airway management and what are the guidelines related to the anticipated and unanticipated difficult airway. So I'll take you through these guidelines and I hope they will be useful. I'll be open to discussion even in between. If somebody has queries, they can be asked in between also. Otherwise, we can have question answer sessions at the end also. So I bring greetings from my institute. I work at the Cancer Center of All India Institute of Medical Sciences, and we recently have a very big 800-bedded onco center, which is in the vicinity of AIMS campus. And that is the place we are getting almost many difficult airways almost every day. We are having almost 8 to 10 difficult airway management almost every day because of the patients type we are receiving, and that is giving us a lot of learning experience in difficult airway management. Now, why this presentation or why this topic has been incorporated? Because we know that the successful airway management is primarily based on a systematic approach. And that would just not increase the success rate of airway management, but that is also required to decrease the morbidity and mortality. And we know that the delayed airway management or unsuccessful airway management definitely have not only airway-related morbidities, but it can also hamper various organ systems. And that is why if we remember from our time immemorial when we have started our anesthesia practice, we were thinking of various plans, various approaches, and those plans were being used in tandem. If one fails, we can proceed to second. and all things needs to be prepared in first. And that is why those plans or those strategies has been put in a more evidence-based, in a systematic approach, and what is being deciphered or released as guidelines or structured algorithms by various societies across the world. And these algorithm-based management has been found to be very useful because it gives you a guide for managing these airways in a successful way. Now, usually we think that airway management is really easy for majority of us, but except when it isn't. And that is what at times the unanticipated difficult airway comes into the picture, wherein we expect that everything would be fine. And we already had a good session by Dr. Amit Dixit, wherein he's demonstrated the role of focus in airway management in a dynamic way, where we just can not only assess the airway, but also use it in a dynamic airway management. But there would be a situation wherein we expect that everything is going fine based on our initial examination, but then we do a laryngoscopy and find that it is CL4 or CL3B, and we are not able to see anything. And that is what requires various plans. And that is why various organizations across the world, I think there are more than 50 airway management guidelines which has been released across the world, which also gets updated. And these so many algorithms, the reason is simple. So I'm not here to confuse that there are 50 guidelines and you need to remember everything. These guidelines has been formulated because we have so many airway gadgets now in our armamentarium. We have those availability of equipments also at many places. And all this requires a little different expertise. And these expertise needs to be not only learned, but it should be retained with practice and practice. So just to simplify the approach, each nation, each geographical area will try to have, based on the practice scenario in their particular state or particular country or particular demographic region, they would try to give an algorithm. Now, this is an interesting article where they have summarized various algorithms which has been published, and they found that the algorithms which has been published is almost around 33 publications which has been published, out of which 14 are from societies, and AIDA, All India Difficult Airway Association, is one of them, where the guidelines has been mentioned in this more prominent journal. So these 14 guidelines has been usually a region-based. Region-based means the usual practice of the anesthesiologists in that particular area. For example, say ASA is more populated towards the American population, the availability of FDA-approved products there. Similarly, DAS is from UK. And similarly, AIDA is from India, wherein looking into the infrastructural and availability of equipment, these guidelines has been formulated. And then there are individual guidelines by individual authors who are doyens in airway management. They have also released, amounting to somewhere around 38 algorithms. But the point here is, in spite of this algorithmic approach, in spite of understanding these issues, we are still struggling with the adherence. Still, the airway morbidity and mortality rate is still higher. And that was well confirmed with the NAP study, which was published in UK a couple of years back. And the adherence to the difficult airway management varied from 19 to 94%. You can see this huge variance here. So this means, in spite we have so many good evidence-based structured approaches, but still the issue remains about the usage in the real practice. And even when the algorithm content is retained, there is not always an adherence. So understanding and adherence is one of the issues. And the reason could be low adherence is when we are bombarded with multiple informations, we do not know which to follow. We do not have a universal algorithm as such, and that becomes issue. Also, the multiple international algorithms are produced in a parallel. They create a little confusion, and that's why the universal adaptability remains a big issue. And that's why we need to understand and accept and adapt the guideline which suits our best, which suits our area best, suits our expertise and availability. But whatever the guidelines are, we need to remember there are three basic components or basic preparations that we need to remember. One is the experience of the anesthesiologist. That is very, very important. The patient assessment and patient management plans, and the environmental, I mean, the support help that you would require for these patients should also be arranged. And that is what gives you an overall safety of the patients for reducing the morbidity and mortality. And this has created a good amount of shift in the airway management, because if you see the various equipments which are available to us, whether they are devices or techniques, the basic issue remains upon is the more we becomes tuned up to new equipments, the same happens the increase in the human error. So this relationship between technology and human error is a big issue, and that needs to be remembered. Though we are amenable to using newer modalities, newer equipments, newer techniques, but the complexity in using these equipments also increases the human error, and that could affect the outcome of any airway management. So these technical aspects, along with non-technical situations, must be a part of whatever approach you manage, and that's why the airway training remains one of the important aspects for learning any of the airway things, just not the purpose for a technical skill, but also from the purpose of a non-technical aspect. I'll take you through some of the guidelines which has been released by All India Difficult Airway Association. They have released 5 guidelines, which probably would be updated very soon in next year or so. The obstetric, the pediatrics, the extubation, and the ICU guidelines. So I'll take you to the first guidelines, which is one of the important one, which is for the management of unanticipated difficult tracheal intubation in adults. Now, this is a 4-step approach management of patients in adults who are having any type of unanticipated difficult tracheal intubation. Now, when we go through this stepwise approach, if you see the first step, wherein we do a conventionally laryngoscopy and tracheal intubation for these patients. Now, we need to look for the first step, the conventional management tool in India is still the conventional direct laryngoscopy. But in case if those persons who have video laryngoscopy, they can also be used for these patients. Now, in case if somebody is unable to intubate during the first attempt using the conventional methods, the most important modality that must be remembered is using of the oxygen. A high flow oxygen, earlier we used to say 15 liters per minute, which was the conventional oxygenation that can be delivered through the anesthesia workstation. But now the COVID has given a boost in the uses of HFNC, and now the high flow oxygen, even up to 17 liters, can be used in these patients, so that at least oxygen is being insufflated. The maximum 2 attempts can be given, 2 more attempts can be given in these patients, but remember the saturation should be more than 95%, and the mass ventilation should be attempted in between the failures, so that the oxygenation is being maintained in case the ventilation is successful. But remember, at any point of time, if the saturation is less than 95% and they is not being maintained by that particular step, we have to move the next subsequent steps at a very fast rate, ignoring the other components of this step. You can use the external laryngeal manipulations. You can release the required pressure. You consider changing the device. If you are using channel blade, you can move to unchanneled, non-channel blade. You can change the operator so that the chances of success improves. Also remember, it has been seen that if the depth of anesthesia is inappropriate, the muscles are in a tonic phase and hence the airway difficulty increases. So try to maintain a good depth of anesthesia so that the whatever technique you are using, you are able to secure the airway. If you succeed, you can confirm using capnography. But in case it fails, you can resume the mass ventilation and then you can subsequently proceed to the next step. Now, the failure of the first step, now next step, usually we follow the use of supraglottic airway devices, and preferably with the availability of second generation, we can use the second generation supraglottic airway devices now. Ensure that saturation is maintained more than 95%, and you can just try changing from one SCD to the other in case if the first attempt fails. In case you are successful, then you should think of whether the surgery can be done using the supraglottic airway devices, or you need to change it to something else. If definitive airway is required, then you can do a surgical airway while the ventilation is being maintained by a supraglottic airway device. But in case the supraglottic airway device is not providing you good ventilation, then you should need to think of the third step, where it is rescue phase mass ventilation. You need to remove the supraglottic airway device. You continue oxygenation at 15 liters or higher if you have the availability of HFNO. Ensure that neuromuscular blockade is appropriate, and then you can continue with the rescue phase mass ventilation. Now, this is a critical point wherein you need to take a decision whether the surgery can be done with face mask, whether it's an emergency surgery, or you need to think of going ahead with the next step, which is a surgical airway. Now, this is a situation where you are land up in a situation is a complete ventilation failure. Now, if you see the earlier options, it was cannot intubate, cannot oxygenate was the situation here. But now it is not actually the lack of oxygenation, because you can use the high flow nasal oxygenation techniques, which will help you to maintain oxygenation. But we know that since ventilation is not happening, later or sooner patient will try desaturating, or the patient will try to have mount up of carbon dioxide because ventilation is not happening. So this is a situation where you can go for emergency cricothyroidotomy because you are not able to maintain ventilation, though saturation may be maintained at this point of time with use of high flow nasal oxygenation. Now, once this is failure, complete ventilation failure, you ensure for emergency cricothyroidotomy, where you can use any of the techniques. The most commonly used technique is the surgical cricothyroidotomy, because you can use a narrow bore tube here for that can be used even for ventilation. But other options that are available as rescue measures can be wide bore cannulas or needle cricothyroidotomy, which subsequently has to be converted to tube procedures. Now, once this has been done, you should be cautious about the post-procedure plan, because multiple attempts has been done. As I mentioned earlier, these patients can have airway morbidity and mortalities. So the post-procedure plan should include the further strategies how this patient can be done. Because multiple attempts has been done, there could be airway-related morbidity like edema. Extubation may not be feasible. So you need to treat those airway edema and look for the other complications that could have happened. Documentation needs to be done for these patients. The cricothyroidotomy is an important step that everyone needs to remember, because though this may not be required quite frequently, but again, this is one of the important skills that must be learned by every one of us, so that in case if it arises, we can do it. Now, coming to the second guidelines, which are related to the obstetric part, which has been again published by All India Difficult Airway Association. This again remains an stepwise approach, wherein we try to look for ventilating a patient with an extra concern that the baby may also get hypoxic. And that's why at times, sometimes we may require perimortem LSCS for these patients, in spite that if patient is not able to maintain oxygenation and has an hypoxic leading to cardiovascular arrest. Now, again, the main crux for this remains that the oxygen supplementation should continue. And in case if the required pressure is being used, which is one of the conventional modality, though the definite role of required pressures is not very well known, but if it is being used, it can be released, and the optimization of the airway by optimal external laryngeal manipulation can be done, and attempt can be done. If it confirms, the surgery can be done subsequently. But if this first step, using the conventional laryngoscopy or direct video laryngoscopy, is not functional, next step remains also the second generation supraglottic airway devices, but ensure the oxygen flow is being maintained at this point of time. Now, a couple of surgeries, even the obstetric surgeries, now they are found to be very safe by the uses of second generation supraglottic airway devices. So you can go ahead and do it. In case if it mandates, you can do a fiber optic guided tracheal intubation through the supraglottic airway devices. That is one of the options. The blind intubation through SADs are not suggested. You can use the FOB to guide the tubes even through the supraglottic airway devices. Now, in case if the supraglottic airway devices is not giving you an optimal ventilation, you can think of removing it and start giving a rescue phase mask ventilation, as we have done for the other adult patients. At this point of time, again, ensure the neuromuscular blocking agents. This is one of the biggest dilemma which people inquire, that on one side we are saying that we are not able to ventilate, and on the other side we are ensuring neuromuscular blockade. Now, there are a couple of studies and a good evidence now that in case if the neuromuscular blocking agents are not sufficient, or neuromuscular blockade is not sufficient, it itself is an indicator of difficult ventilation. And since we have already stuck up, we have already given the neuromuscular blocking agents earlier, there may be a time that another couple of minutes have passed and the patient may have some recovery. So at this point of time, if you try inserting the supraglottic airway device or do a rescue phase mask ventilation, you will find difficulty in ventilation because of various reasons. There could be laryngospasm, there could be constant contraction of muscles. You may not be able to elevate the mandible, and hence the airway potency may not be maintained. So that's why most of the guidelines have ensured that a neuromuscular blockade should be ensured once you have stuck up in this situation where you are not able to maintain ventilation and oxygenation. Even after that, if you are not able to maintain ventilation and you are stuck up, it's a complete ventilation failure. The surgical access remains one of the options even for these patients. And that needs to be done. And as I mentioned earlier, the surgical cricothyrotomy is one of the good options. Now, herein, if the patient is not able to maintain oxygenation, has some issues, and the baby is alive, because the baby monitoring needs to be done during the airway management. In that situation, a perimortem cesarean delivery is required because there is still a couple of time wherein the reserves of oxygen are still there, and hence the baby may survive. So in case if a patient has a cardiac arrest, if a mother has a cardiac arrest, the perimortem cesarean delivery should be done within 4 minutes of the cardiac arrest of the mother, and the baby should be resuscitated as per the conventional guidelines for neonatal resuscitation. Again, because we have handled the airway multiple times in various ways, there could be edema, there could be other complications, bleeding that may exaggerate with time. So all those complications must be monitored. If the mother has been awakened, then think of other modalities of management. If the delivery is on an urgent basis, then we should think of other approaches that should be done for these patients, including the surgical airway, or the use of central urexal blockade may also be an approach for these patients. Always after the management of difficult airway, the counseling and documentation must be done for these patients. Now, coming to the pediatrics airway management, the IDA has released guidelines related to the pediatrics difficult airway also. And there has been some subtle differences for the management of airway in unanticipated difficult tracheal intubation in pediatric age group that needs to be taken care of. Now, the first step remains the conventional with the emerging use of or the availability of video laryngoscopy. Even a pediatric blade size are coming now. So this has come up a big way in management of pediatric patients. But now remember here that the difference as compared to the adults here is because the pediatric patient has a lesser oxygen reserve. So the number of attempts may not be same as in the adults, number one. Number two, the pediatric airway management requires certain expertise for the management of pediatric airway. And that is the reason we should be careful that these patients should be managed by or you can say the second or third attempt should be done by an experienced anesthesiologist who has more experience in managing the pediatric airway on a routine basis. So that is one of the crux here, and that's come the role for call for help. So once a person is managing an airway, he fails, he should always give a call for help, though it is for other scenario also. But here the call for help will include for a person who is having a little more experience in a pediatric airway. The depth of anesthesia should be monitored here. The upper airway should be maintained in a little different way because the pediatric upper airway has a more of a softer tissue. And when the optimal external laryngeal manipulation or head tilt chin lift is being done, the soft tissues can further exacerbate the difficult airway or further obstruct the airway. So that's why you should be careful. Head should be maintained in neutral position. You can use pillow below the thorax so that the patient's head remains in a neutral position. And then you can go ahead and start using airway adjuncts. At times, the lack or the difficulty in ventilation may also be related to the gastric distension because it will lead to splinting of diaphragm and hence less FRC and the splinting of lungs. So relieving gastric distension is one of the options that should be attempted in pediatric age group. In case if it fails, the conventional laryngoscopy or video laryngoscopy fails, you can use the supraglottic airway devices for these patients, wherein you can use the second generation preferably so that if required, you can intubate through them. In case if the ventilation is failed through SADs, the third attempt will be similar, the rescue face mask ventilation, but ensure again here, even in the pediatrics, the neuromuscular blockade should be ensured appropriately. The use of airway adjuncts is more commoner in pediatric age group like oral and nasal airway. So when you are face mask ventilation, you need to use appropriate size airway adjuncts for these patients so that the face mask ventilation becomes better. And in case if you think there is gastric distension, try to insert a gastric tube and decompress the stomach. And in case if you land up in a complete ventilation failure, you need to look for the emergency surgical airway access. A little different based on the patient's age group. If the child is less than 8 years and the expertise for doing a tracheostomy is available, it can be a tracheostomy. If surgical help is not available or the expertise is not available for patients, for children less than 5 years, a transtracheal needle puncture and using jet ventilation should be attempted. And for more than 5 years, a needle cricothyrotomy can be done. But for any patients more than 8 years, a needle cricothyrotomy is one of the modalities, and that subsequently, if the patient is optimized, can be converted to a conventional tracheostomy. Again, all these pediatric patients, because even a small edema will lead to airway compromise, so these patients should be monitored for all the complications in the post-operative period. Now, the intensive care unit patients have two different types of difficulties that these patients feel. One is related to the anatomical difficulty, the other one is related to the physiological difficulty or physiological difficult airway. Now, when we say the patient is not able to get a secured airway and the patient is in apnea, the various underlying problems which the patient or the critically ill patient has, they will further exaggerate the occurrence of hypoxia and cardiac arrest subsequently. These patients may be on a hemodynamic shock, they may be having a respiratory compromise, the reserves will be less. So this means those physiological difficult component will be in addition to it, and they give a less chance for us to prevent them from hypoxic injury. And that's why it requires a little different approach for managing these patients who are critically ill and requires airway management. So this stepwise approach is applicable here. Now herein the patient always, before they are being secured for airway, they should be pre-oxygenated properly, and induction of anesthesia needs to be done these patients. And it should be good if there are 2 persons involved from the beginning. The oxygenation should be optimized. The conventional face mask ventilation is one of the good options for oxygenation at high flows, but these patients at times would be on NIV. So in case if they're on NIV, the same can be used for maintaining oxygenation. And now with the availability of, or with the expertise in uses of high frequency nasal cannula, which is available at many places, this should be one of the good modality for maintaining oxygenation. You can use etomidate or ketamine for these patients along with succinylcholine or rocuronium as an induction agent and for neuromuscular blockade. Cricoid pressures may be applied, and in case once you have given it with cricoid pressure, you can go ahead and do an IPPV to maintain the oxygenation for these patients. And then we should need to, once the neuromuscular blockade effect has come up, then we can attempt for laryngoscopy and tracheal intubation. And remember, during this process, the high flow oxygen, if you have applied HFNC, they should be continued. If HFNC is not available, at least oxygen by 15 liters per minute should be continued in these patients. Now, in case if this attempt is a failure, you can go ahead and put up a supraglottic airway device. It should be second generation, and maximum 2 attempts can be given. If first is a failure, try to use either a different size or maybe a different type of supraglottic airway devices for these patients. And in case if a patient is having some efforts, the depth of anesthesia can be increased by giving boluses of induction agents once again. In case if supraglottic airway devices is not successful, you can go ahead and look for, after removing the supraglottic airway devices which was not able to ventilate, you can do a rescue face mask ventilation and ensure again the neuromuscular blockade is appropriate. In case if a patient lands up into failure to this also, the complete ventilation failure, then patient needs to have a surgical access, and surgical cricothyrotomy remains the choice of management for these patients. Now, extubation among these patients for unanticipated difficult airway also remains. The same thing will be applicable for difficult extubation also. So for difficult extubation, the IDA manages the 3-limb approach. Now, in this 3-limb approach, this is based on the presence of various difficulties. It could be a normal airway, but we require to obtain the hemodynamic response. Or the patient has 4 Ds, that is difficult mask ventilation, difficult intubation, delayed recovery, or difficult pre-existing disease. Or the third condition could be because of the surgical regions itself, the 3S. Patient may have surgical cause for airway compromise or suspected airway edema or suspected airway collapse. Now, in case if a patient is having a normal airway, you would just want to obtund or suppress the hemodynamic response. The options available is deep extubation with supraglottic airway device exchange. In case if it is pre-existing difficult airway, in those situations, once the patient is fully awake and obeying commands, then you can recruit the lung. Now, this is one of the newer things that has been added in the guidelines is the recruitment, because you want to increase the reserves. If there is an extubation failure, the patient should have sufficient oxygen reserves. So if it is not contraindicated, whatever the conventional techniques that you use, the lungs can be recruited. As we have done during intubation, all patients should receive oxygen supplementation at the time of extubation also. And these patients would require exchange or extubation or removal of tube over an airway exchange catheter. If simultaneously you need to look for the pathology which may have happened, you can extubate them over and fiber optic also, so that you can simultaneously look for whether there is some edema or collapsibility. And once it has been done, the oxygen supplementation needs to be continued. You can use even HFNC now. This is being available, and then patient can be removed from these. The third situation where it is a difficult airway because of the surgical regions, you need to delay extubation by the time the edema should develop, and then edema should settle down, and then consider for leak test while they are still with tube on ventilator. If the leak is present, then this means the edema is not there. You can recruit the lung and extubate them, usually over an airway exchange catheter in a monitored environment. If the leak is absent, this means the airway edema is still there. You need to delay extubation for some time and then reassess. If acceptable, then do it. Otherwise, these patients would require some type of surgical airway, because still these patients are having edema and airway obstruction, and these patients should go for reintubation and subsequently tracheostomy. Now, when we say, coming to the second aspect of it, we say the anticipated difficult airway. So this was I was talking about the unanticipated difficult airway. Now, when we say the anticipated difficult airway, know that these patients would have difficult at various levels. It could be at the level of oral cavity itself or the nasal cavity. It could be in the laryngeal and pharyngeal areas, or it could be at the glottic areas also. So depending upon the difficulty level, which is based on the assessment from history, clinical examination, and imaging, then you can take a decision. So a complete airway evaluation should include just not the ease or difficulty of tracheal intubation, but also whether when we are going to the next rescue things, whether they are still difficult or easy. For example, if you are not able to put up a tracheal tube, whether there is difficulty in putting up a supraglottic airway device. If there is not, whether if required a surgical airway, whether neck access is there or not. Maybe sometimes there is a large mass, for example, a large thyroid mass. In those situations, the front of neck access may also be not there. So that's why we need to review these history examinations and imaging for these patients. And in addition to it, we also need to consider other aspects like patient cooperation, the clinician skills and expertise, and the availability of additional help while these patients are being managed. So looking for those things, you need to look for a plan. And the plan options that we are available with is, can we avoid the tracheal intubation, or this patient would require a definite tracheal intubation. The options where we can avoid it, if the surgery can be done under regional block or a central neuroaxial block, we can do it. If you think the surgery can be done under supraglottic airway devices, there is no risk of aspiration, or if it is comfortable, or patient is not undergoing thoracic surgery, then you can do it. Or if a patient can be deferred for some time, by the time you can arrange expertise and equipments, in those situations, you can go ahead and do it. But wherein you think that tracheal intubation is mandatory from the surgical point of view, then try to think of awake tracheal intubation as the first modality. In certain situations where you think that the options or the patient cooperation is not there, or the equipment and the expertise is available, a tracheal intubation may be attempted after induction of general anesthesia. But then need to remember whether it will be with spontaneous ventilation or without spontaneous ventilation, means under the effect of neuromuscular blocking. So these are the various options that you can think of in patients of tracheal intubation. But we can add on at this point itself that in certain situations, these patients would require upfront tracheostomy. At times when patient is having an airway compromise and they'll end up in an emergency situation with stridor, they would undergo a tracheostomy. And if a patient is tracheostomized, then subsequently any other surgical procedures can be done. So ensure that the tracheostomy is appropriate, the tube is functional, and in case if the tracheostomy tube requires to be changed, then the track is matured enough. So that precautions, that care should also be taken care of. Now, deciding on awake or post-induction tracheal intubation, this algorithmic approach appears to be a good one. Now, once you have examined these patients and you have thought that the surgery cannot be done at a regional block, then if the general anesthesia is induced, the tracheal intubation is predicted to succeed in no more than 3 attempts. So we should not be doing multiple attempts, because with each attempt, the airway would become more difficult. So that's why majority of guidelines are fixing the attempts to 2 or 3 at times, and then the next rescue or next plan should be considered. Now, also think of whether there are other patients and contextual issues which are favorable. For example, like when we talk of some emergencies with lung compromise, they can have rapid oxygen desaturation. Whether there is little risk of aspiration once unconscious, no obstructive airway pathology, additional skill help is available, clinician is well versed with difficult airway management. So these other contextual issues should also be considered and then takes a decision. If the patient is having a low risk of failed oxygenation, if you induce general anesthesia with these patients, then you can induce the general anesthesia and try to manage the airway for intubation using advanced gadgets like fiber optic bronchoscopy. But in case if you think that the induction of anesthesia will lead to significant oxygenation issues, then these patients must be kept awake. And based on the patient's further assessment, you can think of the awake oral or nasal intubation in these patients, or if you think the nasal oral approach is not feasible because of the pathology, like in trauma patients, awake tracheostomy may be considered. Now, for the awake intubation and fiber optic intubations, these are the preparations that should be required. So when we are targeting the anticipated difficult airway, do ensure not only a good examination of the patient, but also patient should be prepared, which includes psychological preparation, use of anti-sialagogue agents, pre-medication, and preparation of airway like topicalization of airway for anesthetic effect. And also check that your airway equipments are functional. So pre-use check should also be done for these. Now, these are the good guidelines which has been released by a Difficult Airway Society for awake tracheal intubation in adult patients, wherein they have mentioned the 4 pillars of giving them good oxygenation, topicalize using appropriate agents like lignocaine, perform the patient in a airway management in a situation which is more comfortable. So some of us are comfortable in patients to be in supine position, but a head-up position or a sitting position may also be appropriate in patients who are having issues related to the difficult airway. For example, a large thyroid mass, they will not be able to lie supine. So they will be more comfortable in sitting and the air will be little open up. So based on your assessment, you can think of which position would be appropriate for these patients. The sedation is at times required, but again, it can be counterproductive because any amount of sedation can lead to from partial obstruction to complete obstruction. So that's why you should be very, very careful when you're using sedation in these patients. And the various steps for these patients needs to be followed up. But one of the basic key principle is that the high flow oxygen supplementation must be continued in these patients. And now with the availability, earlier we used to say 15 liters, but now with the availability of the high frequency, high flow nasal cannulas, you can use even the higher flows so that at least the oxygen is being maintained into the patient's body. Now, again, this is an important slide, as I mentioned earlier also, because when we are attempting difficult airway management, there could be various procedural complications that can happen. For example, say increased amount of secretions can happen. There could be an obstruction. There could be a change in the mode of oxygen delivery. So whatever the complications are presumed to be happening in these patients, we should be prepared for it. And as and when they happen, we just not to assess and identify these complications, but also simultaneously we need to mention it. Because at times we use multi-modalities or multi-routes of administering topicalization for these patients, maybe at times intravenous, gargles, sprays, nebulization. So you should remember that sometimes these toxic dosages may cross the toxic effect. And remember that the maximum dose that you use for airway topicalization should not cross 9 milligrams per kg. Also, you should be careful that these patients may bleed at times. Some amount of oozing can happen. So proper suctioning devices must be available. Multiple attempts must be taken care of. And the sedative regimen, whatever you are using it, though the guidelines outside India recommends using remifentanil, but it is not available in India. Being a shorter acting agent, the reversal will be much better. But since we do not have, we have agents which are little longer acting, so you should be cautious while you are using them. Now, in case if you are stuck up for a awake tracheal intubation and you remain unsuccessful, then you should be cautious. The 100% oxygenation should continue for high flows and then think of what needs to be done. If a patient is awake, he's maintaining oxygenation, you can postpone and replan and think for an additional help. But in case if it becomes an emergency, the immediate airway management is mandatory. Patient is not maintaining oxygenation, then obviously we need to look for the surgical airway access, and that must be ready. A surgical emergency cricothyrotomy is the option available for emergency surgical airway, and that remains the most common modality. But in case if you are using needle cricothyrotomy, it needs to be replaced with the conventional tracheostomy at the earliest, because it's a rescue measure. It can give you around 30 to 45 minutes of a time where you can plan, you can call for help and do a surgical tracheostomy. The various agents that you need to use, you should be using them appropriately so that the chances of failure of awake tracheal intubation comes down. So this includes use of anti-sialogogue agents, appropriate topicalization, sedative agents, and analgesic agents. So this should be used cautiously. And in India, if you think, we are using usually fentanyl and propofol for airway management in these patients, but use of propofol should be cautiously used because it can lead to complete airway obstruction. Now, there could be some, for awake tracheal intubation, there could be some concerns, especially when we talk of physiological difficult airway, because when we are managing these patients, it's just not anatomical, but the reserves are less. Same would be issues in obstetric patients or the obese patients. The other issues in trauma could be that they are bleeding, the airway may not be safe, the use of supraglottic airway devices may not be appropriate. So that's why they should be used cautiously in these patients when you are looking for the awake tracheal intubation. Even the presence of stridor could be a big issue because it's a partial airway obstruction and it can lead to complete airway obstruction. So you should be very, very cautious using any sedative agents here. Now, this is an important slide where when you are doing this difficult airway management, the ergonomics or how will you arrange your various paraphernalia for managing airway management is equal, because at times it can cause panic situation. So this is how the different person and the difficult airway cart should be positioned across the patient. That's why, so that you becomes much more comfortable. So herein, in case there could be two situations. Sometimes the main operator is on the head end or it is the foot end. Now, in case if the patient is on the front side, the person who is doing fiber optic intubation is the front side. So this will be the options available. This is the operator. He is facing towards the patient. The other things are on the head end side. Difficult airway trolley are on the opposite side and assistant is helping him. But in case if you are comfortable doing awake tracheal intubation while on the head end, then you should be cautious that the monitor should be on opposite side so that you can see the videos, and the difficult airway trolley should be beside you along with an assistant so that he can give you whatever equipment as and when required. Now, at times the intubation failure can happen. The reason could be secretions and blood, as in trauma patients. Inability to advance the endotracheal tube over the fiber optic scope because the tube sometimes impinges on the various structures. The anatomy could be distorted, like especially in case of trauma or abscess or infections. There could be a decreased space between tip of epiglottis and posterior pharyngeal wall, like in case of patients with tumors, and lack of training and experience. Now, these are the regions sometimes the awake tracheal intubation can fail, and you need to think of the other options, other strategies for subsequent airway management in these patients. Also need to remember that patient preparation is important to prevent failure. So good topicalization, good equipment, functional equipment, and lack of training of the operator sometimes can lead to failure. So you should be cautious. So that's why it is very, very important to have, though we said awake tracheal intubation, you must have a backup plan so that you can do a safe and efficient airway management in these patients. And that is usually two options here. One is maintaining oxygenation That is by tools like high flow nasal oxygenation or using other devices like use of supraglottic airway device. And also the equipments which are related to the endpoint, the last step, which we always say surgical access. So that should be available. So that's why we say the danger zone in any of the unanticipated and anticipated difficult airway should be taken care of. And the surgical access, though may not be required quite frequently, but one should be well accessed, the equipment available, the expertise trained, and those should always be available because this is the only option at times when other options have failed. And that should be taken care of. Hence, we should understand the proper anatomy of these patients. We made landmark, as Dr. Dixit was also mentioned. You can use your ultrasonography to look for the correct landmark for surgical access, and they can even now ultrasound guided surgical access is being done for a faster success rate with lesser complications. The other options that you can think of in these patients would be awake video laryngoscopy, Now, these are the hybrid techniques. Now, these are the hybrid techniques where we use combination of two different techniques. For example, video laryngoscope and fiber optic. So sometimes when there is a big mass and you are not able to see anything, we can do a video laryngoscopy, and video laryngoscopy assisted fiber optic intubation can be done. Similarly, we can use video laryngoscope guided supraglottic airway device insertion, and through it we can intubate it. So now these are the various options which are in true difficult airway where we want to avoid a surgical airway we can think of, and we can manage these patients. Now, last of couple of slides, because Thrive is one of the main modalities of airway management now. It's not a rescue measure. It should be used for all those patients. So as Dr. Dixit also mentioned, oxygenation, not intubation, is the priority at all times. And that's why if we see the oxygen dissociation curve, the hypoxemia can happen in these patients. And by pre-oxygenation, we tend to replace the stored nitrogen with oxygen, and hence that increases the apnea time. But pre-oxygenation may not be sufficient for all those patients because this oxygen will be used. Sometimes the airway management will take a longer time, and that is what we want, apneic oxygenation. And apneic oxygenation is where we are insufflating oxygenation throughout the airway management. And this is what we are doing it. Whatever the oxygen is being used, it will be replaced by the high flow nasal oxygenation so that patient will not deoxygenate. And we are continuously supplementing using high flow nasal oxygenation. So using these techniques would be important, wherein you can increase the patient reserves by using such devices which are very, very useful for difficult airway management. So nowadays what we say is the para-oxygenation or simply the oxygenation that must be done during the airway management, whether anticipated or unanticipated. So these tools are emerging as good modality for all type of airway management at all places, irrespective of whether they are being in emergency situation or in ICU setup or in the operating room setup. And the use of this Thrive can be as per the technique that we use. When the patient arrives, we can start at low flows, and as the patient anesthesia is induced, we can increase them so that oxygenation is being maintained. So having said that, these are the modalities that we are using. Even the IDA guidelines have emphasized the role of Thrive during the difficult airway management. And I think COVID, one of the positive aspects of COVID is that most of us have become more well-versed and acquire the equipment of Thrive in our OT setup. Now, once the surgery or the whatever the airway management has done, this is very, very important, which we sometimes miss, the follow-up care. We must document what exactly difficulty was there, what management has been done, and what complications would have happened. Similarly, these patients may come up for a repeat surgery. We should always give them an airway alert form so that subsequent anesthesiologists know that these are the issues and they should be cautious. We also should be in a habit to follow up these patients. So whenever we face a difficult airway, we follow up them for a couple of days so that we can manage these patients much better. So having said that, there are various airway management guidelines available, but we are, I think this is one of the upcoming universal, as I mentioned in the beginning, probably the universal management airway guidelines are being prepared by the various airway experts across the globe. Those airway universal guidelines probably would be helpful, and they will decongest the availability of various equipments. These guidelines are under preparation. Probably this may be released this year, and that will be helpful to use our own guidelines into a more adaptive way so that the outcome becomes much, much good. And this is how they are planning. Though we don't have confirmed release of these guidelines, but we hope that they will be available very soon. So having said that, the airway management is absolutely not difficult. But if we are only when we have done proper planning of the various aspects from anesthesiologist point of view, equipment point of view, patient point of view, and the teaching and training point of view. So if you have planned for everything, probably we'll be able to have a successful airway management. So don't panic in case you are prepared well, and the airway management could be done successfully. Thank you so much, and thanks once again.
Thank you, sir, for the wonderful lecture, and thank you, Madhuri madam. Now we'll move on to our question and answer session. Sir and madam, over to you.
Thank you, sir, for that really very informative talk. And as you said, don't panic. That was your final message. But we always see that when there is an unanticipated, difficult intubation, all hell breaks loose in the OT. That is what we commonly see. Though we listen to so many lectures and we know so much, still all hell breaks loose. That is what we have commonly seen even as postgraduate teachers and with so many postgraduates and everything, still all hell breaks loose. So as you said, the adherence rate to the guidelines is very less. And what could be the reasons for that? We have to really find out. But I think the most common reason is, as you said, lack of universal algorithm, and many people are not aware of these various steps in the guidelines. So the best way to do it would be to put charts of the algorithms by the boys' anesthesia machine, and the consultants have to keep themselves updated regarding the guidelines. And simulation plays a very important role. Now all medical colleges have got simulation labs, and in the simulation labs we can teach the students about how we have to follow the various steps as per the IDA guidelines. I have some questions for you, sir.
Yes, ma'am.
See, the usual system is what we do is we give the induction agent, say either propofol, most commonly propofol nowadays, and then we check for face mask ventilation, and then go on to the next step of giving muscle relaxant. So now, do you advise this step, or is it better to skip that step now?
I think now there is sufficient evidence. Checking of the bag and mask ventilation after the induction of anesthesia may not be acceptable. There are two reasons. One, we said we know very well that the bag and mask ventilation would be difficult if the appropriate neuromuscular blocking agents is not there. This is one aspect. So now most of the guidelines say ensure neuromuscular blocking agents to ensure that you are able to bag and mask ventilate. This is one. So when we know that we are going to have a difficult, then why to check it? First aspect. Second aspect that would be important is when we try to do a face mask ventilation and we found it difficult, right? So this means we are wasting time. So that whatever the oxygen reserves were there, those will be depleted there. So this means we are wasting time. And the next step is ensure neuromuscular blocking agents. So why are we wasting say 5 or 10 or 15 or 20 seconds to check for the face mask ventilation? Because the next step would be ensure neuromuscular blocking agents. So that's the reason majority of places says that in case if you have taken a decision and there is no anticipated difficult airway as such, where you have already planned that it will be done under GA, you go ahead and put up our neuromuscular blocking agents and then check it is okay. But yes, simultaneously, always remember that your plan B, C, and D must be ready for all those patients. Now, it is earlier, if I remember 10 years, 15 years back, we used to say, don't give oxygen to the patient because it will cause claustrophobia or it is not required, or it can cause hyperoxia leading to oxygen radical and toxicity. But now, even if it is unanticipated difficult airway, or if you say there is no difficult airway accepted, it is a good norm to supplement oxygen, because giving oxygen for 2 minutes, 3 minutes, or 5 minutes is not going to take away or provide you oxygen radicals which can harm. Oxygen toxicity will not happen. But on the other hand, if you land up into an unanticipated difficult airway, it will save you so much. So that is the real change which has happened in last couple of years for airway management.
Yes. So I think that's a very important message to all the postgraduate students out there. We have a lot of postgraduates, I think, today attending this session. And the next question would be, that like the guidelines say that you should give a neuromuscular blocking agent as one of the steps. So which neuromuscular blocking agent is advised like in such a situation?
I think in that sense, the two agents that are available with us, succinylcholine and use of rocuronium, both are equally acceptable. So not a big issue. There was only a dilemma about the non-availability of the reversal of the longer-acting agents, rocuronium. So that's a bigger issue. But then when we are well versed with the surgical access airway, so use of both the agents are acceptable. If there is no contraindication to succinylcholine, we can use it. In case it's contraindication, we can use rocuronium. So both are acceptable based on your personal acceptability.
Yeah. And I think there was one question in the chat box regarding unanticipated difficult airway. How to manage an unanticipated difficult airway in rapid sequence induction? That was one question which came up in the chat box.
Right. So the anticipated difficult airway for emergency situation, your concern is the aspiration, regurgitation and aspiration can happen. So now since we are doing it in awake situation, so that situation will not happen because these situations only happen when you induce anesthesia, the sphincter tones are reduced and the regurgitation can happen. So once you are doing it in an awake situation and you're doing it in a visualized technique, the issue of regurgitation is not a big issue. And the other thing is you can always do, I think we need to learn it at other places also, how to intubate when the patient is in head-up position, 30 degree or 45 degree, or maybe sitting position. So that will be absolutely a very safe reason for preventing regurgitation and aspiration. But having said that, again, if you remember one of my slides, a suction machine must always be ready and assistant should be there. So even the regurgitation can happen in sitting position. So in case if it happens, one should be ready to make the patient lateral and do a good suctioning.
Yes. Thank you very much, sir. I think now there are no more questions. And with that, we can end this session and move on to the next.
Thank you, sir. Thank you, ma'am.
As we all know, supraglottic devices now form an integral part of every difficult airway guideline. It's important to be well versed with their use. Of all the supraglottic variety of supraglottic devices, intubating LMA is one which offers a conduit for intubation. We will now learn the use of ILMA for tracheal intubation, and this time in the prone position. I welcome Dr. Vidya Patil, Professor and Head of Sri B.M. Patil Medical College, Vijayapur. She has 2 international journals and 8 national journals in her publications. She has been a speaker in international, national and Karnataka state conferences and CME. I welcome you, ma'am, for the CME.
Thank you so much. At the very outset, I would like to thank Dr. Kalpana Kulkarni, madam, and her team for inviting me to the CME. I'm fortunate enough to be a part of this as a chairperson of this session. Now, moving ahead with the introduction of Dr. Alok Samantrai. Dr. Alok Samantrai is completed his post-graduation in anesthesiology. He is from Department of Anesthesiology and Critical Care from Sri Venkateswara Institute of Medical Sciences from Andhra Pradesh, Tirupati. Sir has 23 years of experience to his credit, and he's been life member of societies like Indian Society of Anesthesiologists and Indian Society of Cardiovascular and Thoracic, Indian Society of Critical Care Medicine as well. Over to you, sir. Thank you for that opportunity.
Very good morning, Dr. Vidya Patil, madam. And I'll be talking on the use of a very conventional and user-friendly device. But the difficult part is I'll be talking on for using of the same instrument or device for a very unconventional way how to use that device. So may I have the permission of the chair to start my topic? Yeah. Greetings from Sri Venkateswara Institute of Medical Sciences, Tirupati. A very good morning to all of you. I thank Dr. Ismail Namaji for giving me this opportunity. We have two types of supraglottic airway devices which are specifically designed for aiding ventilation and intubation of the trachea. The first one is LMA fast track and the second one is air tube. However, manufacturers do not advocate blind tracheal intubation through air tube and advise adjunctive use of a flexible or semi-rigid fiber scope, a tracheal tube introducer, an airway exchange catheter, or a lighted stellate for aiding intubation through air tube. So in next 25 to 30 minutes, we will discuss how to use a ILMA with improved success rate. We will also look into various literatures and evidence suggesting use of ILMA in different clinical scenarios. The ILMA device comes packaged in three separate components. One is the ILMA propor. Second one is a silicon tip, wide reinforced endotracheal tube. And third is the stabilizing rod. Let us look into the function of each of these components. The ILMA has a sub-inflatable laryngeal mask and a rigid anatomically carved airway tube terminating in a standard 15 mm connector, which is wide enough to accept a 8 mm internal diameter endotracheal tube. The rigid handle permits removal and steering of the device in relation to the laryngeal inlet along the sagittal vein. An epiglottic elevating bar in the mask aperture elevates the epiglottis when an endotracheal tube is passed through the aperture. The stabilizer rod is used to prevent dislodgement of the tracheal component, that is the endotracheal tube, while removing the LMA component, that is the ILMA mask, while extracting the ILMA mask around the endotracheal tube. Although some clinicians may prefer to keep the ILMA mask for a short time inside the oropharyngeal cavity after a successful intubation. The usual prerequisite before attempting insertion of ILMA is oxygenating the patients with 100% oxygen for a few minutes, checking the LMA for any possible cough leak, depleting the cough of the LMA completely against a hard flat surface or using a commercially available cough depleter, to apply a water-soluble lubricant generously to the posterior surface of the mask so that the mask will easily slip or overcome the friction against the hard palate and the posterior pharynx. Sedation to be given prudentially whenever indicated. Even some clinicians prefer using a small dose of neuromuscular blocking agent for ease of insertion of the ILMA and subsequent intubation. And finally, the positioning of the patient is required so as to properly insert the mask. In our institutional practice, we use a commercially available cough depleter for depleting the mask. We use 2% lignocaine hydrochloride for lubricating the posterior surface, and we prefer using propofol for inducing anesthesia or providing sedation before inserting the ILMA. The insertion of tracheal tube through ILMA involves 3 stages. First is placement of the ILMA in the oropharyngeal cavity so that it is properly aligned to the laryngeal inlet. Second is insertion of the tracheal tube through the ILMA barrel so that the tube goes inside the trachea. Third is after the successful intubation, the ILMA need to be removed while keeping the tracheal tube in situ. Let us look into each of these stages one by one. The first is ILMA placement. Here the aim is to find out the position at which ventilation is easiest with lowest resistance, and this correlates with optimum positioning of the ILMA over the laryngeal inlet. With the head and neck in the neutral position, the ILMA is inserted with the handle parallel to the chest. The rigid handle is used to optimize the position of the ILMA. Then the ILMA is slowly advanced along the hard palate while rotating in the arc of the airway and maintaining light pressure against the patient's hard palate and the posterior pharynx until the rigid handle meets the face or faces resistance as the tip of the mask just lodges in the upper esophageal sphincter or the cricopharyngeal muscles. Once it is properly placed in the oropharyngeal cavity, that is properly aligned into the laryngeal inlet, the cuff is inflated with a volume as recommended by the manufacturer. The usual thumb rule for the intracuff volume is the size of the LMA minus 1 multiplied by 10. For example, if we are using a number 4 ILMA, then the required amount of air to inflate the cuff would be ILMA size 4 minus 1 multiplied by 10. That is 30 ml of air will be required to inflate the cuff. Once the cuff is inflated, anesthesia circuits need to be attached. The other way of inflating the cuff is using a handheld pressure manometer, where slowly the air is pushed inside the cuff till a ceiling pressure of 55 to 60 centimeter pressure is reached. Once the anesthesia circuit is attached, the first thing that should be noticed is whether the bag is moving adequately or not in a spontaneously breathing patients, and if the patient is given neuromuscular blocking agents, then one has to assist ventilation through the inserted ILMA and see adequate chest rise. This indicates a adequate chest rise or a spontaneously moving the bag in a spontaneously breathing patients indicates that the ILMA is properly aligned into the laryngeal inlet. The optimal positioning of ILMA mask over laryngeal inlet can only assure easiest ventilation with lowest resistance. To achieve this optimal positioning, many a time the clinician has to do an up and down maneuver, where the inflated mask is rotated back out of the patient's mouth by 6 centimeters, a jaw lift is performed, and again the mask is pushed back by around same 6 centimeters. This type of up and down maneuver will help in releasing an epiglottis which might have been downfolded during the initial insertion. This centimeter by centimeter up and down movement along the sagittal plane while holding the rigid handle is called Chandish maneuver stage 1. The next step after a successful placement of ILMA is tracheal tube placement. Here one need to look at two black lines. The vertical black line on the tube and the horizontal or transverse black line at 15 centimeter mark. The vertical black line should face posteriorly towards the clinician or towards the patient's nose. And this usually orients the bevel or the distal end of the endotracheal tube correctly to to facilitate passes through the vocal cords. Once transverse black line reaches the proximal barrel of the ILMA, this gives an indication that the tube has just reached the epiglottic bar or epiglottic elevator and is just about to emerge out of the epiglottic elevator to enter into the larynx. As the endotracheal tube exits the barrel and raises the epiglottic elevating bar, some resistance may be encountered. However, this resistance completely disappears once the tube passes another 1 to 1.5 centimeter into the tracheal lumen. Once the endotracheal tube reaches the epiglottic bar, the rigid handle and the entire mask of the ILMA should be lifted vertically. This is called the second step of Chandis maneuver, and this helps in increasing the ceiling pressure and also ensure optimal alignment of the axis of the trachea and the endotracheal tube. After a successful intubation through the ILMA, the tracheal tube cup is inflated and anesthesia circuit is attached, and again one need to reconfirm the position of the tracheal tube as it was done while a ILMA was inserted. The confirmation of position of the tracheal tube can be done by simple auscultation or by using a esophageal detector device or with the capnography. The next important step after successful intubation is removal of the ILMA around from the oropharyngeal cavity while leaving the tracheal tube in situ. However, some clinicians may prefer to leave the mask in the situ for short surgical procedures. Here, following successful intubation, the cup needs to be deflated and arrangements should be made for its timely removal. That means one should not keep a laryngeal mask airway or intubating laryngeal mask airway beyond 4 hours inside the oropharyngeal cavity. In case the clinician prefer to take out the ILMA mask while keeping the only tube inside the trachea, then the tracheal tube connector need to be removed, ILMA cup to be deflated, and the stabilized rod is placed at the proximal end of the reinforced endotracheal tube to stabilize the tube. The tracheal tube will be maintained in place by placing the stabilizing rod into the ILMA, which allows stabilization of the tracheal tube position while removing the ILMA. Now slowly the ILMA will be withdrawn by grasping the tube, which is just visible at the mouth distal to the epiglottis elevating bar. Now once the ILMA mask is out, the tracheal tube connector to be reattached and tube position need to be reconfirmed. This last step is very important because it may be possible while trying to remove the ILMA if the stabilizer rod is inappropriately pressed against the endotracheal tube, then there is a risk of endobronchial intubation, and if the clinician is not able to stabilize the endotracheal tube, many a time there is a risk of accidental extubation, or few times you may see that the tube has just come out of the vocal cord. So reconfirmation of the tube position is very important after removal of the ILMA. Sometimes even after performing both the Chandis maneuver, that is stage 1 and stage 2, one may still face resistance while passing the endotracheal tube through the barrel of the ILMA. If the resistance is felt 3 centimeters beyond the transverse line, then probably the epiglottic elevating bar is too proximal to contract and elevate the epiglottis, and the tube may be impacting the vallicula above the epiglottis. So here the troubleshoot is just use the next size larger mask. In the same way, sometimes the clinician may feel the resistance to insertion of endotracheal tube just few millimeters beyond the transverse line. Here probably the epiglottic elevating bar is jammed too far distally behind the posterior cartilage. And the solution is just go for a smaller size mask. Now let us look how to improve success rate. Selection of the appropriately sized laryngeal mask airway is very important. An incorrect mask sizing may impact both ease of ventilation and success of blind intubations. 3 sizes of intubating laryngeal mask airway is available: size 3, size 4, and size 5 for average body weight of 30 to 50 kg, 50 to 70 kg, and 70 to 100 kg respectively. However, if a person is around 50 kg, we suggest use of a size 4 mask rather than a size 3 mask. Similarly, if a person is of 70 kg, we suggest use of a size 5 mask rather than a size 4 mask. For men, the size 4 and 5 intubating laryngeal mask airway are better than the size 3 mask for ventilation and blind tracheal intubation. However, for women, the size 4 and 5 are better than size 3 for ventilation, but there is no difference among sizes for blind tracheal intubation. Intubating laryngeal mask airway is a reusable device. And before every reuse, it needs to be sterilized. And every reusable device has a lifespan. And if the clinician is using these devices beyond their lifespan, then he is risking the success rate. So usually steam autoclaving is done as a method of sterilization for these devices. Usually the ILMA can sustain 40 times steam autoclaving, and beyond that, if ILMA is used, its efficacy is reduced. Similarly, the tracheal component, that is the silicon tip endotracheal tube, can be used up to 10 times after steam sterilization. Beyond that, its efficacy also reduced. The optimal head position for insertion of ILMA is neutral position, unlike other airway devices where a snipping position is advocated. For the neutral position, the patients will be placed on the operating table in supine position without a pillow. This is because the head position with neck flexion on a 7 to 10 centimeter high pillow aggravate the epiglottic lip and can induce the bumps between the endotracheal tube and the arytenoid process, which does not allow a smooth passage of the endotracheal tube bypassing the arytenoid process. Use of a standard cup tracheal tube is not recommended by the manufacturer. However, the manufacturer recommended silicon tip endotracheal tube is very costly. As a cost restraint measures, one can always try different types of commonly and regularly used PVC tube in this ILMA for successful intubation. Because apart from the ILMA alignment to the glottis, the principal factor that determines the direction of the tracheal tube towards the glottis or away from it is the angle at which the tracheal tube emerges from the distal aperture of the ILMA. As different types of tube emerge with different angles through the ILMA, one can always try all the types of tube available for successfully intubating through the ILMA. Some studies are there where a pre-warmed PVC tube is used in comparison with silicon tip endotracheal tube, and they found both the tubes are equally efficacious in attempting the successful intubation rate. Similarly, Parker flex tip endotracheal tube also been used in comparison with manufacturer recommended silicon tube, and there is no difference in the success rate of intubation through ILMA. Few authors also suggested a reverse PVC endotracheal tube and found that the reverse PVC endotracheal tube has a higher success rate compared to a normally introduced PVC endotracheal tube. We have not come across any comparison between a pre-warmed PVC endotracheal tube and a reversely inserted endotracheal tube regarding the success rate of first attempt intubation. Though blind tracheal intubation is highly successful through ILMA, sometimes other adjuncts were used not only to improve the success rate, but for safety of intubation through ILMA. For example, the blind technique should not be used in patients with pharyngeal and esophageal pathology, where usually the other airway adjuncts were used. For example, a light one or a airway exchange catheter for successful intubation. And the most favored airway adjuncts to facilitate a safe passage of the tracheal tube into the ILMA is use of flexible fiber optic bronchoscope. Two types of approaches are usually favored by the clinicians. The first one is being favored by us too also. Tube first approach is the most favored one among us. Here we pass the endotracheal tube first. Once the endotracheal tube just emerges out of the epiglottic elevating bar, we pass the bronchoscope and guide the bronchoscope through the endotracheal tube into the trachea. Once the bronchoscope enter into the trachea, we just slit the tracheal tube over the bronchoscope. Some clinicians even prefer the scope first approach. Here what they do is just like any normal fiber optic bronchoscope intubation, they first railroad the endotracheal tube into the bronchoscope, then pass the bronchoscope through the ILMA. And here the bronchoscope itself just come by the side of the epiglottic elevating bar or lift the epiglottic elevating bar to enter into the trachea. Once the bronchoscope enter into the trachea, the procedure is same. That means the endotracheal tube is now railroaded over the bronchoscope into the trachea. There are few studies where they have compared time to intubation while using different types of laryngeal mask airway with other airway adjunct like fiber optic bronchoscopy. In the first group of patients, they have used a simple laryngeal mask airway. In second and third group, they have used intubating laryngeal mask airway for intubation. And in first two groups, that means with a normal mask, they have used fiber optic for assisting intubation, and even with intubating laryngeal mask group also, they have used fiber optic for intubation. What they found is the time to intubation is significantly low when fiber optic bronchoscope is not used with the laryngeal mask airway device for intubation. And this is very obvious because everybody knows use of fiber optic bronchoscope is time taking for negotiating the bronchoscope into the trachea. However, the main point of this study is when they compared both intubating laryngeal mask airway along with fiber optic bronchoscope and without fiber optic bronchoscope, they did not find any difference in successful intubation rate. Or in the reverse way, the outright failure to intubate the trachea is same in both intubating laryngeal mask with fiber optic channels and intubating laryngeal mask where a blind tracheal intubation is attempted. So the study concluded that blind tracheal intubation not only reduces the total intubation time, but also it is equal efficacious as intubating a trachea with a fiber optic bronchoscope through intubating laryngeal mask airway. Though intubation through an ILMA is classically described under supine position, this airway device is so wonderful that intubation through this device can be attempted in all patients, all possible patient position inside and outside the operation theatre with little or minimal training. Some planned situations where lateral intubation is prepared over supine position are morbidly obese patients and patients with large tumor on the back. Of course, accidental extubation in patients being operated in the lateral position may lead to an urgent requirement to intubate in the same lateral position. Intubation while using a ILMA in sitting position has also been described in the literature, particularly while rescuing the patients being trapped under collapsed building. This is our experience where we have received a patient with a butcher knife on his back after a street fight. The patient has come to us. We are afraid that any sort of movement by the patients will lead to further damage to spinal cord because we thought the butcher knife is just lying near to the spinal cord. So the only option left for us is not to allow any movement of the patient, but at the same time to facilitate a unhindered surgery, the patient's airway need to be secured very tightly. So the option left to us is putting an ILMA in prone position and using a silicone tip anatomical tube. We have successfully intubated the trachea and the surgery was not complicated and the patient was discharged home. Few other investigators also have intubated the trachea successfully in prone position by using intubating laryngeal mask airway for similar type of situation where the patient cannot lie on the bed. Now we have seen by using a ILMA, the patient can be intubated in the lateral position, the patient can be intubated in the sitting position, and of course, the patient can be intubated also in the prone positions. So does that mean that during this positioning, a routine intubation can be performed through ILMA? You will hear your own experience from a more experienced faculty in a short while. Before that, let us see what evidence says. Here is the answer to the first criticism, which says laryngeal mask in prone position, whether it's a pure exhibitionism or a valid technique. And the conclusion is prone position intubations shorten the induction incision time and it causes fewer hemodynamic changes than the standard technique of induction and intubation in the supine position, followed by turning the patient face down. Here is the second European study which reaffirms the same statement. The conclusion is self-positioning and induction of anesthesia in the prone position saves time. However, they have also concluded that more patients should be studied to confirm safety. And of course, we have here a speaker who will be presenting his series of cases with prone position intubations, and we will examine along with you all. I am also eager to hear from him what is his success rate and what are his complication profile in his series of studies. Here is a brief review where the investigator has examined all the patients who have been intubated in prone positions or where a laryngeal mask airway device is placed in prone positions. And they have concluded that there is a feasibility of placing the laryngeal mask airway device with the patient in the prone position in the elective setting. However, they have also cautioned that there is not enough evidence regarding the use of this method for emergency management of unintended tracheal extubation with the patient in the prone position. Here is an Indian study which reaffirms the same position statement. They have introduced or they have intubated or they have placed a prosil laryngeal mask airway in prone positions, and they have also concluded that it allows optimal utilization of the operation theatre personnel and time. Now coming to the same question, routine intubation in the prone positions. So this is the concluding remark from the concluding side. The author has concluded that routine intubation in the prone position can be performed effectively by experienced anesthesiologist, but this requires continuous training and good support from the anesthesiology staff. So the take-home message is ILMA is a very useful airway securement device, both in elective and emergency situations. One should practice using ILMA in different patient positions in elective settings so that one can improve the success rate during emergency scenario. Thank you once again for the opportunity. Thank you.
Thank you, ma'am. Thank you, sir. Now we'll move on to the question and answer session. Over to you, ma'am. Please unmute your video, ma'am. The audio.
Am I audible now?
Yeah, ma'am. Thank you.
It was indeed a beautiful talk, a very extensive coverage of the topic, Dr. Samantrai. I have just one or two questions to ask you. You initially, in the first part of your talk, you said that you would like to use a small dose of muscle relaxant to make the insertion of the intubating LMA easier. Would you please elaborate on that? What muscle relaxant would you like to use and in what dosage would you like to do it?
Yeah, probably once the ILMA is properly placed and I am sure that the ventilation is adequate, then I don't think there is any hesitancy in using any type of non-deployed muscle relaxant. It's not a, once you are achieving the good ventilation with adequate shield, so probably the routinely what you use, either you can use a vacuronium or rocuronium to facilitate intubation. But this is all these things after ascertaining that the LMA is properly in place and the ventilation is adequate.
Okay, when you're sure of intubating the patient, like when you are sure of the airway, then you can go ahead and use the muscle relaxant.
Yeah, that is just because once your airway is in place, if you are trying to intubate, if the vocal cord is still moving, there is a risk of injury. So once I'm sure that I'm able to ventilate with the ILMA, I just give a dose of relaxant so that the risk of injury to the vocal cord is no more there.
Okay. Okay, sir. Generally, we tend to believe that looking at the make of this intubating LMA and imagining it putting in the mouth and securing the airway, we logically tend to believe that it could be difficult to use it in prone position and of course maybe in lateral position also to some extent. But you proved that logic also fails sometimes, because you have proved that it can be used in prone position. Have you any experience of using this in prone position, sir?
Yeah, we have used in one or two cases in the prone position, sir. Yes, of course, the first time we put, because we didn't have any other option during that time, because we felt that doing a fiber optic bronchoscopy in prone positions will be much difficult for me than putting this ILMA. Actually, at 2011, this device has come to the Indian market. We have started using it more routinely for the supine positions. And the fiber optic bronchoscope, we are not that much experienced that time. So the first what we have put is that is a trial, and definitely it was difficult. But later on, we found it's and putting this ILMA, it's easy. It's everything with the learning curve. So only problem with this is probably you need to have a spine clearance, because of course, although we call it a pure prone position intubation, you need to have some degree of movement at the cervical spine. So although I have presented here is it's a street fight. Sometimes you may get a road traffic accident where you need to intubate in the prone position. But in those cases, definitely you need to have a cervical spine clearance. Otherwise, what you can do is you can just put the ILMA and use airway adjunct. Like through ILMA, you can pass a bronchoscope, and that will make the life much easier.
Okay, sir. Sounds very good, sir. These Chandy's maneuver, though they appear simple when you explain them, and when we see, of course, the videos also which show the use of Chandy's maneuver appear to be simple, but while actually doing it, I don't think it is all that easy. I mean, you really have to have some experience or maybe get trained under an experienced anesthesiologist before being able to do these Chinese maneuvers.
It really gives a great advantage if in the first insertion your alignment is not good. But suppose you have achieved almost 80% or 90% alignment in the first position itself, then use of Chinese maneuver doesn't give a much advantage, or we may not be able to appreciate it. Like you are able to ventilate with 80% or 90% alignment is there. So another 10% we may not be able to appreciate that whether our Chinese maneuver really helped us or not. But suppose your alignment in the initial place itself, you are not able to have a good ventilation, you are not getting good return of the air into the bag. It's around 50 to 60% alignment. Then probably in both cases, you can really appreciate if you do a Chinese maneuver. Once a proper alignment is done, then you see that the bag is filling now nicely with each return of the gas. So probably that is the reason why we cannot appreciate this Chinese maneuver sometimes, because with first insertion, if it is almost 80% aligned, then probably we may not be able to appreciate the same thing.
So let's say if we have decided to intubate using this ILMA in 10 patients, in how many patients do you think we will have to do these Chinese maneuvers? Let us take the number as 10. In how many patients do you think we'll have to go for Chinese, sir? I mean, is it...
the first indication of Chinese maneuver, we should find out the alignment where we get the maximum return of the air with minimal resistance to the bag. Of course, I will do in all the 10 cases if I'm not getting this. But suppose my alignment is proper, then probably in my experience, if I say that if I have 10 cases, probably 2 cases or 3 cases, I may have to do a Chinese maneuver because of a improper alignment in those difficult cases. But most of the times, I found that in those 2-3 cases also, if I change the size of the ILMA, then probably it works.
Okay, sir. That was indeed a very good talk. And that is all I had to ask, sir. Are there any questions from the other viewers?
Yeah, ma'am, there are a few questions in the chat box. Sir, as intubating with ILMA and confirming its placement is a stepwise approach, when should the muscle relaxants be used? That is one of the questions, sir.
Yes, muscle relaxants should be used once you are sure that your ILMA is properly aligned and your bag is filling properly in a spontaneously ventilating patients. And if by mistake if you have given the relaxant already without checking this mask ventilations or the bag ventilations, then probably you have to ensure that your alignment is proper by just assisting the ventilation, and then only you should try attempting putting a tube. Otherwise, you will mess up everything. If your chest lift is not adequate, you have already administered a dose of relaxant, and you try to put the tube, then there is a risk of injuring the trachea and vocal cord, both the things. So the exact step where you are supposed to give relaxant is in a spontaneously ventilating patients, you are happy that your anesthesia circuit is getting properly filled up with each chest rise and fall.
There's another question. How about the use of airway blocks and airway anesthesia in these patients? Will it improve the success rate?
Definitely, once your ILMA is placed and you want to give the upper airway and lower airway anesthesia, you can still go with a transtracheal infiltration of the lignocaine. But I won't suggest to give a hyoid block or supralaryngeal block once the ILMA is in place. That you can do at the beginning itself. Suppose you find it's a really difficult intubation, and then you can go with the air block, airway, your upper and lower airway block, then place a ILMA, then you can pass the tube. There is no contraindication of providing the airway block for tolerance of the endotracheal tube in a better way.
Thank you, sir. Please note there's a slight change in the next session. So we will be taking a session on video laryngoscopes now. To chair the session, I welcome Dr. Safia Sheikh, Professor and Head of KIMS Hubli. Thanks.
Hello. Yeah.
So I welcome Dr. Safia Sheikh, Professor and Head, Department of Anesthesia, KIMS Hubli. She has been a Senior Nodal Officer in Multidisciplinary Research Unit, KIMS Hubli. She has served as the past Karnataka State ISA President and past President in ISA Hubli, Dharwad, Karnataka. She's a member of editorial board of the Karnataka Anesthesia Journal. She has been the chairman of the Karnataka State PG Excel program 2008. She has been a chairman for various CME programs, workshops at KIMS Hubli, anesthesia updates in Hubli and Dharwad. She has delivered lectures at the state, zonal and the national and the SAR conferences and served as the postgraduate examiner in different states. I request you, ma'am, to kindly introduce the speaker and proceed with the today's session.
Yeah, good morning. Thanks for introduction. Yeah, it is. I would like to thank the organizing committee members to give me the opportunity. So it is really nice. I just attended the session. Sessions are going on very well. Yeah. So let us start with the session without wasting the time. So as everybody knows, Dr. Mangal Dave, he is the popular figure and management. So he has done MD Anesthesiology from BJMC Ahmedabad 2003. He is a consultant anesthesiology and head of the Department of Anesthesia at Goggle Hospital, Rajkot, Gujarat. And he is the inventor of video intubation device and delivered lectures in various state and national conferences. And his area of interest, difficult airway and trauma and neuroanesthesia. So nowadays, it is very important. The role of the video laryngoscope has become very important, particularly after starting COVID also. So, sir, will highlight the video laryngoscope. So, sir, the mic I hand over to you. So, let's start with the session. Thank you.
Thank you very much, madam. Thank you. Thank you for the kind introduction. Good afternoon. First of all, thank you all the organizers for inviting me for giving lecture on use of video laryngoscopes in critical airway. Myself, Dr. Mangal Dave, and I am working with Gokul Super Specialty Hospital. At Rajkot. This is my workplace, Gokul Super Specialty Hospital. Mainly our work is of neurosurgery and orthopedic surgery, and we also cater mostly neurotrauma. Na chor haryam, na raj haryam, na patru bhagyam, na cha bharakari. Vyaye krute vardate eva nityam vidyadhanam sarvadhana pradhanam. Today I want to share the knowledge of wealth. The knowledge of wealth that cannot be stolen by a thief, neither it can be abducted by the state, nor it can be divided amongst brothers and sisters, neither it is burdensome to carry. The wealth that increases by giving. Thus, the wealth of education and knowledge is supreme of all possessions. The use of video laryngoscope for managing difficult airway has been advocated by American Society of Anesthesiologists, Difficult Airway Society, and also our All India Difficult Airway Association. As per my experience, we should use video laryngoscopes for all the intubations so that we are experienced enough to use it when it is really required. And we have observed that channel blades are much more useful and give better results than non-channel blades. There are many different designs of video laryngoscopes which are available in the market, and all have their advantages and disadvantages. But the most desired feature which are required for a difficult airway in a video laryngoscopes are easy to access, it should be light in weight, it should be handy, ability to enter into a restricted mouth opening, and above all, it should be affordable and user-friendly. Today, I shall discuss with you TASCOPE. which is my innovation, and my most of the work is related to Taskcope. So this is Taskcope. Taskcope is a video endoscope camera which is connected to our my design of Taskcope blade, and a smartphone or a tablet which is attached, to which the endoscope camera is attached, making it a system like this. This is the picture which is showing the effective mouth opening which is required. 1.5 centimeter to 2 centimeter, which is required for Taskcope entry into oral cavity. So how it is performed? This is how it is performed. She is a trauma patient with short neck and loose teeth. And patient is conventionally induced and relaxed. And I am doing intubation with Taskcope. Taskcope intubations essentially are indirect intubations. First, we introduce bougie into the larynx, and then over the bougie, we railroad the endotracheal tube. In the screen, you can see is epiglottis, and lifting up of epiglottis seen are the vocal cord. And here I am taking the bougie and entering from the channel of the Taskcope. I am introducing the bougie inside the larynx. Yes, the bougie has entered the larynx. And once it is entered the larynx, over the bougie, the tube is then railroaded. And thus, under vision, the intubation is performed. You can see the tube entering the larynx under vision. Thus, the intubation is performed. If everyone else is also able to see what difficulty you are facing with laryngoscopy, then others are also able to help you with giving either external pressure or giving suction. This is also possible with our Taskcope. Here is a smart TV which is attached to the there is some issue with the video. Yes. The smart TV is attached with this and mobile phone. Screen mirroring has been done. And whatever we are able to see with the Taskcope is also shown on the larger screen. And thus the patient is conventionally induced and relaxed. And now I am doing laryngoscopy with Taskcope. Here we are able to see the tongue epiglottis and lifting up of epiglottis. Seen are the vocal cords. Everybody else can see what we are actually doing inside the operation theater. This is introduction of bougie inside. A little manipulation here and there, and now the bougie is introduced into the larynx, and now you can see is railroad of tube on bougie into larynx. Under vision, intubation is performed. So this also can be done with Taskcope. This is awake laryngoscopy with Taskcope. Patient is given 10% xylocaine spray, and we are doing direct laryngoscopy in awake patient. Epiglottis is seen and the vocal cords are seen. And there is a nodule just behind the right vocal cord, which is also beautifully seen with Taskcope. And patient is cooperative. Patient is speaking A and E to see the vocal cord movement and approximation of vocal cord. The movements are normal, but there is a nodule just behind the right vocal cord. So this is direct video laryngoscopy is also possible with Taskcope. And how an unanticipated difficult intubation of Cormack and Lehan grade 4 converts to Cormack and Lehan grade 1 or 2 with Taskcope. here what happened. She's a female, 40 years, around trauma patient, posted for emergency craniotomy. Otherwise, she was normal, but she had a little neck restricted movements in neck. And on examination with normal Macintosh blade, we were not able to see anything else. We were just able to see only tip of epiglottis. This was what we could appreciate. Only tip of epiglottis, even after pressure, after giving external pressure, only tip of epiglottis was seen. But when we introduced stethoscope for the same patient, we could recognize all the structures. The epiglottis is seen, the larynx is seen, and we could intubate the patient with stethoscope. Thus, the CL grade 4, which was there with the Macintosh blade, was Cormack and Lehan grade 1 or 2 with our stethoscope. So this is how stethoscope is very useful in unanticipated difficult intubations. Yes, now you can see that the bougie has been introduced, and over bougie we are reloading the endotracheal tube in the same patient. Yes, intubation is done. Heavyweight patient with potential difficult intubations being intubated with stethoscope. 108 kilo patient, and trauma, alleged assault injury. You can see the double chin sort of structure in the patient. So our aim is, the purpose of keeping this video is to show you that even heavyweight patients are also possible to intubate with the same stethoscope blade. You can appreciate the double chin type of neck, the patient being oxygenated, induced and relaxed, and now stethoscope is taken to intubate the patient. Introduction of stethoscope, midline insertion, what we are doing on almost all the cases. Midline insertion, just walking over tongue. This is epiglottis is seen. Lifting up of epiglottis, seen are the vocal cords. Yes, these cords are seen beautifully. And now introduction of bougie. Yes, the bougie has arrived and entered to larynx. And then over the bougie, the tube is being railroaded. The advantage of having a channel blade is that bougie really hits the exact space where you desire. You know where exactly your bougie will be there. With the non-channel blades, you have to adjust all the bougie here and there, or you stilate a tube here and there, and sometimes we are lost. But with channel blades, that issue is sorted. That's what I feel is much more important, to have a channel blade in difficult scenario. Another patient, male, 45 years of age, head injury for craniotomy, again a heavyweight patient. You can see the ease of stethoscope. Within seconds, the epiglottis is seen, and now the introduction of bougie. And yeah, bougie has entered the larynx, and over the bougie, now the introduction of tube. We have to be also careful while we are negotiating the tube inside, because we may hit any structures, any fold. We have to be careful that we don't hit any vocal fold or any fold in the oral cavity, and not to damage any fold. Another patient, 60 years of age, 133 kilo patient, posted for dorsal spine surgery. And he is a huge patient. He was a huge patient, and he was to be operated for the second time. Previously also he was operated for lumbar spine, and now it was some other surgery. Patient was conventionally induced and relaxed and reoxygenated, and now taken for task scope. And you can also appreciate that we don't need to require a special position or neck extension or giving a ramp. Even without ramp, we are able to maneuver easily and intubate. See the vision of larynx and epiglottis. And now introduction of bougie. Yes, bougie has entered. Almost in 1 minute time, we are able to perform the intubation with task scope within a 1 minute time. Yes, tube has entered. Task scope video laryngoscopy for restricted mouth opening. Restricted mouth opening is very much prevalent in our area because of tobacco chewing, mawa and gutkha prevalence. Here is a male 40 years of patient with one finger mouth opening, and he is being induced for craniotomy. And this is how this is the mouth opening, a very restricted mouth opening. Introduction of task scope. You can see blood in oral cavity also. Facial-maxillary trauma was there. And epiglottis, larynx is seen, the tube is introduced inside, and now the tube being introduced, tail loaded over bougie. We have to, as I told you, we have to be careful in oral cavity. We don't hit any folds and damage them. We prefer 7 to 7.5 number of endotracheal tube, which are easy to guide with task scope and over bougie. Another patient, you can see the mouth opening, even one finger introduction is not easily going because of the tobacco and mawa chewing. Patient is to be intubated nasally. From the left nostril, the tube is being introduced, and the nasal intubation becomes the video-assisted nasal intubation. Once the tube is in oral cavity, then we do laryngoscopy with task scope, and you see what we see. You can appreciate what we are able to see. We are able to see the epiglottis and the end of the tube. This is the epiglottis and the end of the tube, which is sitting just next to it, and pushing it further leads the tube into larynx. So most of the time, video-assisted nasal intubations. Male 26-year-old patient with facial-maxillary injury and restricted mouth opening, being intubated for facial-maxillary injury nasally with help of video laryngoscopy. These are the COVID era videos. You can see full PPE kit and masks on. Jelly is applied in the left nasal cavity, the restricted mouth opening, and the north nasal tube being introduced. Once the tube is reached inside the oral cavity, then we do laryngoscopy and visualize the tube and larynx. The end of the tube is seen and epiglottis is seen. And just going to the base of the epiglottis and lifting it up, we will be able to see the larynx. Yes, see the beautiful view of larynx. And with just little manipulation here and there, the tube enters the larynx. Thus, blind nasal intubation thereby becomes video-assisted nasal intubation. no malignancy for nasal intubation. Sometimes it occurs that the patient has got different anatomy, and because of the anatomy, it is not easy for us to guide the tube further nasally because of some anatomical variations. The same happened in this gentleman, that the tube is being guided nasally, but it enters the larynx, but it is not able to push it forward. The cuff of the tube remains outside and it is not getting pushed forward inside. The tube is from the right nostril, it is introduced and the laryngoscopy is being done. The tube is visualized and the epiglottis is visualized, larynx is visualized. This is epiglottis, which is visualized, and the tube. Now see, the tube is entering the larynx. The front portion it enters, but the whole of the tube, the bulb is not getting passed inside because of some deviated trachea sort of. After inflating the bulb, the end of the tube comes up. But there is still some problem. So what we did was, we took in a bougie and then pushed the bougie from the nasal tube through and through, so that the bougie through the tube entered the larynx and the bougie was in situ. Then over the bougie, the tube was further negotiated. Yes, the bougie now is entered the larynx, and in the vision, the tube is pushed. So sometimes we have to find separate ways to deal with separate situations. This is a high-risk patient which we didn't want to lose airway. A trauma patient with multiple bilateral Lefort 3, 4 grade fractures of maxilla and mandible. We didn't want to lose airway, so we gave only propofol and tried whether it is possible to visualize the larynx or not, and then only give relaxant if it is needed. You may appreciate the injury over the lip and surrounding structures. See the insertion, how difficult it is to insert even the tarscope inside the oral cavity. But still in this patient, we could easily visualize the larynx and epiglottis. Once we knew that we are able to go through, then we applied the relaxant and then we did the intubation. Patient was given relaxants. Sometimes it happens that there is some obstacle in front of your camera. So you have to remove the tarscope and just clean it up and insert it again. Once the relaxant is given, you can see the tube being negotiated further, and see, with a gentle push, the tube is in. So this is how it was carried. Nasal intubation and bulb inflation technique. Sometimes what we feel with encounter with the nasal tube is, the nasal tube is flabby and it tends to go posterior towards the esophagus side. and we want it to come anterior towards the larynx. See, in this patient, the epiglottis is visualized and the larynx is visualized. The tube is going posterior. In spite of giving pressure from front, we are not able to align the larynx and tube. So the tube which was going posteriorly, we inflated the balloon of the tube. So with the inflation of balloon, the tip of tube will come up and it will enter the larynx. You see, the bulb is being inflated. And with the inflation of bulb, the tip of the tube is elevated. Once it enters the larynx, then again we have to deflate the bulb. And then the tube is being pushed further. So these are the tips and tricks how we can perform it in difficult scenarios. Intubation of patient with cervical spine issues and Philadelphia collar in situ. These are the patients which are the most challenging in our day-to-day practice to intubate with Macintosh blade. Trauma patients coming with cervical collar on and fixed neck, which we are not allowed to much play with the neck movements. These are the very difficult patients, and these patients are also dealt very well with our task scope. You can see the size of the patient. He is a heavy patient, heavy built boy with a cervical spine fracture being intubated with task scope. Patient is conventionally induced and relaxed. The neck is in total neutral position. You can see how the task scope is inserted. Epiglottis is visualized and lifting up of epiglottis. The larynx is seen. The bougie insertion. Once the bougie enters, then railroad of tube over it. And under vision, the intubation is done. Another patient, 40 years of age, trauma with cervical spine. Patient is conventionally induced and relaxed. The task scope being inserted. Midline insertion, lift up of structures, visualizing epiglottis and vocal cords. Insertion of bougie inside. Yes, the bougie is entering the larynx. And once the bougie has entered the larynx, then railroad of endotracheal tube. We have to be careful while we are negotiating the tube inside the oral cavity, not to damage any folds in oral cavity. It may lead to bleeding and cause much more troubles for us. Operated cervical spine intubation without neck movements. Sometimes there is no collar, but we are supposed to do no much neck movement. Here is a case of operated cervical spine, and we are doing intubations without doing much of neck movement. See, the patient's neck is in neutral position, the insertion of task scope, the visualization of epiglottis, and larynx. Now the larynx is visualized, and during the whole procedure, you may appreciate the neck movement. The neck almost remains in neutral position. We don't give any undue neck extension with task scope. Because of our hyperacute angle of the camera, it is able to do like this. Yes, see, without neck extension, the tube is in situ. It is inserted. So, to conclude, a good video laryngoscope in the hand of an experienced operator can be an excellent aid in managing critical airway. Thank you.
Thank you, sir. Over to the question and answer session to you, ma'am. Please unmute yourself, ma'am.
Yeah. Yes, sir. Yeah. Can you hear? Yeah.
Yes, ma'am.
Yes, sir. It was really wonderful demonstration. Particularly, you have shown all the demonstration of trauma patients, restricted opening, short neck, and the importance of channel blade. So, sir, I'm having one or two questions. So, suppose like you told that there are many, sometimes there are the chances we can hit the vocal fold. So, if at all we will hit the vocal fold, so what problems we can face and how can we manage such patients?
Madam, most of the time intubation is done under vision. So if at all the tip of the tube is the bevel of the tube, bevel tip is touching the vocal cord, then we have to anti-clockwise rotate the tube. 90 to 180 of anti-clockwise rotation will turn the bevel to the other side, and we can pass the tube accordingly without any damage.
Okay. And sir, routinely whenever we are managing the case, like whether you advise to do intubation, to do muscle relaxant or only with sedation, midazolam and propofol, like what will be your advice?
Madam, routinely we give relaxant to all the patients. Only in selected patients which we are afraid of not losing the airway, then only we do it in sole propofol. And being a neurotrauma setup, we have a neurosurgeon and trauma surgeon standby. So if at all we have plan B ready with tracheostomy all the time. That is our, maybe it is an added advantage to me. But so far we have been able to intubate with relaxants. We have not lost airway in any patients.
Yeah. Sir, one more query, then we'll just take the audience question. For the obese patient, any tips you will advise for the audience and for the PG student when we are using, because always problem we face for obese patients. So for that.
More of the oxygenation time and ramp position will help in almost all obese patients. That will buy time for you, for everyone for intubation. Although I am not using because I have a little experience with this, but it is advocated that if ramp position and more of oxygenation is done, that is helpful.
So compared to 3 more than 5 or 7 minute pre-oxygenation, if we'll do, that will be useful.
Yes,
and plus additional program. Yeah. Yes. It is really nice, sir. It was really very wonderful demonstration. So we'll just give to the audience, I think, whatever the questions. Yeah. Any questions from the audience?
Yeah, ma'am. Thank you, ma'am. Thank you, sir.
Yeah.
So there are a few questions for you, sir. So we want to know the role of video laryngoscope for awake intubation in neurosurgery patients.
In cervical spine trauma and cervical spine patients, sometimes surgeons don't want any neck extension. In those cases, we can do it with airway blocks. I have done quite a few awake intubations for cervical spine.
So, sir, that is with sedation or without sedation?
Airway blocks, no sedation.
No
Only
sedation.
airway blocks. The bilateral superior laryngeal nerve block and transtracheal block, and 10% of lignocaine spray in oral cavity.
Okay. So the next question is task scope meant for bougie insertion first?
Yes.
Okay. What is the durability of this task scope, and is it comparable with other video laryngoscopes?
Yes, ma'am. It is my own design and it is quite durable.
Okay. So another question, can the patient be intubated without using a bougie?
Yes, ma'am. The tube has to be stellated one with a J shape, just like the curvature of the task scope. And then from the side of the task scope, we can enter without bougie.
Okay. So the next question is, can video laryngoscope be used in pre-operative assessment in anticipated difficult airway? Suppose the patient comes the previous day, can we assess his airway using the video laryngoscope?
Yes, of course, madam. Only 10% lignocaine spray over the tongue, and we can do an awake laryngoscopy of the patient with this our scope, as I shown in the video also.
So do you routinely advocate this?
Routinely we don't do, but it can be done in difficult cases. Yes.
Okay. So what will be the mouth opening for it required?
More than 1.5 centimeter.
Okay, sir. So another question to you is cost of video laryngoscope and its availability.
It is available with me. It is available with me, and I will WhatsApp you all the details. The cost is almost 1/10 of available in the market, whatever is available routinely in the market.
Okay. So we need to, one more question. We need to adjust 12 o'clock position every time we use it as we take out the camera for cleaning. Is there any solution for that?
Yes, we put in the camera and just fix it there with a Fevikwik, and you don't need to take it out all the time. Let's let it be there. Let the camera be there. It will add to the camera life.
Okay. So another, can you explain to us the troubleshootings in video laryngoscope?
Yes, ma'am. That is, I think it is already done with the videos. Rest, anyone is always welcome to WhatsApp me anytime. I will guide them.
Okay. So, and yes, sir.
Please have my mobile number 94272205568.
Thank you, sir. We'll make a note of it. So what is the learning scope of using a task scope?
15 to 20 successful intubations with task scope, and we are through.
Okay. So what will be the future of video laryngoscope? Whether will it replace the conventional laryngoscope, and what are the limitations of task scope?
I believe all intubations should be done with video laryngoscopes, because if we are familiar with it, as you said, the learning curve, if we are aware with the using it, then only we can do it, use it in difficult scenario. The limitation of task scope is zero mouth opening. If the mouth opening is not there, we cannot insert task scope.
Okay, sir. And whether will it replace the conventional laryngoscope in future?
That only time will tell, ma'am.
Okay. So there's another question. Recently, we have faced a problem with video laryngoscope. We were unable to manipulate bougie. It was going into the esophagus. How do we manipulate the bougie? Is the question.
Yeah, we have to shape the bougie according to the curvature of task scope so that it goes forward. If the bougie is straight, it is likely to go towards posteriorly towards esophagus. So the bougie has to be given a shape, the curvature. And we are advocating the Talwarkar bougie, which are available with the anesthetics company, which tends to reach. So with that, if we give curvature to the bougie, it is likely that it will go in the direction of larynx itself.
Okay. Thank you, sir. Please share your mobile number again on the chat box. Thank you.
Yes, ma'am.
Thank you, ma'am.
Thank you.
Thank you, Safia ma'am, for chairing the session. And thank you, sir, for the wonderful presentation.
Moving on to the next session on our experience prone position LMA and intubation, I now invite the chairperson for the session, Dr. Rajesh Mane. Dr. Rajesh Mane is a professor and HOD of anesthesiology in Jawaharlal Nehru Medical College, Kelly Academy of Higher Education and Research, Belagavi. He holds a fellowship in respiratory care. He is a secretary of ISA Belagavi City Branch, member of Department of Medical Education, member Brain Death Organ Transplant Committee, and member Board of Study, Belagavi. He has numerous publications in Indian Journal of Anesthesia, Journal of Anesthesia and Clinical Pharmacology, Saudi Journal of Anesthesia, and has also been a faculty speaker at state and national ISA conference, has presented many papers and papers in state conference and international conferences. I now request Dr. Rajesh Mane, sir, to welcome our speaker, Dr. Namazi.
Thank you, ma'am. Good afternoon, everyone. First of all, I would like to thank the organizing committee, Dr. Kalpana Kulkarni and the team for the invitation and also the opportunity given to me to chair the session. I'd like to congratulate the organizing team for organizing such an excellent CMA program. Though the theme chosen, though is a common one, it requires to be held quite often. It needs to be told to every postgraduate, fresh postgraduate student. But also there's a lot of development in this field and innovation as far as techniques and gadgets which one needs to be aware of. The topic chosen for this talk today is an interesting one. though we have read it in literature, it is quite helpful to hear it from Dr. Namazi, who has a vast and excellent experience in this field. Without any delay, I'd like to introduce Dr. Namazi. So I welcome Dr. Namazi to deliver the talk on prone position, LMA and intubation, his experiences. Over to you, Dr. Namazi.
Thank you very much, Chairperson. Today, good afternoon. At outset, I am very thankful to Chairperson for a nice introduction. Today's topic is tracheal intubation in prone position. Tracheal intubation in prone position is not easily done in routine anesthesia practice. However, when anesthesiologist is exposed to a situation where he cannot give the position to the patient in supine position for intubation, and he cannot secure the airway unless he has been trained for intubation in prone position. Here we use the fiber optic bronchoscope, preloaded endotracheal tube. Now we're going in and see the carina. Once you see the carina, you can push the endotracheal tube. Good afternoon. At outset, I am very thankful to Chairperson for a nice introduction. ETT fixation done and attached to the vein circuit, surgery being carried, again confirm auscultation, it is CO2. At the end of the good afternoon. At outset, I am very thankful to Chairperson for a nice introduction. Today's topic is tracheal intubation in prone position. Tracheal intubation in prone position is not easily done in routine anesthesia practice. However, when anesthesiologist is exposed to a situation where he cannot give the position to the patient in supine position for intubation, and he cannot secure the airway unless he has been trained for intubation in prone position. Today my presentation is to demonstrate or train the delegates how to intubate patient in prone position. When you utter the word intubation prone position, usually persons are scared because of they cannot achieve the ventilation oxygen in prone position. Now I will show some of the pictures. Here the patient has a neck abscess and he cannot extend or flex his neck. Second, here is where the blade knife has impaled in thoracolumbar region, and surgeon asks anesthetist not to move the patient for an inch. If patient is moved, the spinal cord will be cut. Hence, the anesthesiologist has been requested to give anesthesia or intubate the patient in prone position. Secondly, third picture is the same, where we cannot give a intubation because he has got knife now in the neck. This picture I want to show because when the routine surgery is going on, after a conventional method of intubation in supine position, turn the patient into prone position, then accidentally extubation occurred. How will you going to secure the airway? So to secure the airway, there are method of tracheal intubation prone. Either you can go oral direct laryngoscopy, blind nasal intubation, or fiber optic bronchoscope. You can use the supraglottic devices like a Supreme LMA, IGL, or intubating LMA. Video laryngoscope, there are video laryngoscope, A-track and pentops. These are the indication we will talk about our tracheal intubation in prone position. Now, for last 2 to 3 decades, there are many equipments have been added to our armamentarium of anesthesia. So we have got supraglottic devices by Archie Brain. Then we have got video laryngoscope. We have got fiber optic. So all these equipments help us. We can intubate the patient in prone position. Direct laryngoscopy, which is for last 70 years, I have achieved anchor sheet in anesthesia practice. But with help of direct laryngoscopy, intubation in prone position becomes difficult because it's difficult to achieve the position. All the 3 axes is difficult to come in one line. Because of a limited time, is very difficult to intubate the patient in prone position. We can try the blind nasal intubation if you are already expert in doing blind nasal intubation. Similarly, the fiber optic gold standard, but also requires skill for intubating the patient with the help of the fiber optic. The supraglottic devices have got a good place in intubation in prone position. Especially, we can use the Supreme LMA, or you can use the IGL, or you can use the intubating LMA. See how to prepare the patient for procedure. Patient asked to take a comfortable prone position, IV line taken, secured, pre-medication given. Monitor attached to the patient's back, bolster is passed under the chest and pelvis to make abdominal movements free. Face is turned on the operator side. Pre-oxygen is done according to standard protocol. Induce the propofol. Proper size of LMA is inserted once adequate depth of anesthesia achieved. Cuff ILM is adequately inflated and leak checked. Technique for prone intubation. ILM passed through the mouth and secured and connected to the brain circuit workstation. Ventilation check and confirm with ATCO2. Then you can give succinylcholine choline. After this procedure, when you secured airway, then only you can give succinylcholine choline as per the dose 1 to 2 milligram per kg. Then you use the bronchoplex or fiber optic bronchoplex preloaded with the ETT with the continuous oxygen insufficient through its oxygen port. Then is passed the cable of the bronchoscope or fiber optic passed through the ventilating port of the ILMA while visualizing vocal cords and carina. Once you visualize the carina, you can push the endotracheal tube inside, and then you can take out the ILMA and connect to the brain circuit. How to learn the stages are followed in the technique of tip. Learn insertion, removal of technique ILMA in the supine position on a mannequin first, then go for a patient. Then you acquire a skill of inserting LMA in prone position on the mannequin, followed by ILMA insertion in patient in prone position for minor surgery. Mannequin study, pass ILMA in prone position, then pass bronchoflex cable preloaded the ETT through ILMA. Identify vocal cords, carina and vision, push the ETT tube to carina and then connect to the brain circuit. So these are some of the mannequin study. Here is the patient in prone position. Already all precaution for mannequin. Then we pass the ILM over here. Insertion is very easy. And once you are cue the airway and confirmed by bag ventilation, then you can pass the cable of the fiber optic in figure 2, preloaded ETT. When you see the carina, then you can push the endotracheal tube inside. Now, this is a picture for study in mannequin. If the patient is given prone position, so now because it is a mannequin, we just pass the intubating LMA and inflate the bulb, maybe 30, 40 according to the size of the LMA. Then confirm that airway is secured by using a bag mask. You can see the chest is, you can see the chest movement. You can see the chest movement very nicely. Then you can pass the endotracheal ETT through the port of the intubating LMA. You can follow the instruction given by Professor Alok Smartna in the morning session. So when you confirm that the ventilation is being done, then you can remove the intubating element with the help of the stabilizing rod. Now stabilizer rod fixed in the endotracheal tube. Then push with the other left hand and you take out the intubating LMA after deflating the cuff of the intubating LMA. So now taking out the LMA, just pushing the stabilizing rod. But hold the ETT properly. Take out the stabilizing rod, take out the intubating LMA. Attach the connector to endotracheal tube. Again check with the bag and mask. Bag, you can see the chest is moving. That means your intubation in prone position you achieved successfully. Now I will show some of the cases which I have done. There are three steps of the case I've seen. On the neck abscess, I pass the intubating LMA in prone position. Surgery is IND and debridement. So here we have taken all the precautions. We started IV line. We have put the monitor on the back and given pre-medication. Then injected propofol and passed the intubating LMA. And then we allowed the surgeon to do IND and debridement after confirming that the ventilation is proper. Now there are these two cases here. We are also showing how to intubate the patient. Here the pre-oxygen is done for 3 to 5 minutes as usual method. Then pass the intubating LMA after giving a propofol and patient adequately under. I have not given at this stage any muscle relaxation. I pass the intubating LMA in this case and now inflating the cuff of the intubating LMA and then check this one, ventilation and oxygenation. Then inserting the intubating LMA, inserting the endotracheal tube through the port of the ILMA, passing the endotracheal tube inside the intubating LMA. Once ETT is inside, then you remove the intubating LMA. Again the same method by using a stabilizing rod, pushing the stabilizer rod and taking out the intubating LMA, taking care the ETT should not come along with the intubating LMA. Now the healthy endotracheal tube, take out the intubating LMA, then endotracheal fixation done. ETT fixation done. and attached to the brain circuit, surgery being carried, again confirm auscultation and ETCO2. At the end of the surgery, again we have done extubation in prone only. I have not followed the your conventional method of turning the patient into supine position, then give reversal and take extubate the patient. Here we have extubated in prone position. The advantage is that the tongue falls forward, secretion being drained, but after adequate reversal, then only you can take out the tube. Now, we confirm the patient has come out, and then I have taken out the endotracheal tube. Here is the case where we have passed the endotracheal tube blindly through the intubating element. Now the last case I will show that we have passed the intubating element under vision. So a tumor on the back, again the same method is followed, pre-oxygenation, given IV propofol, adequately taken under, and we have attached all the monitor as usual, given pre-medication, everything. Then pass the intubating element. And pass the intubating element and inflated the bulb. These are my PG students and who are very anxious to help me. So that so many hands are you can see in this picture. Now again we confirm that it is ventilating properly with the help of auscultation as well as the ETCO2. Now you can see the cable of the bronchosa or bronchoplex preloaded with the endotracheal tube. This is a bronchoplex we are using. So already you pass the cable and observing on the screen. Once you see this is the epiglottis. Now pass the tube, push the cable inside. You can see the carina. Once you see the carina, again we push the endotracheal tube inside. After this, we have taken out the intubating element, and ETT, endotracheal tube, is attached to the brain circuit and surgery carrier. At the end of the surgery, again we have done extubation in prone position. We found very easy as compared to our conventional method of turning the patient on the supine, given then reversal and all those things. We advantage that tongue is fall forward, secretion being drained. So I think it is much better as compared to our conventional method of turning the patient to the supine, then doing reversal and taking out. Here, this is the case, the last case, where we have used the agile instead of intubating element. I think we found more better than our intubating element. Here pre-oxygen being given as usual monitors attached, IV line started, pre-medication is given, and injection propofol being given. When the patient is adequately under, we pass the agile instead of passing the intubating element. The advantage here of that, we have not to inflate the bulb or cuff as in case of we do in intubating element, then attach circuit and ventilate the patient. See the patient has got abscess over the neck. We confirm that the IGL is working properly with the ultra auscultation. Here we have used the fiber optic bronchoscope, preloaded the endotracheal tube. Now we're going inside and see the carina. Once you see the carina, you can push the endotracheal tube. And when monitoring the case also, see what is direct advantage of tracheal intubation in prone position? Induction instant time is very less cervical movement, less manpower required for changing the position, no interruption in monitoring the patient as it does not require to change the chest lead as it happens from supine to prone to supine position. So unfortunately, if tracheal intubation fails, then what to do? You always keep the trolley should be always kept ready for all the TPP. In event of failure of tracheal intubation prone position, reinsertion and proper placement of SAD supraocular device be tried. Attempt of TP should be abandoned if SpO2 falls below 90%. Patient should be turned supine, oxygenated, and follow the conventional method of intubation. So these are the very references are there. They are done routine intubation in prone position also. Aloka Samantre has put the tracheal intubation in prone position with an intubating lateral mask following the posterior spine impaled in knife injury. I have shown this picture in earlier. So we have obtained all the appropriate patients' consent forms in the form of patient has given the consent for his images and other clinical information to be shared in this presentation. So this is the prone CPR. Unfortunately, if cardiac arrest occurred, how do you have to follow the prone CPR? This is a method which has shown the patient provide the sternal support, sandbag or bag, saline. Location is defibrillated, posterior on the apical side, and anterior, and one more is on the back of the patient. And you can do the two hands together, location compression, two hands together over the T7 at the level of inferior border of scapula, two hands, one hand on other side of supine, say at the above level. So thank you very much for listening. So my talk. So only the last time my problem of whether this intubation in prone position, which is being easily done in emergency, can be applied in a routine also. Is it possible? I think it's possible. Only when you can get adequately trained on a mannequin, and you try the simple cases in prone position, then you can go ahead for the surgery which is being done in prone position. Thank you very much. Good afternoon. At outside, I am very much thankful to chairperson for a nice.
Thank you, Rajesh sir and Namazi sir, for a very informative lecture. We now take up the questions. Over to you, sir.
Hello. Hello. Can you hear me?
Sir. Hello.
Yeah, can you hear me?
Yeah.
Yeah, there's some questions in the chat box.
Yeah.
Which I'd like to ask you. Any obese patients who require any airway securement in prone position? Any different approach, or what you suggest?
No. Actually, it is very beneficial for obese patient also, because obese patient required in conventional method from supine to prone required many person, and we have to be very careful about the neck movements and all those things. We can carry more easily for obese patient by seeing that the abdomen and chest is adequately given a pillow below it.
Okay.
And airway also.
Okay.
We can introduce this one ILMA very easily as compared.
What about any muscle relaxation can be given if you anticipate any difficult intubation in prone position?
What is it?
Any muscle relaxation can be given.
No, I see what I usually follow. Without giving muscle relaxant, we take adequately patient under and pass the intubating LMA. And when you are sure that it is functioning properly, then you can give the muscle relaxant and you can pass the endotracheal tube.
Okay. What do you do if there's an accidental extubation in these cases? During the procedure, if
that is what we have to learn. But this technique, you must be prepared to push the SDA, you can push supraglottic devices. You have to learn it, or you may require, suppose the surgery very prolonged, you can intubate the patient. That's the technique we have to learn, and this is the message to the people.
Okay. Among all the LMAs, which one you consider to be easier to insert and airway protection?
Can you repeat the question, sir?
Among all the LMAs, which one is easier to insert and provides better ventilation with airway protection, according to your experience?
Which LMA is easier, according to your experience?
LMA is which?
Which supraglottic airway device is better, easier to insert?
Of course, it is very easier because the curvature of the supraglottic device is according to anatomy of the airway, and so we can pass the supraglottic devices very easily.
Okay. To make it more
I think among these all the three, the IGL is the better one to pass the through the airway, this oral airway in intubation.
Okay. The videos what you had shown, the neck is the head is tilted to one side. Can we just tilt the table so that to make it more comfortable and have more easy access?
In the video shown, the neck is turned towards one side. Can the table itself be tilted to one upwards?
No. See, there are two methods to pass the LMA. Either we can extend laterally, take the patient on the side, one side, or you can gently extend, and you can pass the intubating LMA.
Okay, so it was a nice presentation, which was quite helpful to the young postgraduate students also. So I hand over to the organizing team to see if any other questions are there from your side.
Thank you, sir. Thank you, Namazi, sir. Now we will move on to the next session on our experience of submental intubation. The chairperson for this session is Dr. Sarita Swami. I welcome the next, the chairperson for the next session, Dr. Sarita Swami. She is a professor and HOD, Department of Anesthesiology in Bharatiya Vidyapeeth Medical College, Pune. And she is a postgraduate teacher and examiner since years. She holds a fellowship in chronic pain management in 2010 and established a pain clinic in Bhara Hospital. She is a life member of Indian Society of Anesthesiologists and Academy of Regional Anesthesia, Indian Society of the Study of Pain. She has publications in numerous national and international journals. She has written a chapter in Handbook of Pain Medicine for General Practitioner. She has participated as faculty in state and national conference, participated as a faculty in hands-on training on cadaveric workshop and hands-on training on cadaver peripheral nerve. I now request the chairperson to welcome our speaker, Dr. Sandeep sir.
Good afternoon, all. First of all, I would like to congratulate and thank you to the members of ISA Kolhapur and team of Department of Anesthesia DY Patil Medical College for inviting me as a chairperson. As you all know, submental intubation is the different method of intubation of securing the airway without any additional modern gadgets. So let us hear the experience by Dr. Kadam for managing such cases. Dr. Kadam is an associate professor in DY Patil Medical College, Kolhapur. He is PG teacher in DY Patil University, Kolhapur and director of Apex Pain Clinic, Kolhapur, and stood first in Shivaji University in MD Anesthesia. He is a past honorary secretary and president of ISA Kolhapur. Has numerical publications in national and international journals and also a faculty in Maharashtra state conferences and delivered a lecture in different IMA cities. So I now welcome to Dr. Kadam for we will listen to hear our experience in submental intubation. Over to you, sir.
Good afternoon, everybody. First of all, I would like to thank Honorable Chairperson Dr. Mrs. Swami for her nice introduction. Well, since morning, we have seen various stalwarts in airway management who have dealt in various topics of critical airway management. Now we move to an interesting topic of submental intubation. What is submental intubation? Well, the submental route for endotracheal intubation consists of just pulling the free end of the endotracheal tube through the submental incision after the usual orotracheal intubation has been performed. Of course, after removal of the universal connector. So it is so simple as that. When I went through the literature, I found that submental intubation is indicated mainly in facio-maxillary trauma surgery. Almost 81% of the times it is used in this trauma surgery, and then 15% in orthognathic surgery and remaining in cosmetic surgery. So major bulk is facio-maxillary trauma surgery. Now, before going into the details of submental intubation, I would like to see what are the various options available with us as anesthesiologists to manage the airway in these kind of trauma patients. Airway management in patients with facial-maxillary injury is a big challenge, you all know that, because of the distorted upper airway, and as anesthesiologist has to share the upper airway field with the surgeon, it becomes quite cumbersome for us also. And we don't like to share, you know that. So the various options which are available with the airway management in the patients of facial-maxillary surgeries, trauma surgeries, vary from simple orotracheal intubation, the usual orotracheal intubation, to tracheostomy with nasotracheal intubation, retromolar and submental intubation in between. Tracheostomy has been gold standard for the management of airway in facial-maxillary surgeries for years together. So if we go through the flow chart over here, we can see there are certain subset of patients which have to be maintained, or in those cases we have to go for tracheostomy. There are some subset of patients we can manage with simple oral or nasal intubation, and a few we go for submental intubation. So the group of patients, for example, a patient of polytrauma having neurological or pulmonary deficits in the form of poor GCS, then patient is hypoxic and so on, and we anticipate that this patient will land up with prolonged mechanical ventilation. In all such cases, or even with upper airway obstruction or laryngeal injuries for that matter, or limited mouth opening, or there is contraindication for nasal intubation, all these patients we have to go for tracheostomy. So there's no option for that. Then a case of simple mandibular fracture can be managed with oral intubation or nasal intubation. But there is a subset of patients wherein this is not feasible anatomically, or it risks further injury. For example, fracture with the base of skull, and if we try to intubate nasally, that is going to risk further. And other patients wherein the endotracheal tube itself in the oral cavity can come in the way of the surgical procedure. So this subset can be managed with submental intubation, and we can avoid the tracheostomy in these patients. So the choice of intubation technique requires good assessment and cooperation from the interdisciplinary team that includes maxillofacial surgeon and we anesthesiologists. So now quickly I'll go through the various options which which we have seen in the previous slide, and I'll try to see what are the I'll quickly go through these options. So first option is orotracheal intubation. As I have mentioned earlier, isolated mandibular fracture can be managed very well with orotracheal intubation or nasotracheal intubation. But this technique may not be appropriate in other facial-maxillary injuries, as it may interfere with the surgical access. Okay, because many a time the surgeon needs to check the alignment of intubation has its own contraindications. Fractures of nasal bones, skull base fracture, or patients having CSF rhinorrhea, this can lead to the passage of the tube directly into the cranium. It can risk for meningitis or sepsis, or while putting the tube, it can lead to epistaxis, dislodgement of the bone fragments by the ETT, and of course, post-operatively, these patients do have sinusitis as well. So if oral and nasal intubation is not possible or is contraindicated, then what are the other options? Well, this option of retromolar intubation, this is non-invasive, okay? This is nothing difficult in this, just we have to give the general anesthesia, put the orotracheal tube as usual, and push the tube in the retromolar space. What is retromolar space? In this figure, you can see that retromolar space is the space just behind the molars and in front of ramus of mandible. And here the tube is pushed, then fixed with a metal wire which the dentist or the facial-maxillary surgeons use for the fixation of the interdental wiring. That can be used for fixation of this tube over there, or you have to take a stitch at this point and fix the tube. Now the prerequisite for this type of intubation is to have an adequate space in the retromolar area. And if the space is inadequate, it will be a limitation for this retromolar intubation. So what are the limitations? Retromolar space may be inadequate in many patients. So there are suggestions in the literature stating you can go for smaller endotracheal tube, or you can go for a invasive procedure such as molar extraction and doing a wedge osteotomy and creating a space. But this is quite invasive and it's time consuming. An endotracheal tube itself can interfere with the surgical field even if it is placed in the retromolar space. That is the other limitation. And a word of caution for this procedure is we have to vigilantly monitor the peak airway pressures, as it's of paramount importance, because as the endotracheal tube can get compressed, particularly during the temporary dental occlusion. Okay, then. But lucky for us is that is retromolar intubation is quite easy in children as they have good space. So we can go with this type of intubation in children. Now coming to the tracheostomy. Tracheostomy has been gold standard for the management of airway in facial-maxillary surgeries. Elective short-term tracheostomy is conventional and time-tested method for airway access in these patients. But this procedure can be difficult, you all know it can be difficult in obese patients, children, or patients with having some sort of swelling in the neck like thyroid swelling. And it is not devoid of any complications. It is associated with many immediate and late complications which can range in the percentage of 6 to 8 to 60%. And the complications may be hemorrhage, surgical emphysema, pneumothorax, pneumomediastinum, nerve injuries, or delayed such as infections of the stoma and respiratory tract infection, blockage of the tubes, then tracheal stenosis, fistulas, and of course a visible scar on the neck. So these are all complications which can be possible with tracheostomy, and we have to be aware of those. So again, coming to the same flow diagram, I can say tracheostomy indications are definitive. For oral and nasal, there are definitive indications. And if oral and nasal intubation, there are some difficulties with this type of choice. And if you want to avoid tracheostomy, we have this median path, that is submental intubation. So what is submental intubation? Now we come to the proper topic. The submental route for endotracheal intubation consists of pulling the free end of the endotracheal tube after removal of the universal connector through the submental incision after usual orotracheal intubation has been performed. It is as simple as that. If you go into the history of this submental intubation, it is quite old. Way back in 1986, this gentleman, Dr. Francisco Altemir, a Spanish facial-maxillary surgeon, came up with the idea of submental intubation, and so that he could avoid tracheostomy in patients with panfacial and midfacial fractures. So this idea goes way back to 1986. This technique, of course, provides good secure airway. It provides adequate optimal surgical field, allows maxillomandibular fixation while avoiding the drawbacks and complications of nasotracheal intubation and tracheostomy as well. Before going for the actual technique, we'll try to see what are the things which we pierce, or what is the anatomy, rough anatomy of that area through which we can approach the oral floor of the oral cavity. Well, submental triangle is the triangle just behind your symphysis menti. It is bounded on both sides by anterior biliary of digastric, and the base is formed by the hyoid bone. Floor is formed by the mylohyoid muscle, and then content wise it doesn't contain any important structures as such, but for a few submental lymph nodes and anterior jugular vein. But in this figure you can see the floor of mouth can be approached through this triangle which I have mentioned as submental triangle, but also it can be approached to this second triangle. This is called as the submandibular triangle or the digastric triangle. So what is this submandibular triangle? Submandibular triangle is just lateral, or this is the median triangle which is called as the submental triangle, and this is the triangle which is called as the digastric triangle or the submandibular triangle. It is bounded by the anterior biliary of digastric, posterior biliary of digastric behind, and superiorly by the inferior border of the mandible. And if you see the floor, The floor is formed by the same muscle, mylohyoid, which forms the floor of the submental triangle. Same muscle forms the floor of the submandibular triangle anteriorly, and the hyoglossus muscle posteriorly. Hyoglossus muscle posteriorly. So this is the submandibular triangle. So we can approach the floor of the mouth through the submental triangle as well as the submandibular triangle. Now, precisely in this figure, you can see this is the submental triangle. So this is the median approach to the floor of mouth, and this is the triangle. This whole triangle is the submandibular triangle. This is further divided into two parts, just in front of the facial artery for matter. This anterior part is the anterior part of the submandibular triangle. From there also you can approach the floor of mouth, and this is the posterior part of the submandibular triangle. So at the level of second and third molar, you can approach the floor of mouth, and at this level you can approach at the level of canine and the first premolar. So these three approaches are available for us to approach the floor of mouth intraorally. Now coming to the actual surgical technique of submandibular intubation. Well, informed consent is taken. We examine the patient, preoperative assessment, everything is same for all surgeries. Similarly, we do everything, assess the patient, we take an informed consent, and the patient is taken to the theater. Necessary monitoring is attached, and then pre-medication is given, IV lines is started, and then we go for general anesthesia as usual, whatever technique you are well versed with, and we put the endotracheal tube. Okay. Then once endotracheal tube has been put here, then we extend the head a bit, put a ring under the head, and then we mark the area with a marking pen, so as to whether you are going for a median incision or you can see this is the paramedian incision of the anterior part of the submandibular triangle. You mark that point. Proper sterility technique has to be taken. You have to wash your hands properly. Proper donning has to be done. Gloves has to be worn, and then prepare the part with betadine and then with spirit. Properly drape that thing, and then go for proper surgical technique of submental intubation. So you have marked the point. Then the first thing is you infiltrate that area properly with xylocaine with adrenaline. This helps to decrease the oozing in that area. So once you have infiltrated that, then you take an incision here. Around 1.5 to 2 centimeter incision is good enough for the easy passage of endotracheal tube of 7.5 to 8 mm. Okay. Now you'll ask which incision is preferred, right or left paramedian. That will depend upon its easy choice. If the fractures are on left side, you can go for the right sided incision, and vice versa can be done. Now, the second step is just you have to go for blunt dissection and creating a tunnel from the skin over here in the submental area to the floor of mouth. Okay. So with the blunt forceps, artery forceps, you just separate the soft tissue over there, and then you, with the point, you go just flushing. This is the important point. Go as close as to the lingual surface of the mandible, and with the left finger over here, you just keep a watch on where the tip of this artery forceps is peeping into the oral cavity. So you have to guide the tip of the artery forceps with your left finger, the index finger which have been put inside the oral cavity, and remain as flush to the lingual surface of the mandible. So in this figure you can see we have put the artery forceps right inside. You are using a retractor to retract the tongue away from the point where the artery forceps is peeping inside. Then you see the tip over here entering the oral cavity. Here you can take an incision with the blade, or you can just poke the artery forceps inside and then separate the tissues over there. So we go through the skin, we have incised, then we go through the subcutaneous tissue, platysma, deep layer, cervical fascia, mylohyoid muscle, then sublingual mucosa, and then enter the oral cavity. Okay. Now the second important point is, the first was remain as flush to the lingual surface. Second important point is take adequate time for creating the tunnel. Just don't poke inside and try to hold the tube and then try to pull it. Give adequate time for separation of the tissues, create adequate space. You can put another artery forceps from the lingual surface intraorally and try to create a space. So create an adequate space with adequate time. So spend adequate time in that, because that will ease your further step of pulling the tube outside from this area. So take adequate time. So clinical pearl I'll say here says remain flush to the lingual surface of the mandible to avoid injuries to the important structures. I'll be talking what important structures are those. So remain flush to the lingual surface of the mandible during the blunt dissection to avoid injuries to the salivary ducts and the lingual nerve and the blood vessels as well. Now coming to the next step. So you have created an adequate size tunnel. Then comes the point of bringing the pilot balloon and the actual endotracheal tube free end from this tunnel outside. So first step is whether it should bring the pilot balloon or the free end, it is pilot balloon. Because pulling a pilot balloon after pulling the free end of endotracheal tube becomes very difficult. So first point is exteriorize the pilot balloon from this incision site. You have to be careful because with the artery forceps you can puncture this balloon over here. So you have to hold the tip, actually the tip, not the balloon part, and then slowly pull out the balloon from the incision site. Reintroduce the artery forceps inside. Then with the other hand you have to guide the, before that I'll tell you, before that you have to disconnect it from the circuit, disconnect, remove the universal adapter, and the free end has to be guided with one hand inside from the port tunnel which you have created, so that you can hold with your artery forceps and pull it slowly. You have to be very slow while pulling this, and we have to keep a watch, or you should hold the tube actually so as to avoid sudden pulling of the tube, and even this procedure can lead to extubation. So you have to be vigilant at this point by holding the tubal end with the other hand and pulling the free end of the endotracheal tube slowly. This is only feasible. This procedure will become easy only if you have created an adequate size tunnel. Okay. So free end of endotracheal tube is pulled out after disconnecting the circuit and universal connector is removed. Once you are out and you know that adequate size has been exteriorized from this incision site, you have to reconnect the circuit, inflate the balloon, and then check the air entry on both sides, whether it's equal on both sides. Then even you can do laryngoscopy and see that whether you have not pulled the tube outside. Many times there are chances that the tube will be pulled outside. So accidental extubation can occur. So do laryngoscopy, see the tube properly, do suctioning, then if needed put pack, and then if everything is fine, go for the securing the endotracheal tube with the stitch. So in this figure you see the stitch has been put over here. This is the posterior incision from the posterior part of the triangle where the floor has been approached, and this is the anterior part from the submandibular triangle where from the floor where the intraoral floor has been approached. So this is the figure. In this figure you can see actually the endotracheal tube in the larynx, then crossing the tongue and coming out of the submental area outside. Then coming to the extubation part. Well, at the end of the surgery, the surgeon removes the intermaxillary fixation, removes the fixation wires, and then we remove the stitches over here. The fixation ligature for the tube is opened, and then the tube is disconnected from the circuit, universal connector is removed, and the tube is pulled back into the oral cavity and reconnected to the anesthesia machine. And then we take the stitches over here. The mucosal surface inside the mouth, they need not be sutured. They heal without even suturing them. So in short, you can say this is the site mark, infiltrated with xylocaine adrenaline, incision is taken, blunt dissection is done. This is the peeping artery forceps in the oral cavity. Then first the pilot balloon is removed, exteriorized, and then the tube is exteriorized, and at the end we fix with the sutures. Now, second clinical pearl. So first clinical pearl was remain as flush to the lingual surface and avoid injuries to the submandibular duct, sublingual duct, or even the lingual nerve. Second pearl is, now, which endotracheal tube you are going to use for this. It is metal reinforced endotracheal tube. Of course, this tube will be preferred because due to its ability to maintain lumen patency. So at the acute angle at which the tube comes out from the segmental area, chances that the usual polyvalent tube will bend over here. So to avoid that, we have to use metal reinforced tube. Now the problem with this tube is the universal connector which is connected to this tube is almost fixed. It is not that easy to dismantle this universal connector from the tube. So even before giving general anesthesia, we have to see that we have to make sure that the universal connector is removed, could be easily removed. So you may need an artery forceps or a mosquito forceps to dilate this end of the endotracheal tube over this connector and make it loose, and then bring out the connector and again fit it and see whether it fits properly. So this prerequisite, this thing we have to check before even giving general anesthesia, because if you don't check that and you go for endotracheal orotracheal intubation, and at that moment if you try to dismantle that thing, it is impossible, I'll tell you. So we have to keep that in mind, that before giving general anesthesia we have to watch this. Or a simple option, rather than using the tube which I mentioned earlier, you can go for this wire reinforced silicon endotracheal tube, which is available with the intubating LMA. If you have that, it is good enough. You can dismantle this part easily. Okay, but it is not available with everybody. So we have to go for that armor tube earlier, which I have shown. So then in this figure, you can see the importance of going flush to the lingual surface is you can avoid injuries to this ducts over here and even the vessels here and the lingual nerve which is flush to the submandibular duct also. So you remain with the flush to the lingual surface. So what are the contraindications for submental intubation? Well, of course, patient refusal. Then laryngotracheal disruption, then long-term airway maintenance is required in patient, or post-operative ventilation is required. All these go for the indication. We have to go for tracheostomy. Then gunshot injuries to the maxillofacial region. If the patient has undergone tumor ablation, so the scarring is there, the radiation, after radiation, it becomes difficult. History of keloid formation, actually this is a relative contraindication. And of course, patient with limited mouth opening and comminuted mandibular fractures, you may go for other options such as nasal intubation as well. What are the advantages? Well, it has very small learning curve, I'll tell you. It's easy to perform. In many institutes, I have seen that the physiomaxillary surgeons do this procedure. But in our institute, we anesthetists do this. And I'll tell you, if I can do it, everybody will do it easily. So, advantage is easy to perform. Unlike tracheostomy, no specialized post-op care is required. It allows dental occlusion. It is an aesthetic scar because it hides just, it comes beneath the chin over here. So scar is quite aesthetic. And it's, of course, if compared with tracheostomy, it is quite cost effective and avoids all complications of tracheostomy. But it does have disadvantages also. Suctioning is quite difficult because of the acute angle here. You cannot put a suction tube inside the thing and then go if you want to do suctioning from the trachea and bronchi over there. So suctioning becomes difficult. Then while pulling the pilot balloon or the free end of the endotracheal tube, you can damage the pilot balloon and the endotracheal tube itself. And if the surgeon says he wants to re-explore or there are repeated surgeries, this technique may not be feasible. It does have complications that can be immediate or late. So bleeding is one of the complications, but if infiltration and proper technique, bleeding is not much of problem here. Desaturation. Desaturation, now this can occur when it can occur. Of course, when you dismantle from the circuit and you take more time while pulling the free end from the incision over here. Desaturation can occur. So how can I avoid that? The thing what we do for pre-oxygenation, we can give 100% oxygen with adequate amount of isoflurane or sevoflurane once you start this incision. So you maintain adequate depth of anesthesia with the inhalation agent and give 100% oxygen so as to create an adequate oxygen reserve. So functional reserve capacity is completely saturated with oxygen. So you can avoid desaturation while doing that. Another thing is give adequate time for dilatation. So the ease with which the free end will come out will be in a short period of time. Then accidental extubation can occur if you just pull it out with a big thrust. So that has to be avoided. With the other hand, you have keep a control on the exterioration of the tube. Endobronchial intubation can occur. Okay. Late complications, infection at the floor of the mouth, infection submental wound. If you don't do properly, you may injure the salivary duct and create a salivary fistula. Then development of mucocele and facial scarring can occur. There are n number of modifications from the original technique which I have told, that is incision, blunt dissection with the artery forceps, and then bringing out the tube. Especially the double tube technique. This technique was described in 1996 by Green and Moore, especially in situation when the universal connector cannot be disconnected from the armor tube. So what these gentlemen do that time? They came up with an idea wherein conventional oral tracheal intubation is done. Okay. Then incision is taken and other tube is pushed in the oral cavity in the retrograde manner. So push it in the retrograde manner, push it till the oropharynx, then do laryngoscopy, remove the first tube and then guide the second tube inside. So that was the technique what they did. There are modifications that also. Now people have, this gentleman came with the idea of using a tube exchanger for that. There is a paper where it states use fiber optic gyroscope for that. There are various techniques used for the dilatation. Instead of artery forceps, people have used blue rhino. Seldinger technique with tracheostomy kit has been used. Then the free end of the tube is covered with a blue cover of thoracic tube and finger blow to avoid blood and blood clots getting clogged inside while pulling it out. Now there is an interesting paper where laparoscopic trocar has been used to create a tunnel. And RAE tube, the people have used, but it is kinkable. You all know that. So this is the Seldinger technique. This is the nasal speculum being used for dilatation. So these are the references wherein modified techniques have been used by many people. Then coming to the scar, well, it can be inconspicuous as in this case, or it can be a bit hypertrophied as well. So in short, one slide, this slide explains the indications, limitations, advantages, disadvantages and complications, what I have explained earlier. So to summarize, submental intubation technique provides a secure airway, provides optimal surgical field, allows maxillomandibular fixation while avoiding the drawbacks and complications of nasotracheal intubation and tracheostomy. Thank you.
Thank you, Dr. Sandeep and Dr. Sarita, for sharing the experience of submental intubation. Now let's take up the questions. Over to you, Sarita ma'am.
Thank you, Dr. Kadam sir, for sharing your experience in excellent manner. Actually, before going to questions in chat box, I would like to ask you one question. That is, what do you think? Which is the superior method of intubation, retrograde or submental?
Retrograde or submental?
Sorry, retromolar or submental?
Well, if it is feasible, if the patient has, in the presentation I have showed in a slide, if the patient has adequate space in the retromolar area, we can go for that technique. And then there are modifications suggested by people, use of small, if the space is small, go for a smaller size endotracheal tube, or invasive methods have been suggested. But I feel instead of going for invasive method of removing the molar or creating a wedge osteotomy and then creating a space, and it's not needed to be so much of invasive thing over there. Then if you have the space is inadequate in the retromolar space, you can go for submental intubation will be a preferred technique. And of course, in children, you can go for retromolar where the space is adequate.
Yes, and important is it is as we notice that submental is more easier. It is not so difficult to perform this too.
Yeah, it's quite easy.
If space is not available, we have to remove the third molar in retromolar. All these are very invasive procedure. So there are few questions in chat box, but one more question I would like to ask you.
Okay.
While tunneling this and tube through the incision, would you like to advise some oxygenation method to the patient if patient has any high risk or cardiac diseases or anything?
Well, I have told in my presentation wherein I said ki once you similar to the pre-oxygenation what we do before induction of anesthesia. Here we have an option. Once you start taking the incision, you can go off for a 100% oxygenation with adequate concentration of the inhalation agent. So we pre-oxygenate during the actual procedure, that is right from the incision and then dilatation. And so patient is adequately oxygenated. He has adequate reserves, functional cell capacity is fully full with oxygen. And then the time required to exteriorize can be reduced by giving adequate time for creating an adequate size tunnel. So the pulling of the tube will be quick. So these two options are there. Another option can be we can use a air tree where we can put a people have come with modifications wherein they have retrogradely put the air tree cannula where we can put inside the tube there, and then we can pull the tube outside from there. But it's quite time consuming and it's a very tedious job.
Yes, sir. Sir, there are a few questions in chat box. I want to ask, what are the complications you can encounter after prolonged ventilation with submental intubation?
Well, in literature, they have said that we can keep for 2 to 3 days or something, but we don't keep that long. It is just for the surgery, and after the surgery, we just shift to the oral thing and we remove. So we have no experience of keeping it for prolonged time. If it is actually required as a prolonged ventilation post-op and all, it's better to go for tracheostomy than going for a submental intubation.
One interesting question is there, sir. Whether you encountered any difficulty during extubation from submental intubation?
Well, extubation, I have not encountered any such kind of complication. Encountered such thing like difficult extubation. That is just pulling the tube inside the oral cavity from the exteriorized point. That is the question, na?
Yes.
So if you have created adequate size tunnel, it's quite easy to bring it back into the oral cavity.
Sometimes I think, sir, cuff gets stuck up. And
so
then,
thing is, again, you have to deflate the cuff and then try to pull it out.
Sir, one more question is there. Are you advocate any use of airway blocks for this submental?
Don't go for awake submolar. We don't have that experience, so I don't know what will be the thing. Okay. So it's better to give general anesthesia and go for submental intubation.
Sir, one question I would like to ask you: can you add some more indications other than fracture of facial bones or any?
Well, orthodontic surgeries and cosmetic surgeries, they have been done with this type of intubation, submental intubation.
And also, sir, I would like to add for this, even sometimes surgeon need nasal and oral passages are also to repair some postcranial mories and all. At that time also we need...
Yeah, base of the skull surgeries also.
Yes.
Yeah.
So repair of congenital malformation of skull base and all, they use the submental intubation. So excellent presentation, sir. And I enjoyed your session a lot. And excellent webinar arranged by Kolhapur City. I would like to thank everyone once again and over to the organizers.
Okay. Thank you, madam.
Okay.
Thank you, sir and ma'am. We shall now take a break and resume this virtual CME at 3 p.m.
Hello. Hello. Hello.
Good afternoon, everybody. Welcome back to the afternoon session of the CME. We'll be starting sharp at 3 p.m.
Hello. Hello.
Hello. Hello, sir.
Yeah, Dr. Dulked here.
We'll begin. I once again welcome you all. Now let's begin with our next session on fiber optic intubation. For this, I would like to invite our chairperson, Dr. Vittal Dulked. He has more than 30 years of teaching experience in the field of anesthesia, and he also has more than 10 years of experience in cardiac anesthesia in KLES Heart Foundation and Hospital, Belgaum, Karnataka. Sir has special interest in the fields of difficult airway, cardiac anesthesia, physical principles of anesthesia, and innovative techniques in pediatric anesthesia. He has more than 31 international and 23 national publications to his credit. I would like to, sir, to take over.
Yeah, I'm professor and HOD, Department of Anesthesia, KIMS, DU Karad. Yeah, I would like to introduce Professor Apesh Patwa, Institute of Neurological Sciences, Vadodara, and is a chief consultant at Kailash Cancer Hospital and Research Center, Godhra, and Baroda Laparoscopic Center. He is executive committee member of All India Difficult Airway Association. He is director, International Airway Management Society, and president of ISA, Indian Society of Anesthesiologists, Vadodara City Branch. He is a scientific committee chairman, Association of Practicing Anesthesiologists, Vadodara. He is a very eminent speaker, and we know him. Many people would have already heard him speaking very nicely on this topic. I welcome Dr. Apesh Patwa to present his talk on this very important topic of fiber optic intubation. I would like to say a few words. That is the fourth National Audit Project, NAP4 of Royal College of Anesthetists have concluded recently in 2011 that most of the airway factors in airway complications are poor judgment, poor choice of equipment, poor education, and poor training. So here is a very important aspect of this difficult airway management, that is fiber optic intubation. And I welcome Dr. Apesh Patwa, and I will hand over the mic to him.
Thank you, sir, for your kind introductions. And it's always pleasure to be here with Team Kolhapur. Thank you, Team Kolhapur, for giving me this platform to deliver a talk on fiber optic intubation. I'll just share my screen. So are you able to see the screen? My slides?
Yes, sir.
Yeah, fine. So my talk is on flexible endoscopic fiber optic intubation, but ideal term to be used is flexible endoscopic intubation, not fiber optic intubation, because there are different type of scope, fiber optic scope as well as video bronchoscope. So if you are doing with just all scope or flexible scope, so ideal term to be used for such intubation is flexible endoscopic intubation. So I am going to talk mainly on troubles and tricks. So we'll discuss the trouble and then we'll discuss how to overcome this trouble. The first trouble, if you are performing flexible endoscopic intubation or say fiber optic intubation, first trouble is patient. Your patient, if you are doing the fiber optic in uncooperative anxious patient, your success rate goes down. So always explain the need of such type of procedure to patient. Take the patient to confidence and then proceed. Make the patient calm and comfortable, and if required, make use of judicial sedations. So which type of troubles we can get during this fiber optic or flexible endoscopic intubation? The first trouble, equipment related troubles, equipment malfunctioning, improper assembly, that I'm not going to touch. Second troubles is problems or troubles related to actual endoscopy. Third, problems related to passage of the endotracheal tube with the fiber optic intubation in this procedure. And fourth trouble, placement of the tube and dislodgement. So we'll discuss this one by one, and we'll sort out we'll discuss the problem first, and then we'll discuss the solution of it. So usually awake fiber optic endoscopy or awake fiber optic intubation is having a 4-step. Step 1, from nose, if you are doing awake nasal, then nose to larynx. Second, from larynx to subglottic area. Third, following curve to carina, means passage through the trachea. And step 4, railroading of the endotracheal tube, means passage of the endotracheal tube. So if you look at the first passage, first step, that is from nose to larynx. So which area we can get troubles? What are the common problems we get? First, suppose there is a narrow passage, we are not able to negotiate the scope. Second, once you are inside the nose or oral cavity, you are not able to identify the proper anatomy. That's another trouble. You can get lost into oral cavity easily, not able to find any structure or not able to find the glottic structure. Excessive bleeding, excessive secretions. These are the common problems we encounter during fiber optic intubation. So how to overcome the first step troubles? So always check the patency of nostril before proceeding for a fiber optic intubation. There are a number of clinical ways. I'm not going to go into detail on the clinical ways. And make use of radiology if it is available. Suppose you are doing head and neck case and chest, head and neck scan is available. Make use of that scan and check the patency of the nose. Then second, always use passage inferior to inferior terminate. See, according to this publication, there are 2 passages. One passage inferior to inferior terminate, and second passage superior to inferior terminate. So this is the inferior terminate. So always use passage inferior to inferior terminate. So to go into this passage, why this passage? Because there are less chances of trauma, there are less chances of transmitting bacterial mucosal flora into the larynx, and it's a wider space compared to passage superior to inferior terminate. So to select the passage inferior to inferior terminate, you need to pass the scope perpendicular to face plane in this direction. This is the right direction. Look at this. This is a very interesting video. As I am approaching towards the oropharynx, so I am passing my scope through the nasopharynx. My scope is flush to the floor of nose, and scope is my scope is perpendicular to face plane. So always keep your scope perpendicular to face plane when you are doing nasal endoscopy or nasal fiber optic intubation. Another way, you can serially dilate the nasal passage by different size of nasopharyngeal airway. But in our practice, we are not using this method to open the nasopharyngeal space. And still you are not able to clear the nasopharyngeal passage, then it's time to change your scope. Use smaller size scope or change the route of the scope. Change the route from nasal to oral. The another common problems encounters during the first step is cannot identify anatomical landmark or lost in the oral cavity because of we are not applying proper our knowledge into a clinical practice, or because of excessive secretions, or because of some technical issues, or because of bleeding. Look at this video. How many of you are able to find out actual anatomical landmark, which is inferior terminate, which is superior terminate, which is oropharynx, where is uvula? So it is necessary to identify the proper space, proper anatomy when you are doing the endoscopy. So if you are doing the nasal endoscopy, nasal fiber optic intubation, so your entry into the nasal passage and mid nasal passage anatomy, endoscopic anatomy, you should be able to know how to identify what are the anatomical landmark and how to identify endoscopic anatomy. Look at this video. Which nostril I am going through? It's difficult to judge by many of us when we are doing the endoscopy, nasal endoscopy or nasal fiber optic intubation. So I'll show you the easier way to identify whether we are doing from the left nostril or whether doing from the right nostril. Suppose So suppose this is patient in front of me, and there is a serrated section. This is left side of the patient. This is right side of the patient. So this one is left. This is inferior terminate. This is middle terminate. This is superior terminate. And this passage is inferior to inferior terminate. If you look at the right passage, this one is inferior, this one is middle, and this one is inferior to inferior terminate passage. Now, if you look at the air passage, this is the bony protuberance of inferior cervical, middle tubular terminate, and superior terminate. And this is a air space which is L-shaped. So whenever you are doing any nasal endoscopy, you will get L shape and on left side. And when you are doing right side, you will get the inverted mirror image of the L. And base of L is at 6 o'clock when you are doing the endoscopy from front of the patient. But when you are doing the endoscopy from head end, what happened? Suppose I am doing the endoscopy from head end. Now, you will get the base of L at 12 o'clock position. And when you are doing from left side, the base of L is towards left. And when you are doing from right side, the base of L is towards right side. Now, suppose you are passing the endoscope into the left nostril. So this is your endoscope. You will get the view of this area as per the perimetry, as per the viewing angle of the endoscope. So when you are doing from the left side, on the left nostril, you will get the huge protuberance of inferior terminate on the left side, and you will get the L-shaped passage and base of the L at the 12 o'clock position on left side. Now, and if you are doing from right side, the base of L is at 12 o'clock position and base of L is towards right if you are doing from the right side. And you will get the huge protuberance of the inferior terminate on the right side. Now, we'll see the video. Look at this video. This is, which side you are doing? Look at, this is the air passage, that is L shape, black shadow. Look at this. This is L shape. And this is the huge protuberance of the inferior terminate, that is on left. So you are doing the scopy from the left nostril. So this is how you should be able to identify the anatomy. Now, suppose in this endoscopy, which side I am entering? You should be able to identify now. Look at this. This is L-shaped air passage, and this is huge protuberance of inferior terminate, which is on right side. So in this case, I am doing the scopy from the right nostril. And now, so I am doing from the, in this video, I am doing from the left. So base of L is at top, and this is air passage of L, which is towards right, and this is inferior terminate towards right. So I am doing the scopy from the right nostril. So this is how you should be able to identify the nasal anatomy. So once you cross to the nasopharynx, you should be able to identify your entry into the oropharynx. So that can be done. One, if you pass your scope perpendicular to face plane from ala of nose to angle of mandible, this length, and if you bend it little bit anteriorly, you are going to get view of epiglottis. So this is the easier way to identify epiglottic structure. Pass the scope perpendicular to face plane from the length ala of nose to angle of mandible or ala of nose to tragus, and you just bend the tip little bit anteriorly, you will get the view of epiglottic or glottic structure. Now, another way to identify your entry into the oropharynx from nasopharynx. See, usually nasopharynx is slit-like structure, and this will gradually convert into oval-shaped horizontal opening. That is your entry into the oropharynx. Look at this video. So I am passing my scope through the slit-like structure. Now it will gradually become wider. Now it's become oval. This is oval-shaped opening. And on the top, you'll get the uvular movement. Look at here. So this is your entry into the oropharynx. And once you are into the oropharynx, you are going to get the view of the glottic structure. So important thing when you are doing the scopy, when the shape of airway is changing from vertical slit to horizontal oval shape opening, and at the top, once you get over uvular movement, that is your entry into the oropharynx. That is your door to oropharynx. Another thing, suppose you are not able to identify proper anatomy in the nasal structure. So which type of colors are you able to pursue in any endoscopy? Usually you are able to pursue three colors. One, white, second, pink, and third, black. See, this is white color. This is pink color, and this one is black color. So when you are getting pink color, this represents the color of tissue. White color represents the reflection of light from the tissue, and black color is your passage. So what you need to do when you are not able to identify the anatomy, just follow the black. You will be automatically inside the larynx. So now keep following black. I'm just running the video. All of you just keep following the flag. This is the black, and I'll just keep my cursor towards the black, and you'll automatically at larynx. So this is the darkest black. I'm going towards the black. This is the black. I'm going towards the black. This is the black. I'm going towards the black. Again, this is the black. This is the darkest black. I'm going towards the black. Again, I'm going towards the black. I'm just following the black. This is the black. So, if you follow the black properly, you will be in the air passage. So just follow the black. Another thing, another problem with the first step is many times you get stuck with the secretions, you are not able to find the anatomical structure. So in such case, wait, do thorough suctioning through the instrument channel. Allow to make the vision clear after proper suctioning, and then proceed once you get the clear vision. And there are a number of ways you can suck out the secretions from the oropharynx directly from the suctioning, from the nasopharynx to do the pass the suction, or through the instrument channel of the scope. And the best way to clear the passage, if patient is awake, ask the patient to swallow the secretions. This will make the passage clear. You will get the vision of a larynx, and then you can proceed. And usually you get secretions is look like this. So intermittently I'm doing suctioning to get the visions. So after getting proper vision, advance your scope to get entry into the vocal cord. So now second step. See, these troubles we have discussed about the first step. Second step start from the larynx to subglottic area. So what type of trouble you can get in the second step? So first, vocal cord is moving structure. Glottic is moving structure. You will get difficulty to make entry into the vocal cord if you are not technically sound. Many times because of sedation, there will be a collapse of airway. You will not get the proper space to go in. Coughing and laryngospasm creates or increase the trouble. There are certain maneuvering problems. And as you are much near to vocal cord, the fogging of lens is common. How to overcome this trouble? So as we know, the larynx is placed anteriorly, and you are passing your scope parallel to posterior pharyngeal wall. So as you are approaching towards vocal cord, to make entry into the vocal cord, you need to flex your endoscope tip down. And after making entry to vocal cord, further you make the tip movement downward to visualize the distal structure beyond the vocal cord. Look at this video. As I am approaching towards the vocal cord, I am flexing my tip little bit down. And once I am making entry, now I am making the entry into the vocal cord. As I am making entry into the vocal cord, further I have to make my tip movement down to visualize the distal structure. And important thing, do not slide your endotracheal tube once you are just inside the vocal cord. Advance your scope to visualize carina, then and then slide your tube. Another thing, in this step, fogging is very common. How to overcome the fogging? This is the video of the fogging. You can get lost because of fogging. So when you are having fogging, insufficiency of oxygen through the instrument channel will clear the fog. There is another way of making contact of endoscope tip to the tissue, but I am not advising you to do it if you are doing infrequent endoscopic intubation. So another way, if you are applying CPAP through nasal cannula or through nose, so this will create the space in the oropharynx. By generating CPAP, it maintains the oxygenation and it prevents the fogging. Same as with the high flow nasal oxygenation. It maintains the oxygenation, it generates the space by generating CPAP, and it prevents fogging. So that's the effective way of doing fiber optic intubation with the help of high flow nasal oxygenation. So now what happens with the sedation? So this is very interesting publication published in way back in 1994, and there are three narrowest portions of the upper airway. This is AB, CD, and EF. Means retropalatal space, retroglossal space, and retroepiglottic space. And all these space get collapsed with even mild sedation, which varies from patient to patient. And this is the interesting fact. They have taken the scan in awake state and asleep state. Look at the space in asleep state. AB is normal, CD is normal, EF is normal in awake. But if you look in asleep patients, there is no space, no retropalatal space. There is complete obstruction of retropalatal space. However, retroglossal and retroepiglottic space is also critically narrowed with the sedation. So, when you are using sedation, keep this in mind. There will be a collapse of airway and you will not get the proper anatomical landmark. You will get lost and will not get the proper space. And we have taken this video in our clinical practice. We're showing the difference between doing the scopy in awake state and asleep state. So in awake state, see, epiglottis is totally lifted up. In asleep state, epiglottis is touching the posterior pharyngeal wall. There is significant reduction into anterior posterior depth of the oropharynx. So in such case, whenever you get lay space, if patient is awake, ask the patient to extend the neck and protrude the tongue. And if patient is sedated, then give proper jaw thrust to open the space after extending the neck. If you are doing oral or if you are doing nasal fiber optic intubation. Now coming to the third step. So once you are into the vocal cord, see, you know, trachea is not a straight line. It travels downward posteriorly and towards right. So you need, once you are making entry into the vocal cord, you need to flex your tip down like this. Then and then you will be able to visualize the distal structure and you will be able to reach the carina. So look at this video. As I am approaching towards carina, as trachea is shifting towards right, automatically my scope is going towards right. And many times you'll get this type of picture when you are into the vocal cord at the trachea. This is called dynamic airway collapse. There is significant decrease in the intratracheal space because of there is an esophageal bulge into the trachea, and that's because of deglutition of the patient or esophageal peristalsis. So don't make a hurry to advance your scope or tube when there is a dynamic airway collapse. Ask the patient not to deglutate, allow esophageal peristalsis to go away, and if there is a proper space, then and then advance your scope. Otherwise, there are chances of posterior tracheal perforation. Now coming to the last step of the fiber optic or flexible endoscopic intubation, that is passage of the tube. If you look, see in dialect endoscopy, you are generating the space for endotracheal tube to pass. You are creating a direct line of sight and you are creating a channel for the passage endotracheal tube. But in fiber optic scopy, flexible endoscopic intubation, the passage of the tube is S-shaped. It's like oropharyngeal-laryngeal curve. So your tube can get impinged, get resisted at two places, one at nasal inlet. So to overcome nasal impingement, lubricate the nasal passage properly over the tube, and rotation of the tube over the scope gradually overcome the nasal passage impingement. And second impingement is laryngeal impingement. Your tube gets stuck at the laryngeal inlet in spite of your scope is inside the larynx. Look at this. See, this Jackson has identify the different side of larynx where tube can get impinged, can get resisted. So here scope is inside and tube is getting resisted at right arytenoid. Here scope is inside and tube is getting impinged at the interarytenoid tissue. Here scope is inside and tube is getting impinged at the left arytenoid. And here the scope is inside and tube is getting impinged at the epiglottis. So tube can get impinged anywhere into the laryngeal structure. So how to identify that my tube is getting lodged or getting impinged or getting resisted at the laryngeal inlet? So if your tube is getting resisted, or if you get resistance at the distance 13 to 17 centimeter from nasal inlet, that always suggestive of your tube is get lodged or tube is get impinged or tube is get resisted at the larynx. So scope is inside, and if your tube is not going in, how to overcome this impingement? So there is simple maneuver. We draw the tube little bit, 2 to 3 of up to 5 centimeter. Rotate the tube 90-degree counterclockwise rotation. Means Murphy or tube should be anteriorly and BL facing posteriorly. This will overcome all type of laryngeal impingement. See, now coming to let's discuss this publication. Here, according to this publication in Anesthesiology, awake fiber optic intubation resulted in higher acute laryngeal injury. One another publication in the same journal, 3 years later, fiber optic intubation is safe regarding vocal cord sequelae. Why there is a difference? One, there is higher laryngeal injury. Second publication is safe regarding vocal cord sequelae. Why? Because in second publications, the methodology, they have used the different type of endotracheal tube and they have optimized the gap between the endotracheal tube and fiber optic scope. And that's the reason there is higher success rate and less laryngeal morbidity. So in short, the selection of tube is having impact on laryngeal morbidity, laryngeal injury, and success rate. So there are different types of tubes available: PVC, flexometallic, Parker flex tube, P-curve tube. Which one to be used? If you are using vortex tube, PVC tube, in 35% of the cases, there are chances that your tube can get impinged and that increase the laryngeal injury. It's because of stiff tube, sharp tip, and right side tip and Murphy's eye. But if you are using flexometallic tube, it decreases the chances of impingement and increases the success rate. And even the design of tip is also having impact on laryngeal injury and success rate of fiber optic intubation. So there are different type of tip designs. So if you are using Parker flex tip tube, so where tip is pointed towards the center. So this tip is pointed towards the center, towards the scope. So it minimizes the gap between the scope and the tube and minimizes the lagging of the tube. And because of this reason, it decreases the laryngeal impingement and increases the success rate. And if you are using silicone rubber tip tube, which is coming along with the fast track LMA, so it's the best way, is giving higher success rate and less laryngeal morbidity among all type of tubes. So it should be the first choice for the flexible endoscopic intubation. Even the gap between the endotracheal internal diameter of endotracheal tube and external diameter of the scope also affect the success and affects the chances of laryngeal injury. So what should be the optimal gap? Your endotracheal tube size should not be 1.5 mm larger than the diameter of the scope. So if you are using 6 mm scope, optimal tube for this scope is 7.5 mm for higher success rate and decreased chances of laryngeal injury. So simple tips for selecting tube: use fast-track tube if it is available, and internal diameter of tube should not be larger than 1.5 mm than the diameter of the scope. If your tube is getting resisted, use 90-degree counterclockwise rotation of the tube to overcome this impingement after withdrawing the tube. And that is called undo technique. Keep the bevel up in nasoendoscopic intubation and keep the bevel down in oral endoscopic intubation. And finally, we come to a placement of the tube. You should be able to count 5 tracheal rings from the tip of the tube when you are inside, when you are placing the tube inside, because 1 tracheal rings, there will be 2 tracheal rings per centimeter. So if you are 5 tracheal rings away from the carina, means you are 1 inch away from the carina, which prevents the accidental extubation as well as it prevents the endobronchial intubation when there is a flexion of neck, full flexion to full extension of the neck. So now coming to the, if you are doing from front, what happens? You will get the exactly reverse image, and maneuvering is also exactly opposite what we have discussed till time. So in short, the art of endoscopy basic is your first chance is your best chance. Oxygenate through any possible route. Keep endoscope straight and taut. See, endoscope want to do intubation. It is you who is doing it or not doing it. Stay in the midline, get off the wall. Moderation is everything. Slow down to finish the procedure faster. If you don't know where you are, if you are getting lost, withdraw the scope, come to a step where you are able to identify the anatomy and then proceed. Force is always wrong. Slow down to finish the procedure faster. And when you are doing the endoscopy, think that you and endoscope are one. Thank you. Thanks a lot.
Thank you, Dr. Dulkhet and Dr. Apex, for the much needed information on fiber optic intubation. Now let's begin with the questions. Over to you, sir.
Thank you, Dr. Patwa. It was a very lucid and very illustrative. The videos are fantastic, and you have very nicely explained step by step where you will encounter what. So it is very crystal clear. I think even some of the tips are quite informative to me also, because I am regularly doing fiber optic. Very nice and lucid presentation by Dr. Patwa. And I would like to ask him I would like to discuss with him, or rather some things. That is, how would you like to train the new postgraduate students in fiber optic intubation? Because it is a very important procedure and a very skillful procedure. It has to be properly trained.
True. See, first thing, when any PGs is having intention to learn the fiber optic training, so it should be always done with the guidance of the senior. That is one thing. First, they should start with the proper training on mannequin or simulation base. And that is one thing. Second, they should know the proper endoscopic anatomy. Second, they should know proper anatomy of the endoscope. They should know the maneuverability of the endoscope. And then they should, with the simulation-based training, they should do a proper training on the mannequin and simulator. Once they are through with that thing, they should be allowed to go for a on-patient training. And when you are doing on-patient training, I'll suggest those who are doing, they are starting their career on the flexible endoscopic intubation, they should not do under sedation. They should use block, keep the patient always completely awake. And there are certain type of courses are existing. Actually, we are also conducting a 3 days on-patient training course. It's a ADA course. And the fellowship on airway, advanced airway management is also there under the banner of All India Difficult Airway Association, where you can get the exposure of all type of airway procedure and airway gadgets on patient.
Which means there are so many companies. I am not advocating any company or anything, but what instrument you are using and what diameter you are using? I would just like to ask.
I'm not giving the name of the company because
it is a become sort of advertisement. Yeah.
So use any type of flexible endoscope. There are two types of endoscope available. One is fiber optic. The life of fiber optic is less, and you require very fine handling of the fiber optic scope. Another scope is a video bronchoscope, in where there is no fibers. There is CCD which is embedded on the tip, and the light is through the LED. So there is a camera embedded on the tip of the scope. So these type of scope are better because handling is, even if there is a poor handling, there will not be any damage to such type of scope. And there are a number of companies are coming with this type of portable video bronchoscope. Few of the Chinese companies, few of the Indian companies, and few of the German companies are having such type of scopes available in the market.
Which diameter you prefer? Means usually?
Usually, see, for an adult, I am using 6 mm diameter. And if I'm using 6 mm diameter, I'm keeping my endotracheal tube size 7.5.
Yeah.
And another, for a pediatric, I am having 2.8 mm scope. And if I want to do a fiber optic intubation in adult with the pediatric scope, then I'm using the entry catheter over the scope to minimize the gap between the tube and the scope.
Yeah, thank you for that. And suppose there is a Ludwig's angina, for example, very challenging problem is Ludwig's angina. So how do you go about this difficult Ludwig angina case?
Yes, see, Ludwig's angina, if it is an emergency intubation, I am not advising to go for a fiber optic intubation, go for surgical airway. That is important thing. Ludwig's angina with emergency, go for surgical airway. Don't use fiber optic.
But even the tissues are so friable sometimes, which will be, I think most of the times, they can get away with even surgical airway, I think. That is what I feel.
So
but sometimes
go for a surgical airway.
Yeah. And one more thing I would like to share with you is the recent developments in imaging technology. They have come up with 1 millimeter and 2 millimeter that is scanning single fiber scanning fiber endoscopy. And I think we took a double lumen tube and right-sided double lumen tube, for example. And if you want to be sure of right upper is ventilating or not, we can pass this type of fiber. This is a future technology which is coming up. That is single fiber scanning fibroscopy and silicon fiber endoscopy, which is giving all this recent advances in technology of endoscopy, and which I think anesthetists also will share this technology in future. So with that, I profusely thank Dr. Patwa for his very enlightening lecture on this very difficult and important technique for the anesthesiologist. Thank you, sir. Thank you.
Thank you, sir, for updating me. I am not aware of this type of technology, but I am using fiber optic scope with the 2 mm diameter also. But if you are getting the single fiber endoscopic scanning techniques, So I'm not aware of, and thanks for updating me for that.
Thank you, sir. Thank you. Yes. Thank you, organizer, for giving me an opportunity to share this this scientific chair. And I like to thank Dr. Kalpana Kulkarni and all the organizers for wonderfully arranging this important session. Thank you, Dr. Kalpana Kulkarni and all the organizing.
Thank you, sir. Sir, we have a question for you. What is the difference between fiber optic scope and bronchoplex?
Bronchoplex. I am not aware of bronchoplex.
Okay, sir. Thank you. What about the airway blocks, or how to go about the anesthesia while doing the fiber optic scope?
Yeah, in my clinical practice, I am routinely using superior and laryngeal nerve block, transcricoid spray, and transcricoid puncture and spray, and for posterior pharyngeal wall anesthesia by the 10% Xalocan spray. Recurrent superior laryngeal, transcricoid spray, and oropharyngeal spray.
Okay, thank you, sir. Now we'll go to the next session. The next session is on critical airway situation and management techniques. And the chairperson for this session is Dr. Shalini Sardesai. Welcome, ma'am. Dr. Shalini Sardesai, she is the Dean and the Professor of Department of Anesthesiology, Kashibai Namle Medical College and General Hospital, Pune. She has been a PG guide and MUHS University examiner and subject expert. She has numerous publications in renowned journals such as Indian Journal of Anesthesia, Journal of Anesthesiology, Clinical Pharmacology, and Anesthesia Pain and Intensive Care. Welcome, ma'am. I request you to welcome our speaker, Dr. Syed Mohid Ahmed. Ma'am, please unmute yourself.
Yeah. Hello.
Thank you, ma'am.
Yes. Good afternoon, everybody. First, I would like to thank our organizing committee, Dr. Kulkarni Madam, Dr. Kadam Sir, for inviting me and giving chance to chair this session for academic feast on critical airway management. Also thankful to organizing committee for my warm introduction. We all know that since the advent of supraglottic airway devices, especially LMA, the approach to airway management has undergone a dramatic transformation. And LMA has taken an important role in the management of difficult airway. Nowadays, it is an important, inexpensive instrument, not only in anesthesia or operation theater, but also in outside the operation theater, or even during the critical care area, or even outside the hospital. Those intensivists or those healthcare workers are involved in the airway management. So it is a very important tool, very important conduit for the intubation, for in a difficult intubation scenario, also in the CPR, during CPR. So initially it was LMAs were used, or supraglottic devices were used for small surgical procedure. But nowadays these are used in almost all types of surgeries and in all patients, including all pediatric and geriatric patients, with different positions, even in prone positions also. In the morning only, Dr. Namaze sir has given wonderful lecture on how to use intubating LMA in a patient with prone position. Now, in the era of this, fiber optic and video laryngoscope and the use of ultrasound for intubation, the certain techniques like retrograde intubation or retromolar intubation has their own merits. In spite of this advanced era, such techniques has their own role and are very useful in certain conditions. So to deliver a talk on this topic, that is the role of supraglottic airway devices and some intubation condition in critical airway management, I would like to our eminent speaker, Dr. Syed Moeed Ahmed. Before handing over the mic, I would like to, I have great pleasure to introduce our eminent speaker. He has done PhD, MD, FICCM, FCCP, FIMSA, MNAM, so many degrees and so many specialization in different areas. He is working as professor and chairman in charge of ICU at JN Medical College, Aligarh Muslim University. His areas of interest are airway management, CPR, and critical care. Sir is editor-in-chief for Indian Journal of Anesthesia. He has a lot of contribution in the development of different guidelines like All India Difficult Airway Guideline, Indian CPR guidelines. He has more than 110 international and national publications. He has been awarded by many awards. There is a long list. I congratulate sir for such wonderful academic performance and achievements. He has got ISA President Award in 2015 and 2017. He has been felicitated by Honorable Vice President of India. He has been awarded Dr. Boj Raj Award for Best Review Article in 2016. He has been felicitated by AMU VC in 2008 and 2010. He has done Commonwealth Fellowship in 2009. He is one of the member of Indo-US Academic Research. He has worked as a researcher of the year 2008, and he is the member of founder president of ISA City Branch, All India Difficult Airway Association City Branch, ISA City Branch, ISCCM City Branch. I welcome you, sir, and I hand over the mic to Dr. Saeed, sir. Please.
Thank you so much, madam, for that.
Sir, we are not able to hear you. Unmuted. We can't hear us. Sir, we are not able to hear you.
Hello. परत आता केलं मी त्यांना.
Sir? Sir, can you hear us? We are not able to hear you. Please try to hold your mic nearer. Sir? Sir, we are not able to see your screen.
Hello. माइक तो मेरा तो ठीक है, यहाँ तो स्क्रीन शेयर तो I'm trying to share my slide. Hello, can you see my slide?
Contributions, but not big ones, not the rich-like contributions from the Indian top order. They are all now back in the dressing room. Leaders on the field, 3 rounds behind in the end. There's a little bit of criticism of his tactics yesterday from certain quarters in terms of what their game plan was and their scoring. They didn't want to score big in the first set. We don't have that. And now in a certain situation where they can truly carry the side out back to stand in the end. This is good from Joe, bringing Japanese on immediately after one as well. Allows gives the chance for Japanese to come back, settle down. Udo was, Tiger was not the way around to the good ones. At the moment, 78.1, that's a lot for a front line spinner. Happens sometimes, it's happened to all of the shoulders, so how we come back from it. Yeah, so that's a really good point. And even they're big products. So it's important to get this confidence to get the aircraft spin from the second time now. It's important to confidence and the goods.
lot of disturbance going on the background. Someone respond, please. Hello. Can I start? Hello.
Hello, sir. Sir, can you hear us? We are not able to hear you. Please try to use headphones.
Hello, can you hear me?
Hello, yes, sir. We can hear you now. Yes, yes, sir.
But there is a lot of, disturbance at the background. I think someone is playing some record there in your place. Is it okay now? Can you hear me now?
Yes, sir. We can hear you.
I'm audible, na? My screen
Yes.
is also visible, right?
Your screen is visible, sir. Yes, sir.
Okay, fine. Thank you.
Okay.
Okay, dear. So I can proceed, huh?
Yes, sir.
So, thank you so much, madam, for that excellent introduction which you've given for me. At the outset, I must congratulate the organizers for organizing this event. But at the same time, I must apologize for my not being able to participate on time because I had some unavoidable circumstances which I had to face probably. I bring greetings from my institution, from my university, Aligarh Muslim University, and my institution, Jawaharlal Medical College. I have been given a topic which are pretty important topic, and at the same time quite a large number of topics. So it's on supraglottic airway device, surgical cricoid-thyroidotomy, retrograde intubation, retromolar intubation. But I think retromolar intubation has already been dealt in the previous lecture in the morning. So I will try to skip this and then deal with these three important topics. So as you all know that, as Madam rightly said, that we have been already, doing a lot of work on LMA, and LMA has been the most important device which has revolutionized the management of airways. Not only airways, plain simple airways, difficult airways as well. But time has come to, vintage laryngeal mask airway and adopt second general supraglottic airway device, which I'll be dealing mostly. So there have been several way of classifying supraglottic airway devices. Cuffed versus non-cuffed, number of cuffs, location of the distal end in relation to glottis, sealing mechanism, perilaryngeal verse, and there are so many different way of classifying supraglottic airway device. But most commonly used method is in fact the first, depending on based on the generation, which we say first generations, which are simple airway device which has low pressure pharyngeal seal, low pharyngeal seal pressure, may or may not protect the lungs from aspiration, and have no specific design to lessen the risk. And they are, classic LMA, flexible LMA, and laryngeal tube and Cobra PLA. They are all the devices which are first generation devices. Then we have second generation devices. Now these are the devices which are nowadays being used, commonly used, and most extensively used in most of the situations, because they have some additional advantage on this. So additional design features to reduce the risk of aspiration, which is there. And they have a high seal pressure, which is very important because it helps you to increase your airway pressure when you're ventilating these patients. And it also has an internal integral bite block to protect the patient's airway against occlusion, and maybe more efficacious in ventilation, as I said. So they are all PLMA, laryngeal supreme, LTS, iGel, SLIPA, and Blockbuster, and there are other things which we have in recent generation. Then we have third generations. They are cuffless device which has two drains and have small bowl, which is Bascamas, which is very famous in this as a third generation supraglottic airway device. So accordingly, we classify supraglottis as first generation, where we have only airway tube, whereas second generation, we have additional design features to reduce the risk of aspiration, high seal pressures for ventilation and at high pressures, and integral bite block. So they are the three important features which make these devices as the second generation airway device. These can be used both in elective surgeries, and they are recommended as rescue airways in unanticipated difficult airway, and also as procedures outside the operating room, very well known as radiological MRI, radiation therapy, and diagnostic shock therapy procedures in children. So other indications are, pulmonary medicine, thoracic surgeries like bronchoscopy, laser surgery, tracheobronchial stent. So they are all being used in these situations, these surgeries. Now, what are the difficulties, or you can say contraindications, or difficulties when in situations where we cannot put supraglottic airway devices, like a patient which is commonly used pneumonic is drop, where disrupted airway, trauma, caustics, because of trauma or because of irritation or caustic substances which has caused disrupted in the airway. They are situations where we cannot put a supraglottic airway. This restricted mouth opening, which is less than 2 centimeters, will always limit your airway device, a supraglottic airway device. And obstructions like mass, foreign body, or edema can also prevent, and poor lung compliance. Now, this is again one which could be a relative contraindication, because nowadays we have a good airway seal pressure device like supraglottic airway device with second generations, which can increase your in your airway seal pressure and can use in these situations. Now, that is what we said, absolute contraindication where we don't have a mouth opening and the complete airway obstruction is there. And then relative, of course, increased airway risk of aspiration, morbid obesity. They're all relative contraindications where probably we'll not be able to use in those situations. Now, laryngeal mask airway, there are varieties of laryngeal mask airway, a series of a battery of laryngeal mask airway. I don't want to deal in detail because they are something which is nowadays not being used that regularly. We are using the second generation. this is the laryngeal mask classic, but since they are the father of your or all the devices, so we must know something about it because they have been asked in the examinations also. So this is a laryngeal mask classic, which has, there's a latex-free medical grade silicone, which decreases the throat irritation and consists of curved airway tube connected to the elliptical spoon-shaped mask, which is around 30-degree angle. The other is airway tube is slightly curved and they're semi-rigid, and two flexible vertical aperture bar is there, which prevents the infolding of your epiglottis. But they are, again, there are a lot of studies which have been done on this, and they have been seen that 90% situations we don't need to have an airway in the parallel aperture bars. But it has a cup pressure of 60, and most importantly, this has a reduced esophageal pressure, ceiling pressure, which is around 10 to 20 centimeter water. So naturally, a patient who has bad compliance, so then in those cases, probably it will not have a very good. It is not a very good device. So it can be used for more than 40 times, and it can be used inserted blindly without muscle relaxants as well. Now, there are all the sizes, which I don't want to go in detail. And this is the insertion technique. Probably most of us know about it, how to insert it. So this is something which probably everyone should know it. And especially the resident doctors must know it, because this is being asked in most of the examinations. Though they are not being used that regularly, but it is a common question which is asked. Now, there are other techniques. One was standard technique where you hold the patient, the subglottic airways in a penhold grip. And the other techniques are with cuff partially inflated or cuff inflated and rotated around 180 degree. And side of the mouth can also be inserted. And bougie, stilate, tracheal trachylite, and very common for Dr. Namazi is that it can be used in prone position as well. So that is something which, of course, he is the expert on that. So there are different methods of insertion, and it can be used in blind intubation, pre-mounted with endotracheal tube. As you see, we are putting it with an endotracheal tube inserted, and bougie aided also, which can be used in those situations. It can be used as in trachlite or with fiber optic intubation as well. Now how do you know that the supraglottic airway device has been correctly placed? So naturally, the distal tip of the silicon upper esophageal sphincter should be at the upper esophageal sphincter, and the side of the cups piriform fossa, and the upper part of the cup should be at the tongue base. And most importantly, you should see that there's a swelling in the front of the neck, and the upper part of the cuff should not be visible through the oral cavity. And when you're inflating the cuff, there should be some slight movement of the tube outside. So they all tell you that yes, you have been placed properly. Now this is the LMA, ILMA, which is intubating LMA, and it is being used. Very commonly in most situations where we are not being able to intubate a patient. We can intubate through the laryngeal intubating LMA. But advantages are it has a preformed rigid tube, and it has a handle. So you don't need to put your fingers inside, and at the same time, it is primarily meant for intubating patients, where we have this dedicated armored tube along with an introducer. So naturally, these are the devices. This is a device which primarily being used for intubating a patient, at the same time ventilating the patient while you're intubating it. So there can be advantages in situations where we are not having a very good oxygenation in some patients while intubating this one. But the most limitation of this device is it has a very limited size, which is 3, 4, and 5. Now that is what the limitation is in these devices. Otherwise, it is obviously a very good device. So the other devices which is really being used nowadays very extensively in most of the situations is the ProSeal LMA, and they are the devices which has an additional advantage of posterior inflatable cuff, which is 2.5, which is available above 2.5 size, and they help the tube to fix or adhere to the laryngeal inlet and avoid. Increase the esophageal pressure, and so can be ventilated with this very easily and avoid any aspiration, because it has a gastric tube as well. This is a device which has a dorsal cuff as well, as I said, which is above the level of size of 2.5 size. So that is a very good device, especially in patients where we think that patient can be there's a chance of aspiration. There we can use this device in those situations, and especially where we need that the patient's lung compliance is not very good. We can use, especially in obese patients, where we think that patient will be ventilated in higher pressure. So these are the devices which are being used, and you need to know how to insert it, the standard way, the introducer way and the bougie way, and you know that it is correctly placed when it is being when you can pass the right tube through the easily through the gastric port. Now this is a small video. Probably it works. Is the video working? I hope it works. And this is the standard technique how we insert it. And naturally we hit the hard palate, the tip of the device, and then we introduce it with an introducer. And we know that it's correctly placed once we see that the patient we can pass a right tube through this port. That is one of the signs which can tell you that. Otherwise, when you ventilate, you must see the the expansion of the chest, along with there should be a swelling at the front of the neck, which tells you it's yes. And then you should not see any. There should not be visible cuff. Should not be visible in the oral cavity. So they are all signs which tells you yes, you are absolutely in the correct position. This is the other technique which we use, that, as I said, with the help of you're passing it, and then you railroad it with the help of your this is a ventilating stillet, or you can say a Riles tube, and then you pass it through your gastric port, and then you can railroad it, and then that gives you a position. This is the other way how you can put an endotracheal tube through supraglottic airway device. Now, how to detect? As I said, there are different methods of detecting it. Why does PLMA give a better protection? As we already dealt, that increases the pharyngeal leak pressure, reduces the leak fraction, and drain tubes can be used to prevent the gastric aspiration, drain out all the esophageal contents. Should regurgitation occur, the drain tube vents the fluid, whatever is there inside the gastric stomach. So this is something which is there. So it has a very good it helps in ventilating a patient who has less compliance. They are all advantages. And the most important thing is, as I said, the pharyngeal seal pressure is very good. So naturally it improves the ventilation in such patients. And you must see that benchmark for second generation is primarily PLMA, where it has overruled the other devices which has come in subsequent years. So the disadvantages are less suitable as an intubating device because it has the gastric drain passes within that tube, so it reduces the overall dimension of the airway tube. So naturally that is one disadvantages which is there with this. Otherwise it is an excellent device. Now we have the laryngeal supreme, which is a preformed, pre-shaped device, where the advantage is that it has, again, you don't need to put your fingers or introducer for this, and then it helps the bowl. It has a bowl which prevents any sort of aspiration as well, and it has a larger pre-cuffed cuff. So naturally that is one thing which is very important, and it has an inbuilt bite block as well. So the safety features are similar to that of PLMA, but obviously the round tip has a 10 degree slant that allows the cuff to follow the contour of the esophageal sphincter to optimize its correct placement. Now this is something which is advantages which is not there with PLMA as such. Now this is the other device which we have nowadays, which is iGel, and the advantages, of course, there are a lot of advantages with this. It's a single use cuffless mask, but it is a gel-like thermoplastic elastomer which helps to adapt itself once it is inside the oral cavity. And advantages, it does not have any cuff, so the chances of cuff leak is not there. So that is one thing which is, and it has an inbuilt bite block, and it is a very rigid and stout. So naturally the chances of kinking is not there. At the same time, it has a very good esophageal seal pressure, which is around 30 centimeter of water. So that again is an added advantage. And in certain cases, there is an esophageal, oxygen port also, which helps to supplement oxygen. This is what is in short. I'll just show you how it is. We can use in a mannequin. I'll just shortly, very fast, go through it so that we can finish it.
This shaft accommodates two channels. One is a ventilating shaft, here, and the other is an opening of the tube ranging from size 7. So using this device, you
I'll just go.
hold this device and this pipe lock in this area has been especially strengthened and it does not require a chip. And as a type of patient, and then you bring the patient at point, relieve it, and select it to a
So that is what is, most of the people are using it, so that's nothing very different in. The chances of failed ventilation rates is around 5%, not more than that. And this has an, when correctly positioned, ICL penetrates into the esophagus rather than the less than LMAs, and its esophageal seal is low. So naturally, it is better when we talk with the other devices are AirQ, which are not that frequently used, but some people has a fascination. I've shown it. Especially for the PGs, I just wanted to show the device. We have the Oragain, which is again a device which is being very frequently used in most of the patients because it's a pre-shaped and it can be intubated and ventilated through this, and it has an esophageal port as well. So naturally, it can as a drain tube. They are all second generation airway devices. The other devices which are newly come is the protector, LMA protector, which has a 2 gastric channel, and it has a bowl as well, and then it has a pressure regulating valve as well, so which tells you that what is the esophageal pressure that is there, and the important thing is you can intubate through this as well. So they are all the devices which are there, and we have a blockbuster which has recently come up, and there also we have a gastric channel along with it, which has a esophageal pressure, seal pressure, which is very high. So they are all primarily very similar to PLMA, but some additional features are there which helps it, which makes it be distinct to the rest of the PLM, because it is something which has an esophageal pressure seal which is around 30 plus, and it is pre-shaped. That is most important, preformed and pre-shaped. So it can be, again, it has a dedicated the armored tube, endotracheal tube, through which you can intubate this device. So that they are something which is not there in the other supraglottic air videos. Then we have the blockbuster, which is a 3rd generation device. It has a tab which helps it to take the shape, and it is again cuffless. One important thing is it's cuffless. It has a sump which accommodates if any fluids are there, and it has an esophageal opening and a gastric drainage channel which prevents it from aspiration. Now, these are the advantages. It's a cuffless device and a membranous bowl which inflates each positive pressure and then deflate at the end of expiration, passive expiration. So additional features, I just don't want to go now. These are the laryngeal tube. They are all being used very frequently in most of the cases, but nowadays it's very rarely used. But they are all to be known for the resident doctors. They must know because they are being displayed during the time of exam. So they must know what are these devices. This is a combi tube which has been previously being used in CPR management, but nowadays not being used. They are, again, it's a progeny of combi tube. It's an easy tube which is similar to that combi tube. Now this is a device, SLIPA, streamline line inline pharyngeal airway. Now this is again this is a cufflet device which helps to prevent it to some of the people. And I say I've not come across this device. I've not seen it, but they are there. It's a 3rd generation device which is being marketed, but it's not being that regularly used in regular practice. So cleaning is, again, dilute solutions, sodium hypochlorite, bicarbonate, soapy water may be used. Formaldehyde, glutaldehyde, ethylene oxide not to be used. Prolonged immersion in chlorhexidine is to be avoided, and cuff should be deflated immediately prior to autoclaving as spontaneous inflation occurs over a few hours. And no residual air fluid should be left in the cuff, and it has been that if residual air has 0.25 ml elasticity of the cuff decreases considerably. Now, these are the solutions which is being used, and these are the specifications for autoclaving this device. So the conclusion: no single device meets all the criteria for ideal supraglottic airway device. Second generation supraglottics are likely to provide better airway protection, and their use is increasing in clinical practice. Airway providers should be skilled with several devices and techniques, including various supraglottic airway devices, to be considered competent in airway management. Now, this is what was supraglottic airway device in short. Their utility and use in ICUs, I'll deal with it later on. This is what is scalpel and cannula cricothyroidotomy. Now, we know that we have failed to intubate this patient. We have failed to pass a supraglottic airway device, and then we failed to go for a rescue face mask ventilation. Now, what is left to us? The trigger is that patient has come up to a complete ventilation failure, right? And this is a situation where intubation, ventilation, and using supraglottic airway device and face mask have all failed after giving the best attempt, even if oxygenation may be maintained. Now, so that's it. This is you must, if it is better that if you know the mnemonics in situations where probably you might face a difficulty while going for a scalpel or a crico or a cannula crico or emergency cricothyroidotomy, whatever you say. In this situation, bang, which is bleeding tendency, if the patient has bleeding tendency, or if the patient is agitated, or the neck scarring is there, or growth or vascular abnormalities are there in the front of the neck. Now, these are the situations where probably you might face difficulty in passing and going for a scalpel or emergency cricothyroidotomy. But in situations where you don't have any option, probably you've got to go for it when you need to maintain an airway. Now, surgical cricothyroidotomy gives 100% success rate, whereas puncture, like narrow bore less than 4 millimeter cannula over needle, it gives 37%, and wide bore cannula gives at least 57%. So after surgical, it's better to use a wide bore cannula, which I'll show you in subsequent slides. So once you have come to this is the difficult airway guideline, IRA difficult airway guideline, where we have faced an unanticipated difficult airway, where the patient has been failed to be managed with intubation, supraglottic airway device, and rescue face mask. And so we've reached to the stage 4, where we need to go for an emergency cricothyroidotomy, where we need to continue the patients with oxygen flow at the rate of 15 liters per minute, and effort should be continued to go for rescue face mask ventilation. But perform one of the following techniques. You've got to save the patient's life by giving oxygenation. So naturally, surgical cricothyroidotomy is the first choice, especially in adult patients. You can go for a wide bore cannula cricothyroidotomy, or then if you are not being able to have any such devices, then you can go for needle cricothyroidotomy. That's something which a jet ventilation will probably help you to maintain oxygen on this patient. The first thing is maintain oxygen at the rate of 10 to 15 liters per minute, and call for help. Now, this is something which is important. You must have an additional help who is going to help you out to go perform these technique. And the patient should be supine, and the head should be extended. Now, this is how the patient should be, and need to have only 3 devices with you, along with a syringe, you can say. So 4 devices, which we say that we have to go for a laryngeal shake hand. To identify the cricothyroidotomy, aka cricothyroid membrane. With the 2 fingers, the index and the thumb, you try to hold the cricoid cartilage, and with the help of your index finger, so second finger and the thumb, you hold the cricoid cartilage, and with the help of your index finger, try to roll down from the mentum till you meet the lower border with the thyroid, where you get a dimple, which is known as the cricothyroid membrane. So that is the cricothyroid space, and this is known as a laryngeal shake hand, with the help of which we can identify the space. Now, once you've identified the space, then you go for, now this is what is the space looks like. It's a trapezoidal space, which is around, the superior border is formed by the thyroid cartilage, inferior border of the thyroid cartilage, and the inferior border is formed by the superior border of the cricoid cartilage. And the dimension is around 9 millimeter to 1 centimeter from superior to inferior, and sideways it is around 3 centimeter from left to right. And the structures, obviously, it is facial, subcutaneous tissue, thin facial layers, and a superior thyroid artery. But one very important thing is, it is just 1 centimeter below the vocal cord. Now, this is something which is very important, and you must know that as a landmark. So first is, it's a 4-step technique. You can say stab, twist, bougie, and tube. So STBT. which gives you 100% success rate. So first is you have fixed the cricoid cartilage, and you identified the cricothyroid membrane. You give a stab with your scalpel, and once you've given a stab with your dominant hand, and then you twist it, okay, twist it vertically, and then you, with the help of a dominant hand, you pull the hand towards you, scalpel and the hand towards you, and then you change your hand by holding the scalpel with your left hand and free your dominant hand, and that dominant hand is going to now hold your bougie, and the bougie is being passed through this opening which you made. So this scalpel is being pulled towards you so as to create a space here, which will help you to negotiate your ventilating bougie or your whatever bougie you have, right? And then once you passed it, you try to see whether it goes freely, and you railroad it and you move it up and down to see whether it has gone freely, because there is always a chance that you can go for a false passage and it can cause problem to the patient as well. Then you, with the help of the other hand, you hold your endotracheal tube, you railroad the endotracheal tube through this, and then you try to negotiate it, because this is something which is very important, and then you with the help of your catheter mount, and you have a number bag, whatever it is, and then you try to inflate the cuff and ventilate this patient. So this is what, in short, I'll just show you what this is. This is what we are using. This is a scalpel and a bougie and an endotracheal tube, and so I'll just very fast, I'll try to show you this video. So naturally, that is what they are doing. This gentleman is standing at the head end, but you can stand at the side, right side, left side of the patient. That is also possible. Both the sides you can do it. Now he's going in a different method of identifying the cricothyroid membrane, but ideally we do it in the laryngeal shake hand method. And then he gives a stab incision there, but he gives, obviously this technique is a bit different than what we usually use. And so this is what he has identified, the cricothyroid membrane, and then he gives a stab incision, okay, which is again an horizontal stab incision, and then he will twist it. He twists it, and then he will try to shift it to one side of the neck so as to create a space. That is what he's doing, and then he passes the ventilating, bougie or simple bougie or a ventilating bougie, and then with the help of the as I've shown, then he railroads he does it so as to see whether it goes freely, and then obviously he will railroad the endotracheal tube through this. Yeah, so that is what he's doing, and he tries to squeeze it inside, because this is something which is a mannequin. It takes some time. Otherwise, in patients, probably not real life, it will not be that difficult. And once he's done this, he takes it out, and then obviously he inflates and then ventilates the patient. So that is what is scalpel. Then we have the wide bore cannula. I'll try to show you. This is the varices needle, which is actually, this is being marketed by Smith Portex primarily. Portex people are using it. It is a wide bore cannula, and it has a 6 millimeter size and 6 millimeter airway tube, and it has a varices needle. Now this varices needle is a guide to tell you that whether the patient is having the tube is inside the trachea. So identify the space, give a stab incision. Now once you put in, you see the red flag here. The red flag tells you that the patient has hit a hard structure. So it comes out. And once it goes inside, the red flag will disappear. So it disappears. And disappears means it has gone inside a hollow structure, which tells you that the patient has entered the tube has, the varices needle has entered the endotracheal tube. The trachea. Now once again, once you push it inside, once again you'll get a red flag, which tells you that you have hit the posterior tracheal wall. So naturally we withdraw, we change the direction of that, withdraw a bit, and then change the direction of the cannula, and then it has a stillet, a needle along with an introducer. So the needle is still the needle is being withdrawn and the introducer is being withdrawn, and then you push the device inside. Now this is what is in short. I'll show you. So naturally you first identify the space, and then you give a stab incision. This is what is being done here. Similarly, you see the cricoid cartilage and the thyroid cartilage, and then this is the middle of it. Ideally, when you give an incision, it is better you give to the lower half of the cricothyroid space, because then you'll get less amount of vessels there. If you are, so you get pass it, you take it an imaginary line which divides the cricothyroid space, the thyroid membrane, into two halves. So the lower half is preferable, but it prevents any bleeding to occur. So if you see the red flag appears, and once you push it inside, the red flag disappears. That means you are inside the trachea, and then you aspirate. So naturally, once you aspirate, you can aspirate either air, or you can take air, water inside it, and then you can aspirate as well. And then you change the direction to around 45 degree, and then you withdraw, push it inside the base. So it goes further down, and then you withdraw first the needle, and then subsequently the introducer. And then while you are withdrawing it, you also simultaneously push your cannula inside. So this is what is primarily but one very important thing is what I hear, I forget, what I see, I remember, and what I do, I understand. So naturally, these are all primarily something which has to be done regularly. Otherwise, you will not be able to have a confidence when in real life. So I would advise you all, whenever you get chance, you try to go ahead with it. I'll just share the other slides. 1 second. And the other slide is, I need to share again. How do I share screen? Yeah. Share. Yeah. So the third component is the retrograde intubation. Only thing history about this, because these are the techniques which are not that frequently used nowadays, because we have so many gadgets to avoid from difficult intubation, and both anticipated and unanticipated. Probably we are not using this regularly. This has become almost in history for us, but people should know how it is being done. These are primarily being done in most of the workshops, because we have so many gadgets with us, so that probably most of the incidences we don't use this technique. But anyway, this was it's not a very old technique. It's around 1960, which was first described about it. But very importantly, it was in the armamentarium of difficult airway, ASA difficult airway in 1993. So it's not that very old. It's around 30 plus. The technique, of course, is, this is a misnomer. Retrograde intubation is primarily is a misnomer, because actually its the name should be translaryngel guided intubation. So indications, it can be both in hospital, out hospital, and pre-hospital, and most importantly in anticipated and unanticipated difficult intubation. But it can be used electively as well, whenever you think that the patient might face and you don't have those gadgets with you, like fiber optic and other devices. Then probably in those situations you can use it as you can use it as a device, right? You can use it as a technique. So the contraindications are most importantly, lack of experience. If you are not experienced, please don't use it. Don't go for this technique. So you must have a very good experience on this. Should know the anatomy and how to go ahead with it. Unfavorable anatomy is again a lack of access to the cricothyroid muscle, like for instance, fixed flexion deformity and obesity, and they are all patients with post-blunt contracture of the neck. They are all contraindications, probably because you don't get the anatomy to see properly. Laryngeal disease, malignancy, stenosis, coagulopathy, infection, there are other contraindications. And airway anatomy we've already discussed. One very important thing I would like to tell you here is that this is an cricothyroid membrane, and we have a vocal cord right up here. So naturally, whatever you do, you might always traumatize the vocal cord. If you pass the endotracheal tube or your needle through this, there's always a chance that you might damage the vocal cord. So this is something which I wanted to tell you. And these are the structures which we should know. The cricothyroid, thyroid cartilage, and the cricoid cartilage are the two important structures, and then obviously the vocal cord we should know. There are so many techniques: classic technique, guide wire technique, fiber optic technique, and skill pull through technique. But I will discuss the classic technique, which is most commonly used. So positioning the patient should be positioned in a sniffing position, but not hyperextending the neck. It should extend the neck so as to make both the tracheal cartilages, tracheal space wider. At the same time, make the prominent, the cricothyroid membrane both prominent and come with anterior to you. And it could be done in sitting position or neutral position as well, but we preferably go for a sniffing position. Skin preparation is as you do with your blocks, and it can be done either with an anesthetized patient or a deeply sedated patient or lightly sedated patient, along with the blocks like the translaryngeal anesthesia with nerve blocks, like glossopharyngeal nerve blocks, supralaryngeal nerve blocks. You can go with sprays or nebulization. And they are primarily done in elective situations, but in emergency situations, probably you'll not get these two scopes to be done. So now there you might have to go for a slight sedation, and then you can go for this. So the transtruncal puncture for retrograde intubation can be made either above or below the cricoid cartilage. Now that is what I want to tell you. That means it can be either in the cricothyroid membrane or it can be below the cricothyroid membrane in the intertracheal space. So both the things, they are having some advantages and disadvantages. I'll come to that. The cricothyroid membrane is relatively avascular and has less prominent potential for bleeding. So that's an advantage. But the disadvantage is that when you're putting it you're inserting your endotracheal or you're passing a retrograde, then always a chance that you might traumatize the vocal cord, and the angular chance that can be while you're pulling out the guide wire or your bougie, then there's always a chance that the endotracheal tube can be pulled out. So that is the disadvantage with this. So if you're going with an intratracheal space, then it allows a lower endotracheal tube to be travel in the straight. It makes your endotracheal tube in a more straighter fashion, and then it bypasses. It prevents the vocal cord injury. At the same time, it allows the endotracheal tube it prevents the endotracheal tube to be dislodged. So that is why the success rate is better that if you go with the intratracheal space below the cricoid cartilage. And this is what I was telling you. See, it's just 1 centimeter. So there's always a possibility. It's possibility that you might traumatize the vocal cord. At the same time, they can be dislodged. So the endotracheal tube is slightly below the vocal cord. That can be dislodged, and it can come. The patient can. You might not be able to intubate the patient properly. So this is one thing. And to prevent that, what you can do is you can pass your guide wire through the Murphy's eye. Now that is something a technique which can use so that you can get additional space of say more than 1 to 2 centimeter below the vocal cord. And that is something which, as I said, these are the techniques, what they are doing. They have, again, now here, one thing I would like to tell you, what the technique which I have discussed before was that we have passed the aspiration needle, the identify needle, puncture needle, vertically, and then we change the direction towards caudal wide, right? Here, it is not caudal, it is cephaloid. So when you puncture the cricothyroid membrane, you are holding, now here again, you are holding the thyroid cartilage, not the cricoid cartilage. In scalpel and in emergency cricothyroidectomy, you are holding the cricoid cartilage. Here you are holding the thyroid cartilage. And then you are trying to stabilize it, and then you are pushing your needle inside, aspirate the air, and then change the direction towards the cephaloid. Now this is something which is different than the scalpel, one thing. The second thing is, always remember, very important thing is that when you're putting a 14 gauge needle, then you don't withdraw the needle, because the needle, the stoutness or steadiness of the needle of your catheter is being with the help of your needle. So naturally, when you're using, when you're taking out the needle totally, there's always a possibility that the catheter will get kinked. So the catheter should always be maintained and steadied, so that you are steadying the intravenous catheter, or 14 gauge or 16 gauge catheter. So you should not to completely withdraw your needle. Never withdraw a needle. Just withdraw a needle slightly about 2 to 3 millimeter, and then you push your needle, the intracath first, and then you withdraw your needle, so that you get the steadiness of it. Right. So this is something which is very important. You must always keep in mind. So that is what I was saying in the pictorial format. This is what is primarily, we go for a puncture, then we change the direction of the needle, and then once the intracath is there, then we railroad, we pass the guide wire through this. Now here is the critical point. Now if the patient is conscious and it's an elective procedure, then the patient might help you with the help of his tongue to take out your guide wire. Or at times, if the patient is unconscious, you might have to take out with your any forceps or your Magill's forceps, or at the same time you can, some people has to withdraw your this thing. They are all reported, but the best says if the patient is conscious, he can help you, guide you to the oral cavity. It can be also taken out from the nasal cavity as well by putting a Ryle's tube through this and then taking out through the oral cavity, tying it and pushing it out through the nasal cavity. Now this is again when you're trying to do it with a for patient with nasal cavity as well. So as I said, the margin of safety is always there when you go with any cricothyroid membrane space. So that is there. But if you want to go for a cricothyroid membrane space, so always try to use the Murphy's eye through which you try to push past your guide wire. Now that's something which is additional. Now once you put the guide wire, you try to hold the guide wire at the level of the neck with the help of a artery forceps and try to steady it out. Now one very important thing here is don't try to make it very too much steady or too much tight, because if you make it too much tight, then the guide wire which is coming out from the glottis, it will always try to clinch the glottis, and so when you try to railroad your endotracheal tube, it will go and hit the anterior commissure. So that is something which is very problematic. Then in that cases, if you think you're not being able to negotiate your tube, you can rotate the tube to 180 degree so that this distal part of the tube, it is facing the posterior commissure, and then you can negotiate it. One. Secondly, if you think that the guide wire is not allowing it, you can pass over this bougie, and then that is going to create a space between the anterior commissure and the endotracheal tube, and so that can again help you to negotiate your tube inside. So there are different methods by which you can pass your endotracheal tube if you are having any obstruction at the level of your. So there are troubleshooting which is there, which can prevent your tube to be negotiated inside the vocal cord. Now this is a small again a video which I tried to show you. Now this is something. As I said, they are going for a puncture. Now this is video laryngoscope, with the help of which they can visualize what is happening. So they are punctured. Once the puncture is done, they aspirated, and now they are passing the guide wire. Now, once you guide wire, you can visualize through this. The guide wire is in passed. You can see the guide wire here, and then once it is being passed, it comes out through the oral cavity. If it does not come out, or the nasal cavity, because this is a mannequin, obviously it comes out very easily. But either when in living patients, probably takes some time. Now you've tightened the one end is being blocked with the help of you tie it, you catch it with artery forceps. Now he's passing a ventilating stillet through this. Ventilating bougie through this, and then over this he's going to railroad your endotracheal tube. So that is what, as I've already discussed. Yeah. Now when you're passing it inside, there's always a possibility if you make it too tight here, then it can go and block. You can go and cause obstruction. So it can cause obstruction at the level of your anterior commissure. So that has to be taken care of. Either you can do it. So this is the second option. What he's doing, he's trying to push it with a. Yeah. So he's pushing. This is a fiber optic A scope. He's using Ambo A scope, and with the help of Ambo A scope, he's going to railroad the endotracheal tube. Now that is also possible nowadays. If you have this device with you, it's very simple. You can go with the fiber optic bronchoscope as well. You can just railroad the guide wire, pass the guide wire through the oxygen port or suction port, and then you can railroad the endotracheal tube. They are all techniques which can be adapted as per your availability of your device, whatever is there. So the complications are bleeding, hematoma, subcutaneous emphysema, vocal cord damage, and tracheal fistula. This is very important, bleeding and hematoma. You have to be very cautious. And surgical emphysema could be another problem, but vocal cord damage I have already repeatedly I'm discussing, because there are certain case reports on this. So we have to be very cautious on doing for this. Thank you so much. I hope I'm within time. One thing I just wanted to tell you regarding the application of supraglottic airway device. Primarily, actually, I have not used it. I have not mentioned it during my slides, because I thought probably this is primarily for the trainees. So I tried to emphasize on the techniques, the complications, the devices, and the use of this in ICU is something which has been not very frequently being used. Let me tell you, the ICU need a definitive airway. Supraglottic airway device is primarily not for ICU. It is for buying time, because we need a definitive airway. We have to go for either for a time period we can use a supraglottic airway device where we are not being able to ventilate these patients. So then in those situations we put a supraglottic airway device. You go for percutaneous tracheostomy and go for a definitive airway if you are having an anticipated difficulty, if you are having an unanticipated difficult airway. The supraglottic airway device has been used in 5 situations in ASA guideline. So they are the situations where we have unanticipated difficult airway, or we have in situations where we think that the patient airway cannot be maintained, or in situations where we go for situations where the patient patient fails a complete ventilation. That's what I've already discussed. Now this supraglottic airway device, let me tell you, it is no more the laryngeal mask airway. They have no place in the recent guidelines for anticipated or unanticipated difficult airway. It's always the second generation supraglottic airway device which we put in, and whenever using a supraglottic airway device and trying to intubate in those situations, you always should be under vision with the help of bronchoscope. Thank you so much.
Thank you, sir, for enlightening us about the critical airway. Now we'll see the questions. Over to Dr. Shalini, ma'am.
Yeah.
Ma'am, please unmute.
Yes. Yes. Hello.
Yeah, yes, madam.
Yeah. Thank you, sir. Thank you for your wonderful lecture. You have in detail explained about the supraglottic airway device as well as the cricothyrotomy and retrograde intubation.
Yes, but I did not speak on retromolar because probably
retrograde intubation.
Yes, because Kadam has told me that probably he has dealt with the retromolar. So naturally. Sir. And one correction I need to make, madam. During the introduction, you said that I am the editor-in-chief of IJ. Actually, it's not editor-in-chief in IJ. It's IJ, of course, IJ, but IJ supplement. So that is what I just want. Okay, sir. Okay. Thank you so much. Okay.
Thank you. Thank you for your wonderful talk. There are few questions. Yeah, I would like to ask one question, sir.
Please.
Is there any specific role of LMA in morbidly obese patient? In view of selection of supraglottic airway device and also the size of the LMA, whether it depends on ideal body weight or lean body weight. What will you
see? Actually, first of all, your first question is which device to be used in morbidly obese patients, right? This is the first question you had. Now, let me tell you, second generation airway devices, like starting from PLMA, IGEL. Then we have nowadays the LMA protractor has come, LMA Bascom has come up. Now these are the second generation airway devices. All of them can be used, but most road tested means what I mean to say is a comparison between Maruti and other cars, which has been timely tested, very well tested, and that is what is ProSeal. Now that is something which is being very rightly tested because the additional advantage is it has a dorsal cuff. Now that helps you to most of the devices. Let me tell you. It goes as per your body weight, right? But there is no margin of safety. Now, supposing I'll give you an example. Say, my patient is weighing 50 kilo, right? And now according to 50 kilos, I know that I need to use a 3 size any supraglottic airway device supposedly. Now, supposedly there's a difference in the oral cavity because every human being is different. Now, I don't have an additional margin of safety to either increase or decrease my size, right? So you have to be within that limit. But what ProSeal has is, ProSeal has an additional advantage. What is that advantage? Advantage is that it has a dorsal cuff. Now that dorsal cuff is going to give you an additional advantage of making a good air seal pressure. So even if the patient has a less size than the expected size, but that posterior cuff is going to help you out to go for a good esophageal seal pressure. This is one advantage. Now, this similar advantage has to a certain extent IGEL. Why IGEL? Because IGEL can accommodate, adjust itself. At the same time, it can, inflate a bit. I mean, it can swell up a bit and then accommodate itself within that capacity. So these two devices are very well timely tested and they are being used. Nowadays, there are so many other devices which are come up. Of course, I'll tell you, Protector is there, Baska Mask is there, Blockbuster is there. They are all devices which are there, but they are not very well, there are not a lot of studies on that. So accordingly, I would always go for the most preferable and most utilizable is these two devices. There are a lot of studies which have been already conducted on them. So they are at least 95 to 97% they are safe.
Okay, sir. Okay.
The other point is that how do you assess the size? Now, as I said, lean body weight is obviously the primarily which we talk about whenever we consider any size, primarily, whatever we say. But then there again, I said there's always a variations. And variations can always happen in any human being, especially in morbidly obese. Because I'll tell you why. Morbidly obese patients, they have a additional problem. They have because of prolonged obesity, they have a chance of obstructive sleep apnea.
Yes.
Now, this obstructive sleep apnea causes, in the long run, there's an you can say, manifestation, or you can say increase in the pharyngeal wall tissues, right? And that pharyngeal wall tissues, they cause an increase in growth. There's because of the obstruction, it tries to grow and it tries to grow, and that is why you can see that always in obstructive sleep in obese patients that their chance of obstructive sleep apnea is very fast and rapid and to an extensive phenomena. So because the space in the oral cavity they reduce because of this prolonged obstruction, there's an increased growth in the pharyngeal tissues. So naturally, if you go with your body weight, then always a possibility that you will be going for an oversize. So that is why there is always you need to accommodate your size depending upon your lean body weight firstly, and secondly, it is better that you use a device one size lesser than the size which is anticipated.
Okay.
So it's better that because you don't know exactly what is there in the oral cavity.
Right. Yeah. Okay, sir. Yeah, thank you for that. One more question. In how many patients you have experienced life-threatening surgical emphysema during cricothyrotomy or retrograde intubation?
Very interesting, very important question, and I am really thankful to you because see, I am primarily an intensivist. I mean, I'm an anesthetist. Of course, my primary job is in anesthesia, but at the same time, I'm looking after my intensive care unit. So in the intensive care unit, what I faced the surgical emphysema at random. Let me tell you, because I'm dealing with my resident doctors, right? And it's a teaching institute. So I've got to train my residents. So what happens, the resident doctors, that's what I was primarily always hinting at one point, that you need to move your bougie or your guide wire very frequently and see that whether you're in the right place or not. Because that should be real, that should go very freely. Once you punctured your cricothyroid membrane, you should always negotiate your bougie very freely, and that it should pass very freely. Otherwise, there's always a possibility that you'll cause a false passage and cause surgical emphysema. And this is very common amongst the resident doctors. Two very important things is, one is when you're puncturing with the help of a needle, the cricothyroid membrane, don't withdraw the needle completely, please. If you withdraw the needle completely, then the steadiness of the catheter, the intravenous catheter, it is going to kink. It obviously will kink. So you don't withdraw the needle completely. Withdraw a bit and then railroad your catheter inside. Once the catheter goes inside, then you withdraw your needle. These are the two steps, which is you can say the catch-22 or catch point of your technique. And that is where you have to be very cautious. One is when you're pushing your needle inside and then aspirating and then negotiating your intracath. And the third point is when you're pushing a bougie inside, trying to railroad. Now, these are the situations where you'll always cause a surgical injury. And I have faced quite a number of patients when my residence doctor, though I am there standing in front of them, even then the things happen. So quite a number of patients are there, but obviously you've got to manage accordingly. Complications will always happen, but the best part is if you can manage it at the right point of time, then obviously the patient is safe.
Okay. And sir, last, how long we can ventilate with cricothyrotomy? I know it is depend on the size or what technique, wide bore.
That is why I always said that it is always preferable that you go for a surgical technique. One very important thing is that if you have a surgical technique, that cannula cricothyrotomy is best because you are putting in a size of 5 to 6 centimeter of size. So naturally you can ventilate for hours. That's the most important thing.
Yes.
But if you're putting the cannula, which is being preformed and pre-marketed, they are being marketed by certain companies who are having a cannula size of 4 to 6 millimeter size. Now, let me tell you, the 6 millimeter size is the preferable one, which is there available in the form of per cut or something like that. I'm not being able to remember exactly the name. But the advantage is it is as having a 6 millimeter size tube, which I showed you, that red flag one with the blue size, and that you can help go on ventilating the patient for time together. For time. But primarily these cricothyroidotomy are buying time. They are meant for buying time. You need to go for a definitive airway as early as possible. So they are primarily you're buying time, so the patient's life is safe. Now, when you talk about the size which is less than 4 millimeter or less than or a needle, you can maintain it for 10 to 15 minutes primarily, depending upon the expansion and the ventilation of the patient. But otherwise, let me tell you, they are primarily for buying time, and depending upon your size of the cannula, you can go for ventilating for hours. That's one thing.
Yes. Thank you, sir. Thank you for your solving my queries. I think in the chat box, there is no question from the audience. So at the end, I would like to summarize that I want to give message to all our budding anesthesiologists that, LMA has a very important role in airway management. But the thing is that you have to select proper size LMA for an appropriate patient to make it successful. That is the key of success. And regarding this, as sir said, even though this retrograde intubation is an old technique, now in 93 it has been mentioned in the armamentarium of our anesthesia protocol. Everyone should be well aware or well versed with the use of all types of LMA, as well as techniques like retrograde or retromolar intubation, but you need to practice it on mannequin first and then perform on the patient. Even whenever you are using any gadget, first you should be well versed, make a practice, and then only try in the patient. That's the only message I want to give here to all our audience. Thank you, sir. Thank you for a wonderful lecture. Thank you, organizing committee, for inviting me. Once again, congratulations, all of you. This is a wonderful feast or academic feast you have arranged for all our budding anesthesiologists. Thank you once again. Good day.
I would also like to thank the organizers, as I said before. That's really it's something which is most importantly. These are the situations where probably we can learn, but the only thing which we are missing is the hands-on technique. So that is something which I always say, because these are the devices, like for instance, retrograde, surgical airway, supraglottic airway devices, unless you do it, because whatever you're hearing, you'll forget it. And whatever you'll see it, you'll not remember. So, but whatever you do, you'll always try to, you'll understand and you'll always try to remember. So that is why we are really missing, because of this pandemic, we are missing the hands-on technique, which is one of the most important, method of learning whenever you talk about difficult airways, and especially in surgical airways and the supraglottic airways. And my suggestion to my resident doctors, if at all they are there, and my senior colleagues as well, that one should, as Madam rightly said, that practice what is important. And the other thing is, one should know the device. You should always, if any device comes in, you must always see the device and know about it, because they must be having some advantage or disadvantage which is there, and you must be knowing about whatever new generations or new devices are coming in the market. So that's why I always try to show you all the devices which are there, but not talking in detail, because we don't have time, because of time constraint. I wanted to keep it in time within 45 minutes. Thank you so much. Thank you once again to the organizers, especially Dr. Namazi.
Can I ask one small question to you, sir?
Yes, sure, please, sir.
I'm Dr. Namazi, sir.
I know, I can hear you.
Sir, thank you very much, sir, for coming over here, even though you have got some personal problem. Question is that, sir, critical airway is life-threatening scenario of hypoxemia, leading to hypoxia because of failure of ventilation or intubation, whereas the anesthetic clinician find difficulty in bag ventilation or insertion supraglottic devices or intubation or both. What is the difference between the critical airway and difficult airway? Because for difficult airway, there are so many guidelines and so many things are there, algorithm is there, but there is no anything in the for the critical. Today's our seminar is on critical airway.
Very nicely said. I'll tell you, you are you're trying to use more of the terms primarily, because when we say a difficult airway, the difficult airway can be both anticipated and unanticipated, right?
Yeah.
So if you are anticipating it, naturally you are preventing the critical component of it, because you've anticipated difficult airway and then you're managing accordingly, right? So from the very first time go, you have all the gadgets with you and you can manage accordingly. Supposing if you know that this is a difficult airway, I will go with a fiber optic bronchoscope. I would go for an awake intubation. I would go for a awake video laryngoscopy. So that is what you are avoiding, the critical phenomena of that anticipated difficult airway. So that's a difficult airway, let me tell you. But it's difficult, but it's anticipated. You're preventing your critical point. Second point is unanticipated difficult airway. Now, if the patient is unanticipated difficult airway, actually you don't know from the very beginning that whether you will land up to a critical situation. So you got my sequence of events. So unanticipated difficult airway, you start with a very simple method of going for a laryngoscopy and intubation. If you have a video laryngoscope, then probably people would always choose for a video laryngoscope and intubate. Now, once you faced that you are not being able to intubate this patient with the conventional laryngoscopy, you've given one chance, second chance, you don't have a video laryngoscope with you, naturally you would always call for help and you go for a supraglottic airway device. Now, once you go in for a supraglottic airway device, here also you failed. Then you go for a bag mask ventilation, rescue bag mask ventilation. Now, once you have failed rescue bag mask ventilation, now this is the critical situation. Means this is the critical illness of this patient. Means you are not being able to, this is a complete ventilation failure where you are not being able to ventilate this patient. Even whatever methods you are having, and you're being able to just pass oxygen, that's it. But you are reached a situation where you're not being able to ventilate this patient and not being able to intubate and maintain the airway. Now, this is a situation which is critical. Means critical is in relation to the patient's situation, right? That means the patient is not going to survive if you're not being able to put an oxygen cannula or oxygen catheter by any point within a period of time, say 3 to 5 minutes, when the patient's saturation has to be maintained. Now, this is again, according to AIDA guideline, what we have seen, what we have said is that we can go for an oxygenation of these patients, right? Patient might not be ventilated, but we can go for an oxygenation of this patient. So oxygenation can be there with all the additional devices which you have, but that also has a limited time. So that time again is depending upon the apneic ventilation. Till what time you can go for an apneic ventilation? You have to go first, ultimately find out with an supraglottic, with an definitive airway. Now, once you are landing to a situation where you are not being able to oxygenate this patient, ventilate this patient, now this is the critical situation. So this is critical airway. So naturally, here we are not being able to ventilate the patient and neither we are being able to maintain an oxygenation to this patient. So there we have to go for a device which is trying to bypass this by time before we go for a definitive airway. So this is what is primarily when you talk about the difficult airway, when we talk about critical airway. I hope I can answer your questions. I'm not sure whether you have been satisfied because it's a term which tells you that the patient is critical.
Thank you very much, sir. Thank you very much for coming over here. And
if you have any other, because these are terminologies which are not being critical airway. Terminology is, situations where we are really in a situation where we are not being able to come up with the airway, maintenance of airway. So that is what we do. Anything else? Any other questions?
Thank you, sir. Thank you, Dr. Shalini and Dr. Syed. Now we move on to our last session on difficult extubation. I welcome the chairperson for this session, Dr. Aarti Ghorpade. Dr. Aarti Ghorpade, MD Anesthesiology, Professor of Anesthesiology, Rajashri Chhatrapati Shahu Maharaj Government Medical College, Kolhapur. She has worked as the head of the Department of Anesthesiology for 8 years and she has total field experience for 25 years, including 11 years at Grand Medical College, JJ Hospital, Mumbai. Recently, she has worked as an additional dean, Kolhapur, in place of regular dean during COVID-19 pandemic. Her interests are in general anesthesia, difficult intubation, and apart from anesthesiology, she is Sangeet Visharat in Hindustani classical singing. I request you, ma'am, to welcome our next speaker, Dr. Kalpana Kulkarni, ma'am.
audible? Am I audible?
Yes, ma'am. Yes, ma'am. You're audible.
Yeah, thanks for this introduction. Yeah, I thank the organizing committee for inviting me here at Checkers. And now I am Dr. Kulkarni Madam for her speech on difficult extubation. Firstly, I appreciate Madam for selecting this topic of difficult extubation. The whole world speaks on difficult intubation, but extubation also can be equally difficult, and she selected this topic for our student, and I really appreciate her. And I over to Dr. Kulkarni. Thank you.
Thank you, Dr. Aarti, for your kind words of introduction. At the outset, I would like to congratulate all the today's speaker of this conference on critical airway management. They have extensively elaborated on the given topic. They stick to their time, and whatever they have talked, it has helped me to make it easy for my presentation. Special thanks to Dr. Syed Ahmed. In spite of family acute health problems, he has stick to his commitment and attended this conference, and he has been given a longer topic covering most of the things of step 4 management of the difficult airway. Thank you, sir. Dr. Amit Dikshit has already covered on ultrasound guided assessment. Dr. Rakesh Garg has made my job easy. He has already elaborated on all the guidelines of difficult airway management, extubation, ICU management, and in pediatric as well as obstetric patients. Other things like talk by Dr. Samantra on intubating LMA, then fiber optic bronchoscopy by Dr. Apesh Patwa, and this talk by Dr. Saeed Moeed has. We know that all these techniques and gadgets have definite application in difficult extubation scenario or reintubation process. So all of us have definitely learned the techniques, methods, and different gadgets which are available for management of such critical situations, that is cannot ventilate and cannot intubate. The Dr. Saeed Moeed has cleared the difference between critical airway and difficult airway. So we all have understood it. So I will begin my talk shortly. At the outset, I express greetings on behalf of Department of Anesthesiology, Dr. D.Y. Patil Medical College Hospital, Kolhapur. I am thankful to all the today's invited speakers of this conference who have extensively elaborated on difficult as well as critical airway situations and the management guidelines since morning. I would like to end the theme of this conference with a talk on difficult extubation, mainly in the perioperative settings. So although most of the patients are extubated successfully on table in difficult situation also, but we often face dilemma about on-table extubation and again awake versus deep plain extubation in such patients. As tracheal extubation is a logical consequence of tracheal intubation for the continued control of airway, a pre-planned strategy is important. So by now we are aware about the difficult airway definition, but difficult extubation is a difficult decannulation of the airway, which depends on many factors related to patient, surgery, or anesthesia. The incidence in perioperative setting is 0.4% and in ICU it is 25%. Extubation failure is an inability to maintain a patent airway with effective spontaneous ventilation after purposeful removal of endotracheal tube within a specified time. This generally needs reintubation. The ASA close claim analysis and National Audit Project 4 observed a mortality rate of 5% in patients of extubation failure, and weaning failure is an inability to tolerate spontaneous breathing without ventilatory support. This also requires reintubation and ventilatory support. ICU patients requiring reintubation for weaning failure have a higher mortality rate than because of extubation failure in operation theatre and post-anesthesia care units. An extubation strategy should have a low intubation rate without patient discomfort The respiratory complications after tracheal extubation are 3 times more common than tracheal intubation. So what are the causes of extubation failure? The most important one are the airway obstruction because of pharyngeal and laryngeal causes, spasm, multiple intubation attempts resulting in upper airway edema, hematoma compressing the airway externally, or clots or secretions internally, tracheal collapse or tracheomalacia may be because of mediastinal masses or external thyroid swelling. Upper airway soft tissue collapse can occur due to the prolonged effects of anesthetics, opioids, and muscle relaxant. Severe associated cardiopulmonary diseases and rheumatoid arthritis, obesity, obstructive sleep apnea, and obstetric patients. Specific surgeries like thyroid surgeries, tracheal surgeries, carotid artery surgery, posterior fossa anterior cervical spine surgery may result in pharyngeal edema and vocal cord paralysis. As prediction of extubation success is unreliable, any extubation should be viewed as a potential reintubation. What are the risk factors for laryngeal edema, which is the most common cause of extubation failure, especially in pediatric patients? The other risk factors are prolonged intubation, Glasgow Coma scale less than 8, geriatric patient, traumatic intubation, aspiration, larger size of endotracheal tube, excessive tube mobility, metabolic instability, presence of nasogastric or orogastric tube, and in asthmatics. So, and the extubation is also associated with complications as like during intubation, airway trauma, coughing, breath holding, laryngospasm, edema, aspiration resulting in desaturation and hypoxemia. There can occur paradoxical vocal cord motion. The incidence is 2.3%, and negative pressure pulmonary edema, which can occur in 0.1% of the patient having very high mortality. The other stress responses, as we know, that tachycardia, arrhythmias, hypertension, which is significant in pre-existing ischemic heart diseases, hypertensive patients, and patients with preeclampsia. Risk of regurgitation and aspiration remains, and there is a rise in intracranial tension, intraocular tension, as well as intrathoracic pressure. So this is the routine extubation criteria which we often follow during the post-operative period. That is level of consciousness, level of recovery of protective reflexes, recovery from neurovascular blocking agent, blood gas studies, and vital monitoring, that is hemodynamic stability, and return of respiratory mechanics is adequate or not. Besides optimization of physiological criteria, we need to look for some anterior column pathology, posterior column abnormalities, or middle column abnormalities. When we suspect the development of mucosal edema or potential loss of pharyngeal tone due to sedation after extubation, we need to delay the extubation, maintain artificial airway until the problem is solved. If there is no such risk, one can go ahead with immediate extubation, considering supraglottic airway or ACE, that is airway exchange catheter, as a part of extubation strategy. Careful monitoring in high dependency unit or ICU is mandatory. These are the guidelines for extubation in emergency department. Depending upon the risk stratification, it is a 5-step approach. And in ICU, there are subjective and objective criteria which are to be followed. And in ICU, inadequate cough and excessive airway secretions can lead to loss of airway patency and extubation failure. Cough strength is more reliable predictor of extubation outcome than the secretions. Amount of secretions, if more than 2.5 ml per hour, then there is relative risk of 3 of going into failed extubation. So coming to the main part of this presentation, that is guidelines for difficult extubation. This importance of difficult extubation has been suggested by ASA Task Force in 2003 and 13. Later on, Difficult Airway Society published these guidelines in 2012. But most popular one are the Indian Society Guidelines of Management of Anticipated Difficult Extubation, which are published in 2016. We are happy to get most of these experts as eminent speakers for this conference to whom you are listening today. This is a 4-step approach for the basic algorithm of extubation guidelines released by DAS. There is a, depending upon the low risk or at risk, there are separate protocol for the in the guidelines. And they also stress about the evaluation of general clinical factors and take measures to avoid adverse impact on ventilation after tracheal extubation. like use of steroids to prevent or treat laryngeal edema in the perioperative or ICU settings, reversal of neuromuscular blocking agent with a TOF ratio of more than 0.9 is good. Extubation in left lateral head down position minimizes the risk of aspiration. Head up and head upright position is preferred in obese and obstructive sleep apnea patients. 100% pre-oxygenation before extubation. Recruitment maneuvers, if not contraindicated, should be done before extubation. Use of pharmacological agents like intravenous lignocaine, ismolol, remifentanil, magnesium, dexmedetomidine infusion, or in the form of spray and distillation through the endotracheal tube reduces coughing and stress responses. Even filling the PVC endotracheal tube cuff with lignocaine and soda bicarb have been said to have good diffusion with endless irritation. However, risk of aspiration should be weighed against the benefits. Pros and cons of opioids by blunting the airway reflexes and depressing the respiratory drive should be evaluated, especially in obese and OSA patients. Treatment of post-extubation airway edema can be considered with racemic epinephrine nebulization. Some suggest use of helium-oxygen mixtures to minimize the inspiratory effort in acute upper airway obstruction, but benefit should be weighed against the drop in FI output. So some points from this IDA guidelines to stress: avoid extubation failure by prevention of reflex stress responses, pre-planning for airway difficulty due to pre-existing diseases, and delayed recovery after the surgery. Certain conditions such as goiter, obesity, OSA have increased chances of airway collapse. Extubation under deep anesthesia using SAD as a bridge or Baylis maneuver or SAD over the airway exchange catheter after removal of endotracheal tube is good, and oxygen throughout extubation period or short-term use of devices that can serve as a guide for expedited reintubation like ACE, Guji, or fiber optic bronchoscope should be considered. So this is a typical three-limb structured guideline of for the anticipated difficult extubation released by IDA in 2016. They have stressed the role of awake extubation as well as deep extubation depending upon the situation and patient's performance. The 4Ds denotes difficult mask ventilation, difficult intubation, delayed recovery, and difficulty because of pre-existing diseases, whereas there can be surgical causes of airway compromise, suspected airway edema, and collapse. Difficult airway cart must be ready during the process of extubation, and some points like recruitment of lung oxygen supplementation already I have mentioned. These guidelines are available on the net and most of us are following them. Few words about awake versus asleep extubation. The advantages of awake extubation are complete recovery of the airway protective reflexes and effective breathing is present that increases safety for possible difficult intubation. The disadvantage is airway reflexes are active, so lead to increased risk of rebleeding because of coughing, increasing venous pressure, and straining. Patient is awake but not calm and cooperative, then extubation procedures are also difficult. Whereas asleep extubation, it is advantageous because patient still paralyzed state, avoids coughing, fighting with the ventilator, so less risk of rebleeding. The disadvantage is lack of protective airway reflexes lead to increased risk of aspiration and airway obstruction. There is also a risk of laryngospasm if extubation is performed during transition between deeply anesthetized and awake state. So one need to look for the recovery of residual neuromuscular blockade, whether the mask ventilation and intubation was easy or not, or there is increased risk of regurgitation and patient should be normothermic. If it is not, then one should not proceed with deep plain extubation. This is regarding the use of different positioning pillows, which can be of help for oxygenation and intubation process during post-extubation failure. Of course, airway reassessment and maybe with the help of ultrasound is helpful. And airway reassessment can also be done either by direct laryngoscopy, video laryngoscopy, or endoscopy. Additionally, as a part of preparation for a possible surgical airway, identification of the cricothyroid membrane either via palpation with ultrasound and also while calling for help, a surgeon who is more skilled in cricothyroidotomy than the attending anesthesiologist should be preferred. Further, difficult airway cart must be ready and other things like suction monitors and CO2 detectors are of great help during extubation process. There are two important tests like cough leak test and cough test, which are useful for deciding the strategy for extubation. Cough leak test is used to test laryngeal patency, that is ability to breathe around the tube, measured by disconnection of the endotracheal tube and cough deflation in a spontaneously breathing patient or on SIMV mode. The cutoff value is up to 25% of the tidal volume, that is before and after the cough deflation. The amount is usually 100 to 150 ml in adults. Ultrasound may become an established method of determining the width of laryngeal air column during the cough deflation. Cough test, which represents peak expiratory flow rate, if it is less than 60 liters per minute, then there is high chance of extubation failure and 5 times chance of reintubation. Another technique is use of index card, which can be held at 2 cm from the end of endotracheal tube, and if patient is unable to moisten it after 3 to 4 coughs, then there is high chance of failed extubation. Combining a cough leak test with a cough test is an easy way to assess airway patency, level of consciousness, and with the cough deflated and endotracheal tube occluded, patient can be instructed to cough. In the critical care settings, absence of both an audible leak and cough is indicative of 10-fold increase in the development of stridor. This is the important adjuvant during exchange of the endotracheal tube or reintubation. Airway exchange catheter. It is available in different sizes from 8 to 19 range of length 45 centimeters and 83 centimeters long, with respective internal diameter of 1.6 to 3.4 millimeter, with an adapter for both jet ventilation and positive pressure ventilation. The length of ACE should be inserted, which should be equal to endotracheal tube in situ position, and it is normally 20 to 22 centimeters orally and 26 centimeters nasally. ACE are well tolerated and can be fixed and maintained up to 72 hours. Extubation with the combination of ACE of size 3.5 to 4 millimeter within LMA is possible, and fiber optic assessment can be performed. Entry is an adoption of Fuchs airway exchange catheter. It is 56 centimeter long, larger, with internal diameter of 4.7 millimeter, and it can incorporate pediatric fiber optic bronchoscope of size 4.2 millimeter. The external diameter of entry is 6.5 millimeter, so it can accommodate 7 millimeter endotracheal tube. It is stiff enough for railroading and have 2 rapid filter adapters. Uses replacement of endotracheal tube and tracheostomy tube. Fiber optic guided exchange of SAD with endotracheal tube can also be performed. Another method, that is endotracheal ventilation catheter, which can be used. It provides long intraoperative jet ventilation, maintenance of tracheal access following extubation, and allows for reintubation. The distal end of ETVC is designed to handle high pressure of jet ventilation while preventing trauma to the patient, and it passes through the 6 millimeter internal diameter endotracheal tube. So these adjuvants are not without complications. However, the incidence of failed reintubation, hypoxemia, bradycardia, hypotension, multiple attempts at esophageal intubation are more without using ACE or gum elastic bougie than with the use of ACE. Intolerance to ACE due to coronal irritation, coughing, bucking, it can lead to bronchospasm, discomfort in the form of sore throat and hoarseness is there, but we can manage with intravenous local anesthetic agents, sprays, and small doses of narcotics which are beneficial. There can be airway or barotrauma, bronchial damage, misguided catheters due to tube laceration or occlusion, and failed reintubation due to laryngeal edema and dislodgement of the endotracheal tube. Complications occur more in patients with difficult airway, so provision should be made for surgical airway in any difficult to reintubate patient. These are other adjuvants which can be of use for fiber optic assisted reintubation. Use of gum elastic bougie. If an ACE is not available, one can insert a gum elastic bougie and remove the endotracheal tube over it during awake extubation. Since it cannot be utilized for oxygenation, ventilating bougies are also available, as you can see in this video. So another advanced version of supraglottic airway device, that is LMAC track, which will further help and make it easy for reintubation. And second generation intubating LMAs are available. There are Sheridan endobronchial tracheal tube exchangers, suction catheters, which can be used during the process of extubation and reintubation. And lastly, the cricothyrotomy, because surgical airway, the measures has to be kept ready. The indications are airway obstruction and complete ventilatory failure at the end of intubation or reintubation process, fasciomaxillary upper airway trauma, failed intubation or reintubation, and severe trismus, and in pediatric patient less than 8 years of age. These are certain accessories for laryngeal laryngotracheal instillator for local anesthetic and laryngeal tube, which can be used for the insertion through the tracheostomy stoma. So a few words about unanticipated difficult intubation or reintubation in children. The highlights of these guidelines are, as the anterior position of the larynx is there in pediatric patient, use of external laryngeal manipulation, which can be of help during reintubation process. It can be done with the same hand which is performing the laryngoscopy. Avoiding soft tissue collapse of upper airway and nails with mask. Use of two-hand technique or 2% technique for proper mask ventilation. Lateral position avoids airway obstruction due to adenoids and tonsils. And use of propofol to relieve early laryngospasm. One can use air track, video laryngoscope, or TrueView if they are available. And maximum 2 attempts at intubation with call for help at second attempt, and use of SAD is acceptable. In patients having coma clinic grade less than 3, more than 3, use aids such as gum elastic bougies or Prova introducer and entry can be considered for intubation reintubation process. In case of complete ventilation failure, surgical tracheostomy in under the age of 8 years and needle cricothyrotomy in between 5 to 8 years or more than 8 years with 16 gauge IV cannula can be performed. This is one study done by Tyagarajan et al. To study the predictors of successful extubation in children. The goal was to evaluate the usefulness of rapid shallow breathing index and compliance resistance oxygenation and pressure index in critically ill children on mechanical ventilation. And they observed that extubation failures had higher rapid shallow breathing index and lower CROP index values. If the rapid shallow breathing index value less than 8 breaths per ml per kg, it has got high sensitivity of 74% and CROP value of more than 15 ml per kg per breath per minute had a sensitivity of 83% for extubation success. Now some few words about this COVID situation regarding extubation of these patients. Tracheal extubation should be done in the OT as far as possible, and patients should be transferred to the dedicated ward. If tracheal extubation is not feasible, then shift to the dedicated ICU. During transfer, patient must wear surgical and N95 mask. If they are intubated, if the patient is intubated, a single patient use ambu bag with HME filter is attached. Do not use ventilator during transfer. Rest of the things are already covered. So this is again, in this modern era, new method of airway assessment are available in higher centers like multiplane CT scanning and virtual endoscopy that can be of help specifically in high-risk group of patients and especially in this COVID situation for better planning of intubation, extubation strategy. According to National Audit Project 4, 40% of the cases of upper airway and complex head and neck pathology, 70% of them were associated with airway obstruction. So this method of virtual endoscopy is a tool that can detail intraluminal anatomical fly-through information in a format visually similar to the flexible endoscopy views, which is familiar to the anesthesiologist. And hence, virtual endoscopy represents a unique, non-invasive, safe and accurate airway assessment method. But non-availability is still the problem. So to conclude, extubation failure may lead to severe outcomes in the presence of difficult airway. Patients at risk can be identified and optimized by history, examination, and pre-extubation reassessment to predict the airway patency and competence. Post-extubation complications may be prevented by careful timing and preparation for emergent re-intubation, which includes routine use of ACEs in the cases of extubation of difficult airway. Adequate level of post-extubation monitoring and care is must for patient safety and better outcome. These are the references, and I once again thank all the speakers for sparing their time and sharing their knowledge, as well as all the delegates for joining in large number. Last but not the least, all my departmental colleagues and residents for their hardship for making this Zoom conference successful. So take care, be safe and healthy. All the best for coming year ahead. Thank you.
Thank you, Dr. Kulkarni ma'am, for this informative session on difficult extubation. Now we move over to Dr. Aarti Ghorpade for the questions. Dr. Aarti ma'am, we can't hear you. Hello? We can't hear you, ma'am. Hello?
Am I audible? Hello?
Hello?
Is it audible now?
Hello, ma'am.
Hi, yeah, is it audible
ma'am, you
now?
are not audible.
Am I audible? Yeah, 1 second. Not audible. Am I audible now? Sound. Am I audible? Hello? Is it audible? Audible now? घेतलं मग घेतलं ना घेतलं.
Give me 2 minutes.
Yeah, just give me 2 minutes. Just 2 minutes.
Hello, ma'am.
Yeah, I'm just trying. Just 2 minutes. Just 2 minutes.
Okay, ma'am. Ma'am, we can hear you now.
Yeah. Okay. Yeah. Am I audible now?
Yes, ma'am.
Thank you, Kulkarni ma'am. She has elaborated each and every corner of this topic and made this complex topic very simple to understand for students. And it's a very important topic. As I repeat, we all are very used to listening to lectures on difficult intubation, difficult airway, but difficult extubation is equally important, but I feel neglected topic. But I appreciate madam's efforts and to make this topic very simple, which is actually a very complex topic. And to students, I would like to as I always give advice to my students, that to be in readiness, to be in preparedness to re-intubate a patient at the time of extubation, be it a simple patient, moderate patient, any ASA grade 1 to 4, or maybe the intubation may be simple, moderate or difficult, but be in readiness to keep things ready so as to be able to re-intubate and be prepared for war at the time of extubation, so that there's peace everywhere. I thank madam for this topic. Any questions from audience?
Thank you, madam, for your comments. Thank you once again to all of you. I take this opportunity to thank all the speakers, delegates for attending. And most important thing, I want to thank our organizing secretary, Dr. Sandeep Kadam, all the faculty members as the organizing committee members for this conference, and all the residents for joining for the hardship for this conference and making the conference a successful event. I would like to special thanks to our resident, Dr. Vishnu. He is a technology friendly. Everybody was after him to manage this scenario because it's difficult, the technical aspects, we cannot manage everything. So he was assisting every one of us, and this was first kind of virtual conference we have conducted. Thank you for cooperation. In between some there were problems and you all tolerated that. Thank you. We will meet again in the next year. Thank you.
There was a bit of problem in connectivity, so there was a delay. But now it's okay. And I thank the organizing committee, Kalpana Kekar madam, and all the residents for inviting me here as a chairperson for this session. Thank you.
On behalf of the Department of Anesthesiology, I would like to thank all the chairpersons, faculty members, and delegates for patiently listening to this CME throughout the day. I hope at the end of this seminar, you will go home richer and your patients will benefit from these topics that have been discussed here. And I hope PG students as well as consultants will find it useful. One announcement which I would like to make is that the e-certificates which are MMC accredited for the delegates who have logged in will be received after 8 to 10 days. We will be sending you an email, and after which if you register, and you will get the feedback form and the certificate. So thank you one and all. Hope to see you next time. Thank you.